Good afternoon, Shanai sir.
Good afternoon. Good afternoon, everyone.
Shanai sir, welcome.
Good afternoon, sir.
Venkatesh here, sir. Shanai sir.
Good afternoon. Yeah.
Good afternoon, Dr. Lakshman, Dr. Nishant.
Good afternoon, sir.
Naz is there. So
Good afternoon, sir.
Arvind Patel, Gaddi,
Yes, sir. Good afternoon, sir.
and chairman, sir, everyone.
Welcome.
And opening batsman, Ramakrishna.
Yeah, good afternoon, sir.
Good afternoon.
Thank you.
Next call up Dr. Abhay Dalvi. And ಇನ್ನೊಬ್ರು ಯಾರಿದ್ದಾರೆ ನೆಕ್ಸ್ಟ್ ಇವರು ಸರ್ ಇದ್ದಾರೆ ವೆಂಕಟಾಚಲ. Sir, Abhay Dalvi, sir.
We are starting now 3:45, but you can log in by at least 3:45.
ಮ್ಯೂಟ್ ಮಾಡೋದು ಯಾರು?
All these new joiners, Divakar,
ಸರ್
ಆನಂದ್ ಹೇಳ್ಬಿಡಿ, ಈ ಹೊಸದಾಗಿ ಯಾರು ಜಾಯಿನ್ ಆಗ್ತಾರೋ ಅವ್ರದೆಲ್ಲ ಮೈಕ್ ಆನ್ ಇರುತ್ತೆ, ಆಫ್ ಮಾಡ್ಬಿಡಕ್ಕಿದೆ ಅಷ್ಟೇ.
ಇಲ್ಲ ಮಾಡ್ತಾರೆ, ಇಲ್ಲ ಮೈಕ್ಗಳು ಆಫ್ ಮಾಡ್ಬಿಡಿಪ್ಪ. ಇದಾ
ಇಲ್ಲಿ ಮ್ಯೂಟ್
ಎಲ್ಲಿ?
How is the voice?
ಮ್ಯೂಟ್
ಕ್ಲೋಸ್ ಮಾಡಿ. ನಾವು ಕೆಳಗಿನ ಮನೆ
ನೆಕ್ಸ್ಟ್ ಸ್ಪೀಕರಿಗೆ ಕಾಲ್ ಮಾಡಿಬಿಡಿ. ಸ್ಪೀಕರಿಗೆ ಕಾಲ್ ಮಾಡೋದು ಮಾಡಿ ಸರ್. Dr. Bhargavi, keep your mic muted, please.
ನಾನು ಮಾಡಿದೆ.
Yes, sir.
I did heard. I think you can start. It's 3 o'clock.
Yes, sir.
2:59.
Good afternoon, everybody. A warm welcome to you all to this 39th edition of Kscasicon. This is the first time it's being held virtually due to COVID-19 situation. I welcome Chairperson Dr. Sadashivaya Sopimat, all the national EC members, our treasurer Dr. Jaspal Singh, faculty, chairpersons, and the invitees. With the permission of the chairperson, we'll begin this 39th edition of virtually held Kscasicon. I hand over the proceedings to Dr. Venkatesh KL to be conducted. Dr. Venkatesh, please.
Yes, sir. I'm Dr. Venkatesh, Associate Professor, Pediatric Surgery, Bangalore Medical College. I welcome all of you to this 39 Kscasicon. So we have screen 1 today. We have 11 eminent speakers, right from ASI President. We have oncosurgeons. We have laparoscopic surgeons. Right from basics, we are starting from sepsis, antibiotics, vascular surgery, and help the students going in a long way. Right from we are starting with the biomedical research and the statistics by my senior at Ballari Medical College, Ramakrishna sir. So we have very good eminent speakers today. So I call upon today's chairperson for the first session, 3 to 4 o'clock. We have Dr. Satya Krishna. He's a consultant surgeon at St. Martha's Hospital, Bangalore. I welcome you, sir. Satyakrishna, sir.
Thank you, Dr. Venkatesh.
Ramakrishna, sir, you can start with your presentation. Why should surgeons learn the basics of statistics? So the need of today's, whether it's medical colleges, the biomedical research and all this journal studies, statistics are very important. We are going to start with a very important topic. Please, sir. Ramakrishna, sir.
You have to unmute Ramakrishna, please.
I think, Anand, can you unmute?
Sir, now
Yes,
can you hear me, sir?
you're heard now. Please go ahead.
Yeah, the screen slides, I think Dr. Venkatesh will be doing, no?
I think Ramakrishna, sir, will be
Shall
sharing
I
his own.
share my screen?
Yeah, please, Ramakrishna.
Yeah.
I'll stop sharing.
Oh,
Ramakrishna, sir, you please start. You share your screen, Ramakrishna, sir.
Yeah.
You have your 20
Host has
minutes.
disabled. No, host has disabled. No.
I've made you host, sir. Co-host.
Ramakrishna is not a co-host. Please make him a co-host.
Yes, just a second. I had made him.
You can
Yes.
share your screen, Ramakrishna. I allowed that. Yeah.
Yes, sir.
Yeah. Now can you see my screen, sir?
Yeah, Ramakrishna,
Yes, it's coming.
he's
Taking time.
Satya, sir, you can meanwhile a brief introduction. 1 minute about Ramakrishna, sir.
Yeah, Dr. Ramakrishna is a very eminent surgeon, excellent speaker, and this topic suits him very well. In fact, I've seen him present one of these things earlier in the conference in Bangalore. It's a pleasure to listen to him on this basic topic, not usually spoken that common in conferences. It will be nice for us to learn about statistics. It will help the postgraduates in particular, help them in publishing articles and in academics. I request Dr. Ramakrishna to deliver his lecture.
Good afternoon, everyone. I thank KSCSI for giving me the opportunity to deliver this guest lecture. Generally, statistics has been considered as a boring subject, difficult to learn, complex, and we surgeons do not try to learn it. But it is required as a part and parcel of medical profession. I would like to tell you why we need to know statistics. This is the brief definition of statistics. Why we need statistics? To put it in a most simple way, to make sense of data. I will give you an oversimplified example for this. I have collected pulse rates of 100 healthy, normal individuals and put it in a table like this. What sense does it make to you? Obviously nothing. Whereas if I put the same data like this, it makes some sense. If I put it like this statistical parameters, mean, median, standard deviation, etc., you will immediately grasp and know how the data is distributed, what you can expect from the next patient's pulse rate, etc. And the graph makes you to understand it quickly also. So in general, the statistics is required to design our studies. It tells you what type of data you have to collect. After collecting, how to analyze the data, how to interpret, to draw conclusions, and you will know whether your conclusions are based on solid data. If you don't know what happens, you'll end up like this man. All this man needs to see over this wall is a single ladder, and he has plenty of them. We Indian surgeons do a lot of surgeries. We have a lot of clinical material, but still we struggle to publish a good research paper out of all data. This is the problem we face. Statistics is required everywhere, be it healthcare utilization or resource allocation or quality improvement or producing a new product, is pricing, everywhere it is required, but I myself restrict to its use for surgeon. Actually, it is required to interpret the data and numbers, tables we come across while reading the journals. To interpret them correctly, to understand them, we need medical statistics. If you are a medical college faculty, you need to learn this because you have to teach your students about these concepts. And if you are a peer reviewer, you keep on getting many articles based on data, whether whatever conclusions drawn were correct or not. These things you have to assess and give recommendation to publish or not. These things also require knowledge of statistics. If you are a PG student, you have to write your synopsis for dissertation, design a study for your dissertation, then write a scientific paper or present it in the conference. Everywhere you need statistics. Basically, you should know what is a normal distribution curve, what is the confidence interval, what is the meaning of p-value, sensitivity, etc., etc. These are very basic statistical terminologies, and we should know at least this much to understand and correctly interpret whatever numbers you get while reading across the journal articles. And if you have got enough knowledge, you can perform your own statistical analysis when you have done some studies. There is nothing wrong to take the help of statisticians. I'm not against it, but what happens if you entirely depend on them? It becomes difficult. See, if you approach them with certain basic knowledge of statistics, you will get a better output, better end result. If not, whatever they give, you have to accept it. Moreover, if you are in private, you may not get statistician easily. You may have to pay them. Still, you may not get a timely response. Sometimes they will send back your data asking for more clarification, more data, change the table. Such back and forth communications to arrive at the final analysis, it may sometimes take months together. All these things somehow you can manage, but what I'm bothered is really this last thing. Sometimes we get a wrong analysis and we don't even know it is wrong. That is the most problematic part. I can give you plenty of examples to drive home this message. A few examples I have taken, which are typical. This is one of the papers I was watching in Kscasicon. The student has conducted a control study to see whether one particular gel, let me call gel X, whether it is helpful in healing the ulcer faster. He has conducted a case control study and got this data. He did not know what to do with this. He gave it to statistician. See, each patient has got one pair of data, like initial ulcer area, final ulcer area. So the statistician has used a paired t-test. He calculated p-value, this is correctly, which was less than 0.05, and concluded that gel X is helpful in faster healing of the ulcers. Could you make out where he went wrong? Probably the student, his mentor, the statistician, nobody understood. They had totally ignored this control group. What they should have done, he should have calculated decrease in size of the ulcer for each patient. Now we have got two sets of data, one for the control and one for the study group. Compare these two using t-test, independent t-test, not paired t-test. If you do that, you get p-value 0.25. That means the gel is not useful in faster healing of the ulcer. There is no difference between these two groups. Sometimes we read journal articles and just we read and take whatever written there as the ultimate truth. Sometimes there will be flaws in the article. We will not be able to understand if you don't know the statistics. This is one such example. This was published in Indian Journal of Surgery in 2019. When I read, I found several flaws there, and all those things I read it on in a systematic manner, like we do a critical appraisal of the paper. And the item number 7, this entirely deals with the flaws in the statistics. All these things I wrote and sent to editor as a paper. This was published in subsequent issue of Indian Journal of Surgery. And here you need the statistics knowledge. Actually, critical appraisal is done better in journal clubs, where a group of surgeons along with postgraduate students, they discuss a particular article published in a good journal. I am thankful to Dr. Lakshman for putting me into faculty of Sagar Astor group, where such meetings are held every month regularly. This is one such article. Usually we select a randomized control trial published in a good journal. This was published in 2019 in British Journal of Surgery. The moment we see a good journal, we think everything, whatever written there is ultimate, it is correct, and we don't even try to question it. When we discussed, we found several flaws in this article. It included flaws in the research methodology also, and more importantly, statistical part also. Just for example, take this. The study found a significant lower hernia recurrence rate after closure of the defect, that is IPOM plus, compared to IPOM. Here they have calculated p-value for this table 0.04. So they said difference is significant. We did the same chi-square test using the same data, and we found the actual p-value is 0.55. Now the conclusion is that there is no difference between these two groups, no difference in the recurrence rate. We noted all these flaws, wrote a letter to editor of the British Journal of Surgery. They accepted our letter, and our letter was published in a subsequent issue of BJS. That's the importance of critical analysis or journal club. I am a peer reviewer for Indian Journal of Surgery and many other surgical journals. I keep on getting articles for review. There I find several wrong concepts of, means the author has not understood the statistics. They are entirely dependent upon statistician. Whatever they give like that. See, in this table, numbers are very small, 0, 1, like this. If your table has got numbers like this, you cannot apply chi-square test. Instead, you should use Fisher's exact test. In this article, the author is trying to see the accuracy of clinical diagnosis and radiological diagnosis, and he is using chi-square test. Again, a wrong concept. If you want to see the accuracy, what you should calculate is the sensitivity and specificity, not chi-square test. In this article, the author has divided the patients of diabetic foot ulcers into 3 groups. Group 1, 2, 3, depending on the HbA1c levels. There were several flaws. One I am pointing out here. This peripheral vascular disease. With respect to peripheral vascular disease, he has given this data, and the p-value he has given 0.714. All these are correct. Data is correct. Calculation of p-value is correct, but interpretation is wrong. See what interpretation he has written in the article. The presence of PVD did not affect the rate of wound healing. This is wrong. Actually, what is the interpretation is the number of patients with PVD in these 3 different groups. It did not differ significantly. That's what he should have mentioned. But he has mentioned PVD did not affect the wound healing. This is even theoretically, it is difficult to digest this sentence. Here, chi-square test is used to see the association between the 2 categorical variables. Actually, if you want to test the association, you should use correlation, not chi-square test. Here, he is trying to calculate the mean p-value. Mean p-value is not a raw data, so you cannot calculate mean of different p-values. It is a wrong concept again. All these things have gone through the author, his mentor, and statisticians. Still, they have peeped into the journal. So these are the problems if you entirely depend on the statistician. You should have knowledge. This is important for postgraduate students. They write a synopsis and submit to RGOHS. Sometimes it gets rejected because of the statistical problems. See, this synopsis was rejected, stating wrong calculation of the sample size, wrong methodology they have used, and this was returned to the PG, rejected after 6 months. Now imagine what is the tension PG must have undergone. So they have to write the correction, and if they want to go for another new topic, it becomes so difficult. So what is the knowledge or attitude of the doctors on statistics? This was a survey conducted in 1987. They have sent form to 250 doctors. 9 questions were there based on the very elementary statistical terms. The average score was 2.4. That is the level of knowledge doctors had. Even after decades, I don't think it has changed much. This is the survey I conducted recently, and this is the Google form I used. I sent the form to nearly 400 surgeons. Only 53 responded. This is the form I had used. The responders consisted of college faculty from assistant professor to professor, including, and then consultant surgeons, and also postgraduate students. Half of them did not bother to read the articles regularly, and when those who read the article, only about 6% of them, they understood the statistical concepts well. Most of them understood only a part of it, and majority of the statistical part they did not understand. They all felt that undergraduate and postgraduate level, you should teach the medical statistics. This is nearly 90% felt that it should be taught, And the level of knowledge of the teachers to teach their students, only 1/3 were satisfied about their knowledge. Remaining 2/3, they were not sure of the knowledge of the teachers to teach them. What they do when they come across some statistical problem, majority, about 60%, they approach statisticians, and the next popular thing they did was to approach Google. All these were our KSESI member. Only 1/3 were aware that the information on medical statistics and research methodology, it is available on our website, kscasi.com, and 2/3 they were not aware. But about half of them, they were aware that for easy calculation, various software applications are available online, both free and some of them paid. About half of the responders, they had direct access to statistician. Probably these are from the medical colleges, and they said 2/3 of them, they said the statisticians are approachable, but when it comes to their satisfaction level regarding the final output, only 1/3 were satisfied about the final outcome. Remaining 2/3, they were not satisfied. They had various problems, starting from arrogance of the statistician, no timely response, then communication gap, etc. And they also gave us some suggestions. The statistics should be taught both at undergraduate and postgraduate level. They should be made a compulsory examination subject in the curriculum. That's what they felt. So I asked what they feel about this survey. About 64% they felt that this is a valid survey, it addresses a valid current problem, and 2 of them, they said it is total waste of time, there is no use of conducting such survey. This is the interest of our members. About 2/3 of them were interested to take a quiz on statistics. So having known the problem, what can we do about it? All we need is a right mindset. Once we understand that the knowledge of statistics is required for us, then there are plenty of ways how we can learn. This is our website, kscasi.com. One tab is there about research methodology workshop. If you click on that, the various information you have. See, before Corona, we used to conduct a research methodology workshop in various medical colleges. We conducted about 7 such workshops, then Corona intervened. We continue to do this virtually on a Zoom platform. We had 2 sessions. This is the video of session 1. The second half of the first session was entirely dedicated to medical statistics. You can visit there, even now it is available. You can go through that. The other part of research methodology were here in the session 2. And one more tab is here, research methodology workshop. If you click here, it shows links to various PPTs, PowerPoint presentation, and also voiceover video presentations of various topics. You can download any of them, use it either as it is or with your own modification. Conduct similar workshop in your own institute to spread this knowledge. And we have not exercised any copyright there. KSESI has published one book, Evidence-Based Surgery and Research Methodology. Here, one full topic is dedicated to medical statistics. I have also designed my own website. Here, I have dedicated one page for medical statistics. Click here. These are the calculators I have designed using MS Excel. You can use them to calculate quickly the standard deviation, mean, median, all these things, even do t-test, all these things. And the book, what I mentioned, it is also available here for free download. And I have given links to various useful calculators. These are the online calculators. You can do various tests of significance, how to calculate the sample size, that also you can do. You can randomize the patients into different groups using computer generated randomization. All these things you can do. These informations are available for you to use. This is the book I have written, Medical Statistics for Beginner, which was published by Springer in 2017. It's available on Amazon if you want to buy. Another thing I want to tell you is researchgate.net. Here, there is an option to ask questions. You click here, the box opens, you put your question, what problem you have. There are a group of good, knowledgeable persons. They always give suggestions or solve your problems. And with that also, you can get solution to your problem. Now in 21st century, we need to work hard, not only work hard, but also we have to work smart. The statistics part, if you add to your knowledge, you become smarter. To conclude, ladies and gentlemen, the knowledge of statistics is a must for all doctors, and that includes surgeons also. We need statistics to make sense of data. It's high time that we all learn statistics and teach our students also, and it should be made a compulsory subject in undergraduate and postgraduate curriculum. Don't bother or get too much tensed about the calculation part, which looks complex. It's what is important is thorough understanding and of the concepts of the test, what test to do, when, how to interpret. These are more important than actual calculation. Calculations you can do easily using various softwares available both online and offline. My intention here is not to give you information on statistics, but to highlight the importance of statistics, make you understand that statistics is required for a medical person. And that is my intention. If I provoke interest in a few of you, then my purpose is served. Thank you. Thank you for patient listening, sir.
Thank you, sir. It was an excellent talk. And as you told, I would not use the word boring. A less interesting subject like statistics, you have highlighted the importance. And I'm sure many people will now be very interested in learning it properly the right way so that they can go on properly learning it from experts like you and Dr. Lakshman. A few questions have been put.
Yes, sir.
One is, why not it be in the curriculum of UG and PG as you have told in your study, so that people will get inculcated into the habit of learning statistics from the start itself. And Dr. Venkatesh has made a comment that faculty in medical college now, it is mandatory for them to have basics of statistics.
Yes, sir.
It is mandatory, no, sir. For all the government medical colleges, I don't know about the private medical colleges, like assistant professor to associate professor. This is a mandatory. They have to clear this exams, biomedical research and all the statistics, all this, sir. It's a mandatory from the last year.
Yes, sir.
It's a good move, yes, sir. And the website which Dr. Ramakrishna told, I think all the PGs would have seen that it will be very useful for them and all the surgeons also in general. Excellent talk, sir. Thank you. Thank you very much.
Thank you, sir.
If I may come in, Dr. Lakshman here, I had a question in the chat box. The question is, how do we get institutions to have, very formal, proper, critical appraisal of papers, including statistics? That to me seems to be the starting point. I wonder whether KCASI should have a virtual statewide journal club with special focus on statistics, where perhaps Dr. Ramakrishna and people like him could participate. I would like Ramakrishna's comments on it and comments from our teachers and HODs, please.
Yes, sir. It is a very good idea. I think KCSI must take initiative to have this, and we are always there to participate and help in whatever way we can. It should be done, sir.
There is another question in the chat box, sir. Why is basics of statistics not a part of the curriculum?
It is for the medical college rule maker. Those people, they have to think about it, and we feel it should be made a part. So now, as Dr. Venkatesh said, probably now onwards, they are going to take it up.
Actually speaking, it's not for super specialty, the paper publication. For MD, MS, it is a mandatory, sir, the publication, one publication, or to present their thesis. And in the thesis, the part B is analysis. The use of a statistician, go to the P&SM department. This is all mandatory, all that thing. I don't know how we follow, but whatever that is there in the curriculum, it's only the implementation from our side, the teaching side. We'll have to teach the students all this methodology. We'll have to have all this, like Lakshman says, evidence-based, and Ramakrishna says all this statistics should be a part of the CME program. Any CME, any continued surgical education, these two should be the part of continued medical education. And we have to force the students for all these kind of things.
Yeah, I think it must be right from the start. They must be exposed to statistics.
Analysis of the results needs statistics. Without that, we cannot publish a paper. I think Lakshman sir is the authority. Sir, please elaborate, sir. 1 or 2 minutes.
Professor Shanoy is waiting. Please let him
Yeah. Shanoy sir, Venkatesh here. Welcome, sir.
No, I just want to say that, Venkatesh, that every medical college has a department of statistics. Everything is true.
Yeah.
We just have to present paper. It is also true.
Yeah.
A promotion, it is required.
Yes,
But
sir.
actually, ground reality, as Dr. Ramakrishna so nicely, beautifully said,
Yes, sir.
none of them, including me also, I should submit the fact that don't know the statistics well. The
Start
whole
learning,
idea,
sir.
I think he is trying to stress upon that it should be understood well. The department is there, everything is there. We leave sometimes to the department of the statistician. I think this is my opinion. It should be part of the KCSI, definitely.
Yes, sir.
My submission is that it must be a part of every day, every
Yes, sir.
week, learning of the postgraduate. Doing something because it is mandatory is very different from something that they feel as a requirement for learning. The culture hasn't told them, our milieu, our atmosphere in our teaching and, general carrying of surgical specialty, it hasn't told them that evidence, statistics, numbers are very important, which they are. And so there must be a kind of an overall groundswell where we turn their attention to the fact that learning statistics, learning evidence is as important as learning management of pancreatitis or management of a hernia.
Like we have Lakshman sir and Somjekar sir, they'll be, we have that surgical society groups. Every day they'll be putting all the advances, all that writing an article is like having a coffee for them. Why don't we take the help of the Ramakrishna, Lakshman sir, Somjekar? They're all very good at all this part of this paper publications where the statistics is a mandatory. Why should we depend on a PhD fellow? We should do it ourselves. We should try to understand those basic concepts.
Absolutely. The first work to start with any paper would be documentation.
Yes, sir.
99% of the time when a PG approaches me or any of my students, anybody, there is no documentation. So they don't maintain the data in Excel sheet. A missing data would throw out a very bad statistics. Second thing is, before starting a study, we need to conceive what is the sample size and what is the expected difference. What is the p-value? Like, for example, if you think there are two treatment group, 5% is going to be the difference, which your historical background and your observation you notice. You would then need about 2,500 patients on either side to show that 5%. The moment the difference between two treatment group is 10%, the sample size drops to significantly 800, 900. So documentation, putting in Excel sheet in 01 format, and then learning how to use SPSS software, at least basics, Kaplan-Meier's curve and then forest plot. It's into getting into an habit. Once you get into an habit, it's very simple. It starts with proper documentation, prospectively maintaining your Excel sheet, and then the statistics comes out quite easy.
If we have the data, we can writing of an article will become easy. Like once we have the data, everything. Yes, sir.
No, you need proper planning, sir.
Yes, sir.
Sometimes we don't collect the data in a proper way. So that needs a proper planning. What data you have to collect and what are the data points, how many. Those things also we should be able to plan it properly, sir. Otherwise, in the end, if you try to do, sometimes we feel we should have collected that, we should have collected this. This problem will arise. That's the importance of writing a proper protocol. So before starting any study, you should write a proper protocol. There you will know what data to be collected, and if any flaws are there, you can do a pilot study for some time. Then you will understand what are the problems. You can correct it and start the proper study there.
Satya sir, can we go to the next paper?
Yes, all points well taken. We'll go on to the next paper.
Yeah, any questions pending, please type it in the chat box. The concerned person will answer. Yeah. I invite Dr. Somashekar SP. He is going to talk on nutritional management in early recovery. Yeah. Somshekhar sir.
Yeah.
A brief introduction about Somshekhar. He doesn't need introduction.
He
So there's a
doesn't need-
formality. Yeah.
Yeah, he is a very well-known oncosurgeon. As Venkatesh told, he doesn't need any introduction. In Bangalore Surgical Society, every day we see his excellent articles being sent on the WhatsApp group. Without wasting much time, I invite Dr. to present his lecture. Dr. Somshekhar.
Thank you very much. Can you see my screen? Is it full
Yes, sir.
screen?
Yes, sir. Please carry on, sir.
We can.
Okay, thank you. So welcome everybody, and I thank profoundly the state ASI chapter and Bangalore chapter to invite me for this topic, which is something which is close to my heart. So I will say how a nutritional implementation and a combination with ERAS is going to change the outcome in surgical practice. So the genesis of ERAS with nutrition based on only one golden question. That is, when you go out for a round next day morning, suppose you have 10, 20, 30, 40 patients post-op, you have to ask one question to yourself, your fellow, your team member. Why is this patient still in the hospital? Number one, is it like patient not recovered? Is there a complication? Is it because patient is on a drip so they can't go home? Or is it because patient has a lot of drains so they're not able to go home? Or is there any problem, complication, readmission, edema, paralytic ileus? So this was initiated by Professor Henry Kellett in 1990, who incorporated multimodal intervention with preoperative, perioperative, postoperative nutrition to expedite the recovery. Remember, it is not pushing a patient out fast. Only when patient is ready for discharge, you should make the patient ready for early discharge and send without complication. So 15 years back, this ERAS protocol started, and then the ERAS Society NCARE started and protocolized by evidence-based randomized trials, various 16 randomized trials. They made the guideline through research, education, audit, and they implemented the evidence-based protocols. So what are the main components of this? One is it is a multimodal perioperative care pathway. Surgeon alone is not an important path. Surgeon, nutritionist, nurse practitioner, anesthetist, post-op ERAS coordinator, everybody, including the patient, is a part of it. The main achieve you is early recovery, but that's not the only thing, not pushing the patient out of hospital. You should reduce the stress response, and this evidence-based medicine should be your own data-driven, recognized internationally. So what is ultimately the aim of any surgery? The aim of any surgery for us is cure, no complication, patient goes home without morbidity, mortality. Added to that is a early recovery. Remember, it is not the other way around. Without cure, without reducing complication, without bringing a better clinical outcome, pushing a patient is not an important factor. Now, all of them would have a happy patient, short hospital stay, and low cost to the healthcare. A person is a fool if we don't speak of cost in healthcare. We know that we have only that X finite amount of money. You can use in 10 big surgeries like transplant and leave all another liver 100 curable. So you have to optimize the money. So this is a very important, graph. You can see plus, minus, plus, minus. Like, for example, dialysis. It's never going to be rational, spending so much money keeping a person alive. So on the contrary, look at an aspirin. A tablet aspirin, lowest cost, but it gives the maximum benefit. Laparoscopy. It has got tremendous advantage. It has a good penetration into second tier city, easily reproducible, and then has benefit. And so it is very important to understand that it is not a nonsense approach, but a cost-benefit analysis. So the protocol is faster recovery, less complications, short hospital stay, few readmissions, full control of the complex care, increased staff satisfaction, less workload for the nurses, large saving potential to go. And then what is more important is you have to reduce the stress response to the patient so the complication comes down. That in turn will actually have a very important advantage. If there is a more stress response, complication increase, length of stay increase, there is a delay in treatment, cost escalates, prognosis comes down, quality of life comes down. For example, if there is a malnourishment and there is a major surgery, malignancy, immunosuppression, they're all risk factor. I'll give you one example. It is a very well known factor that in a colorectal surgery, if you start with minimal access, say laparoscopy robotic, and you have to convert to open, or if you have to give blood transfusion, that adversely has a reduction in the overall survival of a patient. So that is why it is very important to understand how we can work in ERAS add a immunonutrition, minimal access, and how protect our patients. So these are the components. Now, typically, what does a major surgery happens? You do a ball prep before admission. There is no nutrition evaluation. You make the patient starve. Like, before a marathon surgery, you make your patient starve, dehydrate, preoperative sedation, anesthetist will write. Then you do a surgery, then postoperatively, Riles tube, catheter, abdominal drain, pain relief, opioid analgesic, bed rest, IV fluid overload, edema, paralytic ileus, patient not walking, sister half the time is in changing the drip, then finally patient goes home. So, hey, you have a typical 1 week to 10 days stay. But remember, not pushing a patient. This is a very important randomized control trial which showed that if you push a patient when the patient is not ready, preoperative improper stabilization, perioperative not following ERAS protocol by you and anesthetist, postoperatively not following ERAS protocol by your nurse practitioner, rehabilitation doctor, nutritionist, and pushing a patient, look at this patient. When a patient is not ready for discharge, you push them, the readmission rate are 20%. We all know that readmission is double the hit on the healthcare. Very expensive, morbidity, mortality is there. So don't push a patient unless you followed all the aspects of ERAS. Remember what is bad. Bowl preparation, not good. Preoperative fasting causes insulin resistance, and then it causes paralytic ileus. Multiple tubes unnecessarily kept, catheter kept for more than 48 hours. So fluid restriction, epidural analgesia, nutrition on day of the surgery, early mobilization are important. Is it just all rocket science, or is it really a evidence-based? Now, if you look back in a multicentric prospective randomized controlled trial, it is found that if you do a proper ERAS, then 50% complication comes down. Anastomotic leak, infection, pulmonary, non-pulmonary. P-value statistically significant. ERAS, not some part, just telling I don't keep a tube, I start patient early and I send. No, that is 1% of ERAS. If you don't do all the ERAS component, it is a waste. Now, if evidence suggests 16 randomized controlled trial of 2,400 patients, if you apply ERAS, at least 75% and above components, complications are half, mortality comes down by half, readmission is less, hospital stay falls down by half. So now we will look at it, how we can actually apply this particular area and how we do this. Remember, it is not just surgical complication. Non-surgical complication like respiratory, cardiovascular, urinary tract infection, all of them actually come down for us if you apply ERAS. Remember, one of the main problem is respiratory, pneumonia, ventilator, ICU stay, wet lungs. So now if you apply this ERAS, you stabilize a patient pre-op, stop smoking, correct the iron, correct anemia, 2 weeks of nutrition, incentive spirometry. Then you apply ERAS, give a good dinner, normal sleep, no sedation, pre-op, maltose, carbohydrate, preload 2 hours before surgery. It is very safe, no problem with anesthesia. Multimodal pain management, no opioid. Then apply a minimal access surgery, day 0, ambulation and nutrition. Patient, you can reduce from weeks to days. And remember, not just this. This is a very important slide. If you apply 50% of ERAS, no benefit. Morbidity, readmission, complication, cost, no benefit. Only when at least 70% of the total component, 36 component of ERAS, 70% is adhere, that is when the morbidity, readmission, length of stay all help. So it is very important that don't do in piecemeal. This is another study published in World General Surgery which showed at least 70% of total component if you apply, then the Kaplan-Meier survival shows a better survival in those surgical patients. So how to fast track this particular area? That's why the ERAS Society is formed. It's a non-profit organization formed in 2001. It is present in 100 hospitals, 20 countries. And in Asia, we and then the National University Hospital in Singapore were the first hospital to sign an MOU with ERAS Society, which is present in Europe, to apply through the NCARE. So then we had this implementation program. We all thought at Manipal Hospital, we are using ERAS since 20 years. I don't want ERAS. What is there to learn? I don't put tubes. I send the patient home. I make them eat. So the ERAS Society told, okay, are you sure you're doing? So they came and they audited our result. Then they trained us. So we thought we are lions, but then we were actually cats before we applied, and reality was different. When we surgeon pat ourselves and think, I'm doing ERAS, they came and audited our first 100 patients individually and look at they have an interactive software. Their ERAS coordinator stays at hospital. You don't enter data and manipulate. They audit real-time, day-to-day in their interactive software. And they found, when we all thought, my GI, myself, my anesthetist were patting that we are using ERAS, our compliance was only 32.5% in spite of all the knowledge modern medicine, and our length of stay was 7.8 in abdominal surgery. And you can see the complications, pulmonary, non-pulmonary, leak, infective, thrombophlebitis, deep vein thrombosis, they were all different. Then we understood. Then they did 5 seminar training. Group of anesthesia, nurses, nutritionists, GI surgeon, oncosurgeon, general surgery, minimal access. All of us went to Switzerland, Lausanne. We got trained by them and we ran this course. Then they came and put up a team here. Every week we meet anesthetist, us, nutritionist, rehabilitation, ERAS coordinator, nurse practitioner, audit our result. Then we had a second seminar. Then the group comes and audits where we are wrong. And then every week we have an online seminars which audit. And then we got a first ERAS accreditation. How? Through this ERAS interactive audit system by a coordinator who is here. These are all the components you must do. I cannot enlist in the given time. If you don't do iron corrections, give first dose of coagulation a day before surgery. How often do we give a day before surgery? We don't do that. We give on the day of surgery or 6 hours before, not compliant. A day before, no bowl preparation, nutrition before, and then apply pre-operative, intraoperative. Day 0, patient must walk and should have a feed. Day 2, 5 hours they must walk. And then, you must measure the weight of the patient every day. If a patient gains weight on first post-operative day after anesthesia fluid, bad prognostic marker, not good, you have not done well. And then a beautiful nutrition rehabilitation, combination of oral, supplementation, before, after was used. The whole goal is to reduce the insulin resistance, neuroendocrine response, stress hormone, cytokine. And this is done by pre-carb load. 2 hours before the randomized control trial shows if you do pre-carb load, then patient is ready to eat fast, that much less of, paralytic ileus. So we got this from Nestle Europe. I requested somebody in Mysore to do this at 100 rupees. And we give this pre-carb load, add it, shake and drink. 2 hours before this dextra maltase was given, post-operatively 60 ml drink of this NutriPro, it gives 1.5 grams of protein per kg. So with a short liquid, patient gets back the energy. We did all this recommendation, we applied, we don't wait for bowel sounds to come. That is not a sign. Everybody is started. Then we give gut stimulants like chewing gum, strong coffee, or we give subcutaneous, neostigmine. And then I was honored that I was invited to be one of the panel, international consensus statement panel by European Journal of Surgical Onco for cytoreductive surgery. And we wrote the guidelines for this. Now we will see what is the result. Before ERAS implementation, look what was our compliance. Less than 39%, hospital stay 10, and total compliance was very low. Now you can see where we are, bowl preparation, preoperatively, not giving pre-carb load, thrombophlebitis a day before, pain, putting unnecessary Riles tubes and catheters. After 1 year, when our compliance increased by more than 50%, suddenly you can see in major abdominal surgery, length of stay came to 3 hours. And see how this interactive software showed where we were lacking. It is supposed to be a full circle, but look at how it is. Now we could reach a good compliance just by increasing the compliance to 70. Length of stay came by 4.6 days. Not just that. Look at the nausea, vomiting, complication, leak rates, paralytic ileus, respiratory, non-respiratory complication. All of them came down. All the complication, you can look, pneumonia, UTI, respiratory, urinary, all of them came down to us by just doing a course correction by a joint. This one. So compliance increased, nausea, vomiting came down. And now you can see the graph of compliance moved up. And suddenly we started accepting low urine output. Fluid, you cannot give more than 2.5 liter in 24 hours during surgery. And then if you give more than 2.5, then the mortality rate is double. So as the compliance increased, length of stay came down, complications came down, readmission came down, morbidity came down, in all the component, pre-admission, admission, post-op. And you can see that now when we cross 70% of compliance, we achieved a good clinical excellency. Not just that, now there are no tubes. Day one, IV fluids is stopped. Nurses is not busy taking care of that patient. Readmission is low. Fluid, antibiotic, everything is less. So we could save almost 30% of the cost. The nursing care workload came significantly down for us after we use it, because now patients walk, day one, they eat well, readmission is less, paralytic alias is less, antibiotic requirement is not required. Across all the components, colorectal, pancreatic, liver, upper GI, we could achieve an excellent care. And then we could also reduce the cost, number of length of stay. So, in reality, we thought that all of us know what is ERAS. Half of them lift the hand, yes, I do, but only 1 or 2 used to do properly as per the ERAS Society protocol and MOU. Only when we audit, we realized. So it is a dedicated team, proper protocol, documenting not by you, by the ERAS coordinator, third party to know, are you complying? Not that we pat my back and I say I'm doing well. So then auditing every week, stress, complication, hospital stay, cost, and then audit and then publish it and look at it. What is the outcome? That is what is there. So in take home message, nutrition, correction, proper nurse coordination between you, anesthetists, surgeons, nutrition rehabilitation, applying at least 70% of 36 components of ERAS, less than 30%, no benefit. And then allowing your colleague to, audit and peer review rather than yourself, and then share the experience. Remember, if we say I do always, we don't. The data and study without a proper data statistics audit is no value. So without facts, without publication evidence, we don't fit into anything. Prospective audit, we may think we look like this, but actually we may be something different. Remember, this is a very important point. Those who say that I follow without publication is level 3 evidence not to be practiced, which has no value. So we should stop guessing, stop auditing ourselves, how we are and what we do, and then start know where we sit. So remember what Edward Deming told. Without data, we are just any other person with an opinion and without any value of what we do. Thank you very much.
Thank you, Dr. Somsekhar. That was an excellent talk.
Thank you, sir.
The point very well made. As you told, you need a motivated, dedicated team to achieve all this.
Absolutely.
So you've been doing this in your hospital for over a decade now, you said.
Sir, we were thinking we were doing for over a decade, but we signed an MOU with ERAS Society since 2.5 to 3 years. So we were doing ERAS for 10 years, but it was never up to the mark which they told. And now since 3 years, we signed an MOU, they audited, they trained us, they have kept a coordinator. Now we have achieved a compliance. Now we have got a ERAS Society accreditation, first hospital in Asia. Now Singapore hospital is getting done now, sir.
Excellent, excellent, Dr. Somsekhar. Congratulations.
Thank you, sir.
Dr.
Speaking, Somsekhar sir, has recently we had from Surgical Society Bangalore, we had a talk about the same thing, sir. He doesn't need any PPT, all the slides, sir. He'll just talk like that. Any topic for that matter, especially this ERAS and all, he doesn't need the PPT, that slides at all. It's only for we to follow. That's all. Congratulations. Congratulations.
Thank you.
Yeah.
Dr. Lakshman made a comment that audit is critical in every aspect of surgery, as you rightly told, be it ERAS or any other field in surgery.
Absolutely. Otherwise, we'll be in a fool's paradise thinking frog in a well, everything is rosy. Only when we audit, we'll realize where we say, and then only we can scope of improvement. They say the first chance of correcting your mistake is first to accept you made a mistake. To know you've done a mistake, you need to audit to know where you've gone wrong.
Very true, very true. Once again, congratulations on the excellent talk, Doctor.
Thank you.
Dr. Venkatesh?
Sir, we'll leave it open for discussion. We'll make it interactive. We'll let, if somebody doesn't know how to put it in the chat box, they can ask directly, sir. We have 5 or 10 minutes more for the inauguration.
Yeah.
Do we have anything else? Any questions, sir? Lakshman, sir, you want to add on to this?
Yeah. Can audits be accepted as thesis topics. I think that will be a very good start, but hardly any institution accepts audits for a thesis. I think that will be a great introduction for PGs.
Sir,
Again, professors and HODs to comment, please.
Sir, according to RGHS, writing an article itself is a thesis topic, sir. How to write a article. Shanai, sir?
You have to
Can we have input from Shanai, sir?
I don't know whether it can be made. This is Dr. Venkat, what you told just now.
Yes, sir.
How to write an article. I'm not sure about that.
Okay.
No, as per the Indian University Act and DNB board and University of MS, MCH, DNB, a retrospective audit is not valid. It has to be a prospective. So if you give a prospective audit during their time, it is valid. Like, for example, you say prospective audit of pulmonary, non-pulmonary complications in consecutive 50 abdominal surgeries. So such audit, which is prospective during the course of the trainee, is valid. Retrospective studies are not valid in any dissertation as per Indian.
Exactly, sir. Yeah, that will have more value. Can we have some feedback from Siddesh, sir? You can unmute yourself, sir. Siddesh, sir? Are you there?
Somshika, just want to add one thing that the scientifically in the forum, the retrospective may not have much value for the simple reason that a lot of data is missing.
Correct.
But postgraduate thesis point of view, they are accepting, sir. Postgraduate thesis.
The retrospective study, sir?
Retrospective study also.
Okay, because DNB board has a clear rule that it has to be during their tenure only and not before. The retrospective means patients before their study they're enrolling. Means publication is accepted, but I don't know thesis topics, sir. As far as I know, it has to be from the day they join and it has to be only prospective.
As far as possible, we definitely give a prospective only. But what really happens is sometimes again this statistics issue, statistics and the number, probable number, what Dr. Ramakrishna was telling. Sometimes in a low volume centers, it may not be enough to give that data. So that is the time they will be asked to check into the 5 years data or something like that. And if then that is the time this issue will come.
Sir, but Shanai, sir, it's all, I think, the thesis subject we take. If it is a rare subject, the sample size will be low. I think prospective, you should have that prospective only, I suppose, sir. You should have the number of cases studied, no, sir? Depends on the condition of the disease. I mean, the topic of the thesis.
Dr. Godi wanted to make a comment, please.
Yes, sir. Godi, sir, you can unmute yourself.
This is regarding prospective and retrospective studies, whether they are acceptable or not. See, with the number of PGs increasing all over the country, in all medical colleges, MCA has been very liberal in giving excess number of PGs. With these excess number of PGs, finding out a prospective trial subject or topic is extremely difficult. So at present, the retrospective studies are going on, are being given, and are being accepted also.
Yes.
For the evaluation. So it is a good idea, it's a good aim rather to give all PGs a prospective trial, prospective research trial, but it may not be practicable at present. With the number of PGs increasing and with the number of clinical material decreasing in every medical college, because we have 61 medical colleges all over the country and we have clinical material which is insufficient.
How about this ethical committee clearance, sir? It's a mandatory, I suppose?
Yes.
Ethical clearance is mandatory for all research topics, dissertations, PG dissertations. It is absolutely mandatory.
Yes, sir. Yeah.
And unless that ethical committee clears, and also they too should need to get a number from the even central registry, they cannot start the investigative workup. They cannot enroll any patient. They cannot enroll. For example, last COVID time, the batch which has come in June month, we call them as a COVID batch PGs. They just got the enrollment now. Now means almost it takes 7 to 8 months.
8 months, yes.
The topics have been given almost in September end. So it takes some time for them to enroll, and they are left with now only 2 years or 1.5 years. Also, as Dr. Bodhi sir said, the number of patients that for that and to match the statistical demands. That is the problem actually.
Yeah,
my submission is taking the point that Professor Godhi made a little further. With so many PGs being in the department, it is difficult to give them research projects with research questions and get the numbers. But a volume of work, particularly in public sector hospitals, is pretty high. And so why is it that we're not seeing any audits, even in research, in thesis areas, and even when people are producing, submitting abstracts for papers, for example, we hardly ever see audits. Audits are easier to do, and perhaps you can get very good information about the, as Dr. Somshekhar said, about this status of practice, and it'll help the department improve the standard of service. So my specific question to all the professors, the teaching staff here in medical colleges, why are we hesitating to push audits, please?
So we'll take the last question for this session. This is to Somshekhar sir. Can ERAS be implemented in a public sector hospital?
Absolutely. ERAS is for every setup, every place, everywhere. In fact, the public sector hospital would benefit the most because they have a limited resource and huge amount of patients. Imagine you have say 100 beds and 4 OT and then 1,000 patients waiting, and they have very little cost access. So complication, readmission would hit them. That is where it would really help. All you need is one of your staff nurse you appoint as a coordinator, get a training done, have a joint clinic between surgical and this, follow the protocol, get a small training, and then follow an audit every week, highly used. And in fact, I would believe maximum benefit is in public sector hospitals, government hospitals, where it would translate into tremendous benefit to patient, lot of money saved, bed is available for more patients, less resources, antibiotic tubes and other things. Nurses are overworked, doctors are overworked in those places. That is where it would help the most.
Yeah, I think in a lighter vein, Naz madam has typed, giving a drink 2 hours before will not hinder anesthesia. Will not go with the discussion, especially for the pediatric surgery. Anesthesia will never allow 4 hours, 6 hours, whether it's milk or clear fluids. Thank you. I'll hand over the proceedings to Devakar sir. Can we go for the inauguration? 15 minutes.
Yes, sir. Dr. Venkatesh, we can go to the inauguration now.
Yes, sir.
Yeah. I welcome you all. Good afternoon, ladies and gentlemen. I welcome you all to this inauguration of Professor T.S. Jairam Memorial Continuing Surgical Education Program. Today, we have Dr. Abhay Dalvi, President, Association of Surgeons of India, amongst us to inaugurate this CSE. And he will be delivering a Professor T.S. Jairam Memorial Lecture after this formal inauguration of CME. Let us begin this with a invocation song, invoking the great architect of the universe with this beautiful prayer.
I think there is no sound, Devakar.
Audio.
एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि.
So, Professor T.S. Jairam needs no introduction, but to take and make his legacy known to the younger generation, we have prepared a brief slideshow about the legend called Professor T.S. Jairam. Dr. T.S. Jairam, born on 19th August 1941, completed his MBBS from Mysore Medical College, and he was a gold medalist. He proceeded to UK in 1947 and obtained FRCS in 1950. On his return, he was posted to Victoria Hospital. He earned a reputation as a good teacher and highly respected as a teacher. For some, he was a revered colleague, and others a friend and a guide. He was a philanthropist at heart. He was pioneer in setting up urology in the state. He worked as emeritus professor of surgery at St. John's Medical College. Other facets to the personality was he was an avid golfer, prominent Freemason. He is remembered fondly by those who knew him. He has left an indelible mark on the surgical history of Karnataka. Thank you. So, as we say, a Sanskrit verse, Shubham Karoti Kalyanam Arogya Dana Sampada Shatru Buddhi Vinashaya Deepa Jyoti Namostute. Meaning, I fold my hands before the light that brings prosperity and auspiciousness, good health, and destruction of the darkness of the soul. Now I request Dr. Abhay Dalvi, President of Association of Surgeons of India, to declare this Professor T.S. Jairam Memorial CSE open by allowing me to light a digital lamp, and I request him to declare the CME as inaugurated. Abhay Dalvi, sir, please.
Yeah, good afternoon. I declare the inauguration of Dr. T.S. Jairam Memorial CME open.
Thank you, sir. Dr. Abhay Dalvi is the chief speaker to deliver Professor T.S. Jairam Memorial Lecture. His lecture is titled Role of CSE in Training. I request our chairman, Dr. Sadashiva Sopimat, to chair the session, sir. Please. Yeah. I request him to welcome Dr. Abhay Dalvi to deliver Professor T.S. Jairam Memorial Lecture. Chairman, sir, please.
Yeah, we are privileged to have our president of ESI to deliver this lecture, prestigious lecture. I would request our president of ESI, Dr. Abhay Dalvi, to deliver this lecture, please. You have to unmute. You have to unmute, Dr. Abhay.
Okay, good afternoon. Is my screen seen now?
Yes, it is seen.
Okay. First and foremost, let me thank the Karnataka Surgeons Association for selecting me to deliver this Dr. T.S. Jairam Memorial Lecture. And I have slightly changed the title. I would be talking on surgical education. Is it become an issue now? I have no conflict of interest, and whatever you will be seeing is my personal view through 36 years of teaching as a near superannuation. Remember, educator need not be a good surgeon, and a good surgeon may not necessarily teach well. And this has to be really understood. If you go back into the history, Robert Liston in 1827 actually used to teach very well, and there were tickets which were sold to hear his lectures. However, he was not a very good surgeon. While performing an amputation, he wanted to be fast. He cut his assistant's fingers, and one spectator died. So this is the only instance where we had 300% mortality in a single surgery. William Halsted is the person who started apprentice-based surgery residency system and has trained countless generations of surgeons. It is even today practiced. But we have to realize that time has gone very, very fast, and changes have occurred, especially since 1986 or so, when I went on to become on the staff of St. GS Medical College and KM Hospital, Mumbai. I saw sonography machine coming in. I saw endoscopes coming in. I saw CT scan, MRI, etc., coming in. And this made a lot of change. Then came minimal access surgery with electrocauteries, which were high end, and even things like harmonic scalpel, ligashore has come into picture. The real revolution that had occurred, especially in India, was 1990, when Professor Udva performed the first laparoscopic cholecystectomy, and then it just started completely changing. So with this technological boom, especially minimal access surgery, came single port surgery, nodes, and now robotic surgery has come into picture. What is the result today? Just before I started this talk, lot of concern regarding teaching was being discussed. Lot of new things about ERAs are being discussed. Also, biostatistics should become part of PG teaching has come into. Now, what is the result? Result of this expanded technology has led to a very stressed and compressed curriculum. They have to learn all in 3-year time frame. There are no rotations in subspecialties. Now it is becoming mandatory. No curriculum change whatsoever during PG except at National Board of Examination level. And when they come in, their eyes are only on NEET to go get into subspecialty or super specialty. Increased number of PGs, as Dr. Godi was saying, has led to nothing but less OR time and OR exposure as far as they are concerned. And what is happening to the teachers? Teachers are having the clamor to learn advanced laparoscopic surgery and advanced surgical techniques. So they themselves, I think, have become mentees. So scenario today, mentee, all India entrance for PG, they come in with a completely language barrier, try to adjust all that they can learn in 3 years, but they are more focused towards subspecialty. And as I said, they have got very inadequate OR time. Mentors are trying to cope up with newer scenarios and have themselves become mentees and have started practicing defensive medicine. There are additional problems. There is no time to read or attend conferences for them. Poor accommodations, no family time because they come from outside the state. There is emotional exhaustion that I am seeing as well as depression. Some people get frustrated and they sometimes revolt, or sometimes I have unfortunately even seen suicides because of depression. There is a paradigm shift that has happened in these years. I was taught to take a detailed history, clinically examine the patient, come to a conclusion, and do relevant investigations. Unfortunately, today, history and examination have taken a backseat and investigations have come to the floor. So the result is patient comes with pain in abdomen, goes for a CT scan. The CT scan is reported by a second or third year resident doctor in radiology. And that is the report which is relied on and not clinical examination. So the art of yesterday is slowly vanishing. What I was taught was preoperative communication with the patient, clinical information, performance, technical and operative skills, post-operative hawk's eye to catch and complication early. And again, whatever you do, communication skills made the day for me. Now, as I see, and we all think of clamoring for surgical education, there are 4 types of people that we see. Number 1 is a standard student who would take his own time to train and reach a proficiency zone. The second person is, as it is very good, the person rapidly develops the skills and remains in the proficiency zone. Third is a person who has got excellent marks in the MCQ entrance examination, but is not competent enough to actually learn surgery. And however hard a teacher tries to train, this person seen in C never improves. But what is more worrisome for me is that a student is learning, reaches proficiency zone, and because of work pressures, and limited time frame that the person has to learn starts deteriorating, starts becoming frustrated, and the skills go down. The government plans, if you see, Vision 2015 is health for all. They want an Indian medical graduate to be a clinician, a reader, a communicator, thoroughly professional, and lifelong learner. And that is why they are now looking at competency-based medical education that has to be done. They have pushed it through the National Medical Commission, but there are practical problems. Selection criteria, the NEET system requires to be changed to competency-based medical entrance so that we know whether this candidate is really interested in learning surgery or no, especially because there is inadequate time to learn or even teach them. Government has hurriedly implemented this. It is like a building which is planned without a strong foundation. If you look at various surgical societies all over the world, whether you take American College of Surgeons or Royal College of Surgeons or even South Africa and Korea, a person becomes a surgeon at an average of 6 to 8 years of training and not 3 years. And that is where a complete surgeon can be made. If you see the curriculum all over the world, it is first 3 years, the foundation of open surgery and introduction to minimal access surgery is laid. At the end of 3 years, the person can choose his or her specialty, but there is no special MCH degree. The person can do 3 years in fellowship in plastic surgery and start practicing plastic surgery. Here, what is happening is when a general surgeon goes out into practice at the end of 3 years, he still has to learn a lot of things which is lacking. And that is why I personally feel the time frame should be increased so that we can churn out better surgeons than what we are doing today. The Association of Surgeons of India has more than 27,000 members, and we are there. The aim is to enhance knowledge. We are running regional refresher courses, national skill enhancement program, and obviously state and national conferences for benefit of the postgraduate students. Corona has exacerbated the problems of the residents. The residents have been pushed into Corona duties. All routine operative work has come to us, and still now slowly it is limping back. Wards have been taken over by COVID patients, and the PGs are themselves getting infected, which is a sad thing. Friends, knowledge can be Googled, but art of surgery cannot be learned by looking at videos. One has to lay hands, and that is what is important. In order to cover up for the lack of operative experience over the last 1 year during this pandemic, the National Skill Enhancement Program of the Association of Surgeons of India has started a video-based program and common operations which I expect the PGs to learn in the 3 years period will be taken on every Wednesday between 9 and 11 p.m. Please tell your resident doctors to log on. It's through ASI India Facebook page. There is no registration fee and it's free for anybody who wants to learn basic topics in surgery. On my part, I am sending an advisory to the government on behalf of all of you all, that is the Association of Surgeons of India, to standardize and revisit the curriculum, have minimum practical experience, rotation of a PG in his or her intended area, and oversee this implementation. And I'm going to plead to them to give us a hearing. I do not know whether we will get a hearing because many a times governmental ear is out of order, but not failure, but low aim is a crime according to me. And that's why we are going to try definitely for the future. I would also tell you to read this article, which has been penned by my colleague, Dr. Avinash Supe, on value-based medical education. And that is, according to me, what is the requirement of the day as far as the PGs are concerned. At the end of 36 years as a teacher, I possibly have churned out a lot of PGs. And luckily for me, all of them are doing well. And here I am still trying to help the PGs now across the country through the National Skill Enhancement Program. I thank the Karnataka state again for bestowing on me Dr. T.S. Jairam lecture. Thank you so much.
Thank you, President. That was really an excellent talk and quite inspiring and motivating. I'm sure that it will make many people to ponder on the points what you have mentioned. And hopefully, I think the academicians should sit together and revisit the curriculum, and hopefully some good things will come out. I think there won't be any questions in this session. So we'll move on to the next session. I think we immensely
Dr.
thank you.
Sopimat,
Yeah.
Dr. Sopimat,
Yeah.
there are many professors who are logged on, as I see.
Yeah.
If you have any suggestions, please feel free to send me a mail.
Yeah.
Okay, because right now it is single brain which is working. I want multiple brains so that a proper advisory can go to the government.
Yeah. So we'll collect the feedback if the faculty gives us any feedback, and we'll forward them to you. And in fact, I think I had made one suggestion. I think you must be reconsidering that
Endoscopy
in the curriculum. Yeah.
Endoscopy.
Yeah.
There are series of 4 lectures on endoscopy. You are also going to be one of the speakers. So it is coming. Don't worry. We have got 1 full year to go.
Thank you.
Sopimat sir, can we have the feedback of other senior faculty, sir?
Yeah, sure.
Yes.
Sure. If they want to make any comment, they can make.
Chennai sir,
yeah.
Lakshman sir. Chennai sir, yeah.
Good afternoon, President sir, Dr. Abhay Dalvi sir. And as has been told that the present batch of PGs who have come now, they have an option of 3 months government postings also. I'm talking from the private medical college. 3 months of postings in the government medical college and 6 months of postings in the specialties and 1 month of additional posting of their. This is the area which I heard the President speaking now. Instead of that 1 month, probably they can have the choice of their. Somebody says, I'm not interested in plastic surgery or say pediatric surgery. He is interested in urology or something. These are the things which can be always sent. I will send my suggestion. Thank you, sir.
Yeah, Dr. Lakshman here, if I may chip in. Wish you the very best, President, sir, for your year in office this year. As you have requested, we will be sending you some suggestions, but in a larger forum here, I would like to air 2 or 3 issues that I would like focused on. One of them is, of course, to take this evidence-based approach to the national level. This would be an excellent opportunity where I'm sure we have a lot of people who are well trained and who are well adapted to making the concepts clear. My request is that we should consider taking it to the national level. The second one is to have a more focused mentorship program. You're very right in saying that 3 years is a very short period. I think after getting the MS, the students, the fresh graduates must spend at least 3 years in actually learning the operating and the nuances of diagnosis and choosing the operations and the like. And it's well served if the ASI can have a central coordinated program, if at all possible, to have these students sent across the country to various consultant surgeons. They need not necessarily be teachers, but they may be very good practitioners, to send them across on a well-planned and coordinated mentorship program. That is something that the ASI can consider. Thank you.
Thank you, Lakshman sir. Rajan sir, can we have your feedback? I think Godi sir, Dayanand Nuli sir can also just chip in. Rajan sir, yeah.
Good evening, Dr. Dalvi, and congratulations. Very, very contemporary and apt topic. My only take is that in our days we had more clinics and bedside teaching because knowledge had to be shared. But today knowledge is available on the Google and everybody can have access to knowledge. It is our, as Dr. Lakshman just put, mentorship of younger students into the intricacies of surgical life that is more important and should have a stress on it, sir. So I feel attachment to a surgical team, for a while is going to be a important aspect of developing skills for the future. Thank you, sir.
Godi sir, please. Just chip in, sir.
Yeah.
You have feedback. Yeah.
I must really congratulate Dr. Abhay Dalvi for an excellent talk based on 36 years of teaching experience. It's a huge experience of teaching. His suggestion, I would like to opine about his suggestion of increasing the postgraduate course from 3 years to 5 years is a very good suggestion, excellent suggestion. But we must also look at the national scenario of the healthcare in India. What we need is more doctors delivering good healthcare across the country in all areas, including the villages. And if we increase the postgraduate course from 3 years to 5 years and hold these postgraduate students back in the department for 5 years, will it be helpful? Will it be beneficial? Looking at the national scenario of the healthcare delivery in India is my doubt. I would like to express to Dr. Abhay, and I want Abhay to opine on this aspect.
Sir, right now what is happened is that in these 3 years, I am expected to send a surgical resident for a period of 3 months to work in rural area and help in surgical practice. So these 3 months are gone. 3 months they take leave for examination, which is officially had to be given to them. So 6 months are already gone. That leaves me as a teacher with 2.5 years only to train a particular person. The first 6 months, especially if the person comes from outside the state and does not even know the local language, to get into the rules of the game, it takes about 3 to 6 months for the person to train. And that means it leaves me only 1.5 years to teach him the art of surgery. Now, this is what is the basic problem. And that's why I feel seriously that I am not churning out a good surgeon at the end of the 3 years tenure. I am about to retire, so I am escaping all this, but it hurts when you see a candidate, and we have been lenient, we have been just passing candidates, even at MS level. During my time, I remember it was 30% passing. Today, last 3 examinations, I am seeing 100% people have passed. Now, when we are churning out surgeons whom you know that they are inadequate, just imagine a surgeon trained by me comes to you, sir, and is unable to even do a resection anastomosis. What impression will you have about me? You will say Dr. Dalvi is a well-known person, but his student doesn't even know to do an appendix. Now that is we are coming to, because students also want to learn only laparoscopy. They don't want to learn open surgery. That is the problem. And that's why I feel it will take some time to churn out a good surgeon who will have good foundation of open surgery and introduction of minimal access surgery. That is what is required.
Thank you, sir. Can we have Guru Shantapa, sir? So you can unmute yourself.
Sir, yeah, sir, Dalvi sir, good evening. And it was an excellent talk, and you have brought out many practical points. One of the suggestions which you can put forth to the higher people, like you said, instead of making MS for 6 years, after 3 years, they should not be allowed for MCH examination unless they work on 2 years. The eligibility for going for specialty like MCH should be post-MS, having worked, having got the experience of general surgery for another 3 years, then only we should allow them. Otherwise, the very entry of MS, they will plan for MCH, and absolutely they will not be learning anything. And second, rightly you have pointed out, even if it is a 18-20 batch of students, straightway examiners are going to pass all the candidates. And absolutely, in my own experience, the person who doesn't know how to do circumcision was given MS, and he will do urology. And recently, one who got a MS from a reputed medical college, after a few months wanted to practice and went for doing appendicectomy, and he came out of the hospital mentioning, I don't know how to do appendicectomy, you call some more other surgeon. Sir, really things are going out of the way. really things are becoming pathetic. And if such people becomes teachers in the further future for the next generation, it is going to be really tough. Thank you, sir.
Can we have some feedback from, I think we have Arvind Patel sir, Siddesh sir, Noli sir. We have so many seniors, please.
I think you all collectively please email to me and I will take up many points. Dr. Guru Shantappa, I have noted, and it is very true that assistant professor who is joining right now is unable to cater to emergencies. Associate professors have to be all the time on standby for at least 6 months before an assistant professor can be left alone. This is the truth that I'm seeing in one of the largest medical colleges.
So there is a basic question here. Is there a definition of general surgery?
Sir, I will tell you what my concept is, that 3 years we should work hard. Don't give them MS. Whoever wants to become a general surgeon should parallelly do 6 years as a general surgeon, and those who want to go for super specialty at the end of 3 years can go into plastic surgery. It's similar to what is happening abroad, that you have at the end of 5 or 6 years a complete general surgeon who has knowledge of open surgery as well as minimal access surgery. And those who want to selectively practice gastroenterology can go for surgical gastroenterology. Those who want to do oncosurgery can go for 3 years of oncosurgery. But this choice should be given by identifying a person's competence to become a good general surgeon or to become a specialist surgeon. That is what we are thinking. Of course, 1 year is too small a time for me. I hope Siddesh will follow up. He's from your state, so you catch hold of him and see everything. Go after him once I finish.
Yeah, I'm calling him since that time. Siddesh sir, are you there?
Difficult to catch him.
Yeah. Shiram sir, I need your chip in. Yeah. Shiram sir, unmute yourself.
Yeah. Good evening, President. I think it was an excellent talk. So definitely we'll send our feedbacks. At present, I think most of the points are covered. Thank you very much.
Thank you, Shivaram sir.
Thank you, sir. Arvind Patel sir, you want to say something? You're raising your hand. Patil sir. I think we have Hebsor sir. Enilva sir. We have our dynamic president, SSB Bangalore, Venkat. Yeah.
Yeah, thank you, Venkatesh. Good evening, President sir. It was a very good talk. I am a professor for DNB surgical oncology. So when we are teaching our DNB students now, we can see that when they are presenting the case, we have to teach them like MBBS students. So definitely what you suggested, I support that. Means nobody should come out at 3 years. They should be at least 5 years, if not 6 years. They should be carry on and come out with either a super specialty degree or a well-trained route, so that he can, when he comes out, goes to the periphery wherever he has to practice independent.
Actually, I'm fortunate that Dr. Pavnila Lal, who is the vice chairman of National Board of Examination, is also towing the same line. And maybe collectively we will be able to put some pressure because he is near to the ministry. Let's see how it goes. Sopimat, I think this can go on and this will get converted into ASI Zoom meeting. So you please go ahead with Karnataka State Chapter meeting.
No, we had time actually.
Okay. I don't know whether we have time.
You finished well ahead of time. And
oh, I'm so sorry.
It was precise, concise by the concept of Sopimat sir and Divakar.
Yeah.
See, we next session is at 4:45, sir. And the speakers are ready. So we want to have the problem of today, and we are discussing seriously. Shall I say?
Deliberately, we have kept time for discussion so that the session is more interactive and more ideas come out rather than just limiting to the talk.
That's no problem. I am ready. No problem.
Dr. Venkatesh, adding additional years is cannot happen only for general surgery. Then there will be further questions happen to other MD specialties, number one. I'm just talking my perceptions.
Yes.
Number two, very often if you are seen, including Rajiv Gandhi University best, many gold medal winners from Shimoga, etc. last years, when the question was asked which branch you take, very often they have not even taken the good branches. They have taken the other branches. When I say other, means could be non-clinical or preclinical.
Lucrative, sir. Lucrative. The financial.
Reason is not just lucrative here. Adding on number of more years. As such, you look at the quality of the type of the students who are getting into the NEET and entering into the medical colleges. See, about 60,000 students now in the MBBS and then post-graduation. They will always look at, oh, this is not only now 5 years, 6 years, 10 years, 15 years. The years will never end like this. They will as well opt for the other software engineering and all whatever it is, other things. So we need to have a real critical thinking about these issues and decide on this about the extension of the number of years. This is my personal view.
Shanai sir,
yes.
See, I think Maharashtra University of Health Sciences had started such a thing in neurosurgery, where as soon as the person finished MBBS, if a person wanted to do neurosurgery,
Correct.
He would work in neurosurgery directly for 5 years and appear for neurosurgery examination. They did the same thing in chest medicine, and it was working quite well. I do not know suddenly why they stopped it and reverted back to 3 years of general surgery to be necessary, and then 3 years of neurosurgery. There has to be something. See, why I am trying to say is that then we can, as teachers, standardize the curriculum. Right now, we are not able to standardize the curriculum with limited time frame that we have. So I said that a particular boy may be really good and he learns very, very fast. We can't even stop that person from learning fast. The problem is of people who know to learn but start deteriorating because they want to learn this also and that also. At one point of time, the boy or girl starts thinking that, oh, I did not learn that and I did not learn that properly. I know to do only this properly. And then that frustration, you can make out the way a person was working suddenly changes and stops working in a proper manner. This is why I feel that it will require a little more time for us as teachers to guide them. As Dr. Lakshman was talking about mentorship, this focused mentorship will come if we are also given that much time. See, today, last year, I got some 2 registrations. My associate professor got 2 registrations. My assistant professor along with me got 1 registration. So 5 registrations, 5 people in 1 unit to be trained. And if you calculate 3 years, I have 15 residents working with me. What do I do? The theater time has not changed. Theater time has remained the same. Days of week have remained the same. The operative time remains the same between 9 and 1:30. By 3:30, we are supposed to finish the theater. How do I give practical experience to my juniors? It is becoming impossible.
So
my associate professor wants to practice minimal access colorectal surgery and minimal access hernia. He takes 2.5 hours for colorectal, which I can finish and teach by open surgery in about 1 hour's time. I have personally stopped doing lap hernias because hernias are not, people are not learning open Lichtenstein repair because everybody wants to do lap hernia. This is the situation. Anyway.
I just wanted to make one last comment that probably it is more than the number of years. I think our system has to change.
Yes.
I think the recognition has to change. There's so many PGs that should be based on the surgical volume. And there has to be a curriculum which has to be designed that these procedures must be taught and this many procedures have to be done. And these are not necessary for a medical college, like, that you teach them laparoscopic hemicolectomy, laparoscopic hiatus hernia. I think basic open surgery foundation has to be there. Then I think this sort of curriculum, unless it comes out, I think they will not learn the basic surgery. Rather than extending the number of years, this many years, and exam system has to be very strict and it has to go back to the older system of strict evaluation. I think everything has to change. I think ASI with the partnership with the NMC probably can bring out some change.
Yeah. You're talking about the logbook maintenance, day-to-day basis.
Yes. It is there, sir. What they are supposed to operate, everything is
It is there.
Clear in the
logbook is there. At the end of 3 years, just before examination, the boy will come to you with the logbook, which is full of operations.
Yes, sir. And to end the session, we have Aruna ma'am is asking, what if it is 6 years like pediatric surgery, plastic surgery, all this post MBBS 6-year course, if general surgery is 6 years, what is the curriculum? She's asking. And Rajan sir, as usual, he has defined the Wikipedia definition. It is a surgical specialty that focuses on abdominal contents, including esophagus, stomach, small intestine, large intestine, liver, pancreas, gallbladder, appendix, and bile ducts, and often the thyroid gland, depending on the local referral patterns, deals with diseases involving the skin, breast, soft tissue, trauma, peripheral artery disease, and hernias, and perform endoscopic procedures such as gastroscopy and colonoscopy. Yeah. So we'll end this session. Anything inputs, please put it in the chat box, and seniors are there to take care of that.
Thank you, President.
We'll go to the, thank you all for your active participation.
Thank you all.
So I thank Satyakrishna sir for excellently chairing the first session. Now I call upon Dr. Somashekar SN to chair the next session. And I call upon my president, SSB Bangalore, Dr. Venkatachala, for his talk on Sentinel node biopsy in breast cancer. Do we have his presentation? Sharing?
Venkatesh sir, introduce Dr. Somashekar N, please. He is professor at JJMMC.
Okay.
He is professor of surgery. Let me do that. He is professor of surgery at JJ Medical College in Davangere, and he is a senior teacher and has been an undergraduate and postgraduate examiner for so many years and has good scientific publications under his name. We welcome Dr. Somashekar SN to chair this session, and Dr. Venkatachala, if he is ready, he can share his screen and start his topic. Thank you.
Venkat, you want to share your screen?
Yeah, I'm doing
it. Yeah, please. Yeah. I hope he is the co-host. He has made been the co-host.
Can see now?
Yes, we are seeing there are some settings.
Yeah, please continue.
Yes.
Thank you, Venkatesh.
Yeah.
So, as you know that this is a hot topic, sentinel node biopsy in breast cancer. With the change in the trends of patients coming to us in this thing, they used to come previously in locally advanced stages or advanced stages. Nowadays, we see the patients coming to us with early breast cancers. So then concept comes to give functional outcome also must be better. So normally what we used to do is axillary node dissection, that was the standard, and mastectomy. Then we moved to organ conservative approaches. And when we moved to organ conservative approaches, we also moved into the functional preservation. Here, functional preservation goes to reduce the lymphedema and shoulder dysmotility problems that can happen with axillary node dissection. As you can see here, breast has a very rich supply of lymphatics, starting from the submucosal sapis plexus. It can go all around 360 degrees. Predominantly, it goes to the axilla. We divide them as level 1 nodes, level 2 nodes, and level 3 nodes, and also sometimes to the supraclavicular nodes directly from upper quadrant or from skin involvement. And second, third, and fourth internal mammary nodes are also very much important. Some lymphatics do go to the falciform ligament. So you can look at the incidence of axillary node metastasis. It increases as the size of the primary tumor increases. So in the in situ malignancies, it is less than 1%. But as you can see in tumor less than 0.5 centimeter, you can see around 5%. 0.5 to 1 centimeter tumors also around 16% can have metastasis. Obviously, the tumor biology and the estrogen receptor status and other things. Coming to the 1 to 2 centimeter tumors, you can see around 1/3 of them. As it goes to 2 to 5 centimeter tumors, around 50% of them. T3 tumors and T4 tumors, you can see that the percentage increases significantly. What we should be looking also is into skip metastasis. Skip metastasis is when we say sentinel node, it is, we always talk about the first lymph node. The first lymph node may be usually in level 1, but it sometimes can be in level 2 and level 3. This is the amount of dissection that has to be done to do complete axillary clearance involving level 1, level 2, and level 3. We do this only for multiple positive nodes these days. Level 1, as we all know, is below and lateral to the pectoralis minor muscle. Level 2 is behind the pectoralis minor muscle, and level 3 is above and medial to the pectoralis minor muscle. So any surgery comes with morbidity. Obviously, we all like to do it with less morbidity, hence sentinel node biopsy. So 70% of the cases of early breast cancers don't have nodal involvement, and 50% develop complications, which can be lymphedema in 15 to 25% of the cases, intercostobrachial numbness in around 70 to 80%, restricted shoulder movement in around 17%, even with adequate physiotherapy, paresthesia, seroma formation, prolonged lymphoria, prolonged drain requirement, prolonged hospital stay sometimes. The increased morbidity with all this is difficult to justify in all the cases. The term sentinel node, by definition, was the first lymph node encountered by the lymph vessels draining a tumor. It was coined in 1960 by Gould et al. For cancer of the parotid gland. Axillary lymph node status is an important prognostic factor for patients with breast carcinoma because it is the most important prognostic factor. Sentinel lymph node biopsy is the new standard. Where did the concept come from? The sentinel lymph node biopsy is the first lymph node to receive lymphatic drainage from a primary tumor. If it contains metastatic tumor, this indicates that the other lymph nodes may contain tumor, not necessarily all. Usually around 69% of the cases, it can be the only positive node. So if it does not contain metastatic tumor, other lymph nodes are not likely to contain tumor. The skip metastasis, I always stress on that. What happens in skip metastasis? The primary tumor, then comes the lymph node. That is the first lymph node. We take it as the first echelon node as sentinel node. Then the second echelon nodes are the third echelon nodes. Skip metastasis directly, skipping this, and going to the second echelon nodes can happen in 2%, means level 1 nodes are not involved, but level 2 nodes can get involved in 2%, and level 3 nodes can get directly involved without involvement of level 1 in 1% of the cases. So only 3% of the cases there can be skip metastasis, that is accepted. So current indication, we limit to T1 and T2 tumors, less than 5 centimeter of the tumors with clinically negative axilla. Clinically negative axilla can be either by clinical examination or any radiological imaging. DCIS, where mastectomy is needed, you can try to do sentinel node biopsy because anyway you raise the flaps to the axilla or the axillary tail area where the sentinel node is usually located. DCIS with suspected or micro invasion has been proven in the final histopathology report. You have to do sentinel node biopsy. Clinically negative axillary nodes following neoadjuvant chemotherapy also you can do. So what are techniques used? The commonly used method now is dual tracer method, and that's use of blue dye and a colloid, radioisotope tagged colloid. It's not, as you know, radioisotope or the nuclear medicine department is not available everywhere. Routine use of IHC for cytokeratin and polymerase chain reaction, that is the RT-PCR. For the molecular diagnostics, if you want to find out the presence of micrometastasis, this we don't use now. The West uses it because they remove the sentinel nodes in the office and send it for tissue diagnosis and H&E staining. And when the final report comes, then they take the patient for breast surgery as well as axillary node mapping, depending on the report. There, the cytokeratin and the PCR techniques are used for identification if the H&E staining is negative for metastasis. ICG fluorescence is an emerging technique. Few centers have the equipment to do it. So this is the tumor. So we have to look into the axilla, inject either isotope and methylene blue or combination usually is used. It goes to the axillary nodes. Whichever is stained blue is taken as a sentinel node. Obviously, we use the handheld gamma probe also to check that. So we have to remove the sentinel node. While we inject the isotope, we also do a radioscintigraphy to know the exact position of the node, because lower inner quadrant tumor, the lymph node can be in the axilla usually, but sometimes can be in the internal mammary nodes also. So you should know, if the internal mammary node is a sentinel node, we don't remove it. We treat it with chemotherapy and radiation and not by surgical removal. Although you can remove it, we have tried, we have done it, but it's not a recommended standard. So sentinel node biopsy can be double in the axilla. We concentrate on the axilla. 0.2 millicuries or 0.2 ml of technetium sulfur colloid is injected peritumorally or intradermally over the tumor about 2 hours before the surgery. In Western people, they use colloid human albumin. Here nanocolloid, here the cost issues come in. We have our own sulfur colloid. For the last 15 years we have been using. Methylene blue 1 ml is injected in 4 quadrants around the tumor. 1 ml each in 4 quadrants. Don't inject 4 ml in 1 quadrant. It can cause significant fat necrosis and tissue damage. So as we can see, this is a patient taken for mastectomy. We have already injected the isotope. Now we are checking for the activity in the primary tumor area. The tumor is located in the central quadrant. You can see that the isotope activity in the area is very high. And then we check in the axilla. Now you can see that the activity in the axilla is lesser compared to the primary tumor. A small incision is just needed, 2.5 to 3 centimeter incision, exactly over the area of activity. So we use the handheld gamma probe, which is being used here to localize this thing. You check now as you go towards the lymph node, you see that there is more activity when you go closer to the lymph node. So then you can see the blue node here exactly in that location. We have picked up the blue node there. So it is a visual impression as well as the isotope localization, both. You can see the beautifully stained blue node there in the level 1 of the axilla. No, level 1 is a big area. No, it includes upper and lower central nodes, anterior, posterior, lateral, medial group of nodes. So mapping is very important to localize where exactly it is located. We also trace this blue node by going to the tracing the lymphatics from the tumor towards the axilla. Now this is a case of mastectomy being done. So already the upper flap is raised. Now I will show you there's a blue node here. So now we pick up the blue node. It is very well seen now. So take the blue node, and what we do is we send this lymph node for frozen section analysis. Once the frozen section analysis is done, then you know that what is the status of that, because a pathologist takes multiple serial sections through the lymph node, analyzes it in detail, and then gives a report. So even micrometastases are not usually missed. So we harvest the node, and again the same gamma probe is used to identify the activity, confirm that it is there. What we also do is we check for radioactivity or any other blue stain node in the axilla before we go ahead with the rest of the procedure, so that nothing should be missed. Any lymph node with around 1/10 of the background activity of the sentinel node must also be removed. So sentinel node should have significantly higher count than that of the background. So anything more than 10% of the activity of the sentinel node also removed. Same is confirmed here with the handheld gamma probe on the counter, and multiple sections around 12 to 15 are taken of the sentinel node. This was the first trial, the Almanac trial, axillary lymph node mapping against sentinel nodal axillary clearance trial, which showed that when there is frozen section shows that sentinel node is negative, avoid axillary node dissection, and positive means do axillary node dissection. Then came the NSCB B32 trial. I will discuss about it next. So it showed that lower rates of arm edema, sensory loss, less drain usage, length of hospital stay was less, and time to resume normal activity 1 year after the surgery was less in those patients who undergo sentinel node biopsy. So what are the cases where sentinel node is done? T1 and T2 tumors, yes, not for T3, T4. Multicentric tumors, yes, but we inject around the site of the biggest tumor. Inflammatory breast cancer is not recommended. DCS without mastectomy, no. DCS with mastectomy, yes, you can do. Suspicious or palpable axillary nodes, no. You can try to do a USG guided FNAC, which comes in the next trials. Older age, yes. Obesity, yes. Evaluation of internal mammary nodes, it can be done in a clinical trial, but not routinely. You can use the scintigraphy as a tool for that purpose. Pregnancy, no. Prior diagnostic or excisional breast biopsy, yes, you can do. There can be some difficulty, but you can still inject in the upper outer quadrant towards the axilla, away from the scar. Prior axillary surgery, yes, there can be difficulty here because of scarring, but still you can try better than doing nothing. Prior non-oncological breast surgeries like reconstructions or mammoplasties, it is not recommended because of the extensive dissection done, or implants. Before systemic therapy, yes. After pre-op systemic therapy, if there is no negative axilla, yes, you can do it. So the American College of Surgeons Oncology Group Z11 trial, this was the trial which just put its around close to 10 years outcome now. The end point, you can see that sentinel node biopsy versus sentinel node biopsy plus axillary node dissection, locoregional recurrence, nodal recurrence, disease-free survival, overall survival, there was not much difference between the two. So what that trial uses is anything less than 2 lymph nodes positive, 1 to 2 nodes positive, no further axillary node surgery will be done. Anything more than 3 positive sentinel nodes, 3 or more, they will be randomized to do axillary node dissection. Further systemic therapy or radiation will be as per the standards. So when they compared that, they found that all the odds were towards the sentinel lymph node biopsy group. So this was the NSABP B32 trial. Negative lymph node status was initially considered. This was the trial where they started it as the node negative to do sentinel node biopsy and also to do sentinel node biopsy plus axillary node dissection. The randomization, there were a huge number of patients, 2011 versus 1975. Then the other trial I mentioned here, the Z11 trial, they included positive lymph nodes and they included the number of cases 430 to 420. Amara's trial was one more, and the International Breast Cancer Surgery Group. You can see that the duration of follow-up was the most in the NSABP B32 trial, and other trials are also have done reasonably well. Ultimately, axillary recurrence, overall survival, or disease survival, as you can see from the numbers here, they are all the same. There is, in fact, it favors more towards the sentinel node biopsy group. So the current algorithm towards management of the axilla is negative nodes by physical examination alone. If you are doing mastectomy or breast conservation, sentinel node biopsy sent for frozen section. Without frozen section, whether to do, because breast conservation, the incisions are different. So what they do is they do it sentinel node biopsy on as a first procedure, send it for HNE without frozen section, and then when they wait for the final report, less than 2 millimeter node or without extracapsular spread, you can, or called as micrometastasis, you can avoid axillary node dissection in those patients. So when frozen section is done, negative sentinel node or micrometastasis means less than 2 millimeter, no further axillary surgery. Sentinel lymph node biopsy is positive for macrometastatic disease like what is mentioned here, more than 2 millimeter extracapsular, complete axillary node dissection is to be done. That is that protocol for negative. So, and I will also come back to the next this thing also. Because the Z11 trial uses this, they do send the lymph nodes for HNE and then the wait. We don't wait here. That is why we adopt this protocol. So here the sentinel node is negative of 1 to 2 positive nodes, no further axillary surgery. If the 3 or more positive lymph nodes or grossly matted disease, they advise complete axillary node clearance. So you have to clear the confusion must not be there. We are doing frozen section because we are not practicing that, sending it for HNE staining first and then doing the surgery later. So frozen section is used by us, whereas the Western people, they when BCS is done, they try to use the the H&E staining technique. If clinically positive, USG guided FNAC or core biopsy. If it's positive, do axillary node dissection. If it is negative, send the sentinel lymph node biopsy for frozen section. Negative nodes, no axillary surgery. Positive means do axillary. Means even in positive, clinically positive nodes, you can still try to do a USG guided FNAC or core biopsy. Core biopsy can be done by radiologists. We have good techniques now. Positive versus negative, the approach will be different. So last but 2 slides. As you know that indocyanine green is coming up. It's useful in centers without nuclear medicine department. It uses a fluorescent dye, as we all know. A near infrared imaging agent. ICG can be traced in real time in high resolution. Transcutaneous visibility of lymphatics is an advantage. An exoscope using extracorporeal magnification coupled with fluorescence camera is used to trace the dye. Cost effective because it doesn't need the radioactive isotope or the handheld camera, because isotope plus the technique usually costs around 10,000 rupees in most hospitals. Gamma camera, it comes to around 15 to 20 lakhs. Several clinical trials have shown higher detection rates as compared to blue dye. Only blue dye, because some centers which don't have the isotope facility or handheld gamma camera were using the blue dye only. So, and equal sensitivity as radioisotopes. Disadvantages is when there is a leak of the dye from the lymphatic system when you're dissecting, it will soil the surgical field and discolor when you look into the under the ultraviolet light, and this will interfere with the lymph node harvesting. The problem is that the company is not ready to reduce the cost of the equipment as of today. You can see here that this is the lymph node, which is looking very brightly on the ultraviolet light, and the lymphatics can be seen. So you can, when you open up, you can trace these lymphatics and go to the lymph node. You can also map these lymphatics on the skin surface. You can see that the lymph node, this color is what you see on this thing, and when you change the software, you get this color. This color is given by the computer, not you see this actually when you start with. And the lymph node will also be stained like this. So to conclude, axillary lymph node status is an important prognostic factor for patients with breast carcinoma. Sentinel lymph node biopsy has been established as the new standard of care for axillary staging. Sentinel lymph node biopsy allows better staging of the axillary nodes and detects occult metastasis, avoids morbidity of axillary node dissection. Thank you very much for your patience.
Hello.
Thank you, Venkat. That was
Good
a
evening,
great...
Dr. Venkatesh.
Yes, sir.
It was an excellent lecture. I think it is a good for the postgraduates also. And on the chat box, I think we have plenty of questions from our delegates. Have you looking into that, or you want me to repeat the questions?
Sir, most of it is answered by our Nataraj Naidu, one more oncosurgeon. Just please go through, sir. I'll just give a brief intro about my question. Venkat is
about identification of the number of lymph nodes. It is 3 lymph nodes is accepted, is it not? Rather than 5 lymph nodes for the Sentinel lymph node study.
So what we do is we don't go by the number of lymph nodes. We see that at least 1 lymph node. Usually we get 2. On an average, it may be 1.2 to 1.5 number of lymph nodes that are picked up. We are happy even if 1 lymph node, because when we go into the axilla quickly after the blue dye injection, that is 15 minutes later. So you may get only 1 lymph node. If another lymph node is there adjoining it, we usually pick it up and we see for any palpably enlarged nodes or any other odd nodes on the gamma camera to see for if something is missed, because a positive node may be there in the first echelon, but the tumor is so much loading, the node is loaded with tumor that the lymphatics are blocked. Then the lymphatics get diverted and it goes to the second echelon node. So we always feel for the axilla and see whether any odd nodes are there. So 2 lymph nodes we are happy. We don't count by 5 because we send more lymph nodes, the pathologist will take more time, the patient will be under anesthesia.
One more thing is, because most of our centers may not have the gamma camera, whether can we rely only upon the methylene blue dye injection and seeing the blue lymph nodes?
So we initially, myself, Dr. Somsekhar, we all did this at Manipal Hospital. When we studied it, we found that the sensitivity is around 67 to 70%. We could achieve slightly better sensitivity rates, but because of our experience, but still we've always found that when you combine the both of them, that results will be far better. Now with the advent of the ICG technique, if machine one is one-time investment, the dye is so cheap that the patient will not be paying much. It is one-time capital investment for the for the hospital. If you get the ICG technique, it will be easier for you compared to methylene blue.
Venkat, we have one more questions. The pathologist will opine on micro or macro metastasis in a note.
No, the pathologist will opine on everything, but generally micrometastases are very difficult to detect on frozen section because they have to hurry up and they have limited time. But we have seen our pathologists with experience even reporting cells like 6 or 10 or 15 cells. With usually they look close, they will be in the near the hilum, you know, no? The hilar fat gets obliterated first. That is the entry of the afferent vessels. So they have seen even clusters of cells also, but we are not routinely using cytokeratin or the RT-PCR technique for molecular analysis to see for tumors. But our pathologists have picked up small clusters of cells also. But usually, if micrometastasis, as of now, the prognostic value is not proven, you can ignore them and then consider them as almost N0.
Okay, Venkat, is that rule of 5 and 10 still holds good? Rule of 5 and 10, Sentinel.
5 of 5, what?
Rule of 5 and rule of 10. Clement sir, Rajan sir has put it that, okay.
Rule of 5, exactly, the number of nodes or?
No, I'll tell you. Sir has put, Rajan sir has put it in the chat box.
Okay.
Rule of 5 is that injection of blue dye locating sentinel lymph node of breast, 5 ml of blue dye, 5 sides, 5 centimeters of diameter. Okay. And rule of 10
no, we
is...
don't inject 5 ml, we inject 4 ml.
Okay.
1 ml in each quadrant.
Okay.
So we go by the size of the tumor, that is less than 5 centimeters in size, 4 ml of methylene blue. And isotope, as I told you, is like 0.2 millicuries, 0.2 ml.
No, is that more than 10% radioactivity following radio?
10% radioactivity.
Yeah.
No, 10% activity usually we get in the lymph nodes compared to the primary tumor.
Okay.
And when you go inside, the activity will be more, but on the surface, it will be around 10% of the activity. Once you remove the sentinel node, you should look for anything with around more than 10% of the activity seen in the sentinel node. If the sentinel node, like in my video, it was around 1600 counts. If it is anything around 100, 150, you have to even pick up that node also.
Okay. How are micrometastasis dealt with? Radiotherapy?
No, micrometastasis you already removed.
Yeah.
You already removed and found that it is micrometastasis less than 2 millimeter. They are almost equal to N0. They are not to be worried. If the pathologist on the H&E staining, the final report gives us micrometastasis, but in the sentinel node biopsy on frozen section, they gave it as N0. So that is a false negative report, right? So in that case, micrometastasis, you need not worry. You need not have to go back and do active node dissection.
Okay. Thank you, Venkat. Anything else? Any questions? Please put it in the chat box. Either Venkat will answer or other oncosurgeons are there in the group. They can answer. Venkat is he has done his MCH. He has done his MCH onco. He is working presently at Sakra Hospital, St. Philomena's and HCG. He is a professor for DNB at Shankara Cancer Hospital. He is president of our Surgical Society, Bangalore. He is a honorary secretary of Bangalore Oncology Group. He is specialized especially in breast oncology and advanced laparoscopic surgery, OBG. He has presented several papers and posters at national, international conferences. Thank you, Venkat.
Thank you, Venkatesh.
Yeah. Somsekhar sir, can we go to the next presenter, Lakshman sir?
Yes, we will go. So I will...
Lakshman sir also doesn't need any introduction. Anyway, it's a formality. Sir has done his FRCS Edinburgh, FRCS England. He is a consultant in GI and laparoscopic surgeon. He's a associate editor, Indian Journal of Surgery, the faculty, GI Surgery, RGHS. He's a live trustee of BMCDT. He's a chairman, BMCDT, Infosys, BMR. Lakshman sir, it's your time. Sir is talking about downsides of evidence-based surgery. Session is chaired by again Dr. Somshekar SN, Professor JJM Medical College, Davangere.
You can start, sir.
Venkatesh sir, audio ಬರ್ತಾ ಇಲ್ಲ ಲಕ್ಷ್ಮಣ್ ಸರ್.
ಅದೇ ಲಕ್ಷ್ಮಣ್ ಸರ್ ಆಡಿಯೋ ಬರ್ತಾ ಇಲ್ಲ. ಲಕ್ಷ್ಮಣ್ ಸರ್, ಎನಿ ಪ್ರಾಬ್ಲಮ್ ವಿತ್ ಆಡಿಯೋ? ಹೌದಾ, ನೋಡ್ತೀನಿ.
Okay, there was a problem at my end.
Yeah, now it's corrected.
Yeah, I have corrected it. Yeah, thank you. Right. Sorry about that little hiccup. I would like to thank KCSI for giving me this opportunity. Over the last maybe 24 months, definitely during Dr. Suprimat's time, the last 12 months, myself and Ramakrishna have been talking so much about this that perhaps people are justified in thinking that we probably do no surgery but only talk about evidence. But the fact is that both of us are doing surgery, and we are passionate about evidence-based surgery. And having spoken about it so much, I thought it was right that we would also talk about some of the downsides, some of the negative things that is happening, and highlight the current state of affairs as far as evidence-based surgery is concerned. Let me first say that I am in no way having any reservations about evidence-based surgery. That is the only way to go. Even though I am highlighting some of the downsides, I think we should all remember that that's the best we have as of today, and none of us should ever entertain any negative thoughts about evidence-based surgery. And what I would like to do in the next 20 minutes is to say very briefly about what we consider EBS is, what are the current objections to it, and what are the reasons for these issues, and how can we address them. I think the last two are very important. What I'm not talking about are two things, and I would like to specify it now before I proceed. I'm not talking about fraud. Okay, I'm talking about the systemic deficiencies that some of us face in EBS, but I'm not talking about people actually cooking up numbers. Nothing can be done about it other than physically checking the data that people produce, and that's not being done on a very large scale. And the second kind of, call it fraud, or call it a huge setback, was something that came in the news just 10 days ago, wherein even very respected, internationally accepted databases, in this particular instance, it was a database called Scopus, which is run by elsewhere. Even this, to our utter shock, had entertained 300 and more than 300 predatory journals in the database. Predatory journals, by definition, are journals who do not look at quality, who most of the time take money, and without the standard accepted peer review, publish papers purely for monetary reasons. And such journals are completely shunned by researchers. But to the utter shock of most of the scientific medical community, a very reputed database had 300 such journals, and they're acting on it, they're taking them away. That's a different issue. But these are the two areas, actual fraud and certain mishaps in the database process, in the database accrual process, are two things I'm not talking about. I'm talking about what is it that we as clinicians can do to improve the quality of application of evidence-based surgery. Judicious use of current best evidence is the operative word as far as evidence-based surgery is concerned. So you must know what the current best evidence is. So you must know how to evaluate the evidence, and that's where statistics that Ramakrishna spoke about comes into being. Integrating it with individual expertise is again extremely important. Nothing works in isolation. The patient values are important. Your expertise, your hospital's capability, and synergize it, mix it with current best evidence, and you get good evidence-based practice. There is so much written and so much that is around that honestly it's extremely confusing to know what to believe. But then one little indication that one can give is the so-called 4S of evolution of finding evidence. Original published articles, we can't all be reading all the articles that come in the way. One of my best sources to me are review articles in reputed journals which apply standard methodology for that. Evidence-based journal abstracts are again fairly easily available on the internet. The CDSS has not come into being, as of now, it's not very easy, but that would be the pinnacle where I will talk about it a little bit in the end, where you will get a lot of information which is synthesized from well-accepted articles. But then I would reiterate this very famous slide that most people who talk about EBS put up. Anecdotal experiences, in my hands, this works well, I've seen it do very well. It's something we just cannot accept anymore. You need to have data. And what I would all recommend is that at least for the postgraduates and practicing surgeons, what we need to go with the information that comes out of systematic reviews and meta-analysis. Individual, randomized, double-blind, single-blind, whatever, can be done for learning the process of evaluation of evidence. That happens in journal clubs. But for your practice, daily practice, I personally depend a lot on information coming out of systematic reviews and meta-analysis. The single most important thing about all these things that we talk about, which give you the level or the quality of evidence, is peer review. There are many naysayers, just like there are naysayers for evidence-based practice. There are many people who have objections, some of them quite valid, for peer review. But as I keep saying, EBS and peer review are the best things that we have as of today, and we really cannot put them down. So always when you go for looking at some evidence, some evaluation of an article, please make sure that it is peer review. Just a recap for some of us, there are preclinical, stage 1, stage 2, stage 3 trials. Any kind of approval that occurs with any of the approval authorities across the world, be it the FDA or our own drug controller, you must have completed phase 3 trials. Please note that it is extremely important. And it becomes very crucial that we evaluate, before we say that this can be used in a patient, we must evaluate the results from a phase 3 completed trial. Now, clinical application, as I said, comes from completed phase 3 trials, which is important. And many times, particularly in medical oncology, we find that this very cardinal rule is not necessarily followed. But then you also have to evaluate the endpoints. Today, we are talking about quality of life. What do I say by this? If you have a medication that reduces the tumor by 50% at the end of 3 months of a fairly expensive kind of treatment, is it really good? No. I would like the overall survival, disease-free survival, and the quality of life to be better before I accept that particular medication, which just showed a reduction in the size of tumor, for example, as its endpoint. You must evaluate the adverse reactions and costs involved also. Today, people sell their home and their lands and things like that for perhaps gaining 3 months of increase in overall survival. If you really told them that that is all the advantage you have, or if you tell them that the real response rate is 20 or 30%, they may not choose it. So it's very, very important that as ethical practitioners, we include the cost involved in the way we recommend and advocate or counsel our patients. Just another recap again, levels of evidence, go with systematic reviews. The best level is that an expert opinion, as you can see, occupies one of the lowest positions. I keep saying this because even now, in spite of the exhortation by various committees and various bodies, we learn a lot. We think we learn a lot from live demonstrations. You know, we go to workshops, we find somebody who's a very, very, I have no disrespect for them, very expert opinion, you know, expert operating on a particular operation. Never do we ask him, you know, how many have you done? What is your outcome? How many have you lived? Have you matched the world in terms of outcomes, in terms of, you know, operative mortality or cure or improved quality of life or whatever? That should be the question that all of us must be asking ourselves and everybody else all the time. And so we must, without disrespect, we must take an expert opinion with perhaps a pinch of salt. And again, one of the downsides of EBM is this, that we do not actually ask these questions when we look at evidence. Now, you have to ask yourself, are my patients similar to the study group? Classic examples, carcinoma stomach in Japan is very different from carcinoma stomach in India or in the West. You cannot extrapolate Japanese studies onto Indian population. Was the outcome relevant? I mentioned it before. You know, was it relevant in the eyes of the patient? That's another question you have to ask, because that is where the quality of life scores matter. Are my skills similar? Yes, that is something we have to dispassionately question ourselves about. If my skills and my hospital's equipment and my team's expertise, it's not just the surgeon. You know, when Som Shekhar was talking about ERAS, he was talking about a teamwork, and unless the whole system is capable of delivering the kind of care that was described in a given paper, you cannot apply that knowledge and say, this is evidenced, so I'm going to practice it. So where we should really, if you take these precautions and then say that evidence is really helping you, then you then come to the question about what the naysayers are saying. And you will find at the end of the talk that in spite of some value for these naysayers, it's not really a great argument. One of the things that happened was this paper from Ioannidis in 2005, who it can at best be called a very provocative article, where he kept on saying that EBS is abused, eminence-based medicine still persists, and he felt that most of the projects and the funding that comes from the national agencies, particularly in the US and some European countries, was always because of eminence rather than real evidence, and that they were always favoring gamblers. What does he mean by that? He meant that people who project huge successes, even though they don't have data for it, always got the grants. And somehow they did things to make sure that what their projections were actually shown in numbers, which may or may not have been very true. But at the same time, there has been a lot written about the good of EBS or EBM. Many areas have shown improved outcomes. Definitely, the application of knowledge has been very good, and they have really shown that physician behavior does change if you keep saying that evidence is important. There is a bit of a repetition in the next few slides from what I have said before, and that is deliberate, because I really want to highlight the fact that while we keep saying that completed phase 3 trials only should be applied in clinical practice, many times, particularly in medical oncology, phase 2 trials are being clinically applied. And it is not the problem with EBS, it's the problem with the clinician who is applying EBS wrongly. Again, this is not a problem with EBS. Endpoints are not evaluated critically. Today, if you have any paper which does not talk about QOL, does not talk about disease-free survival overall, as well as, and overall survival, then those papers carry much less value. I have mentioned QOL many times because that is something that we need to look out for, and I would strongly urge our youngsters, postgraduates and young surgeons to keep looking at it whenever they look at papers. And look at this this slide, which is a very nice paper that came out. if you look at these metrics to be applied for measuring the quality of a paper, only 26% of trials measured overall survival. Only 20% showed a survival advantage. Only 30% showed improved quality of life. Patient safety was not at all highlighted in many of the papers, but then on those where it was highlighted, nearly half of them had some difficulties. Effect of treatment was exaggerated. What do you mean by this? You can have, if you do not understand statistics well, or if the person who is, putting the statistics forth, putting forth the statistics, if he's not completely true to himself, he can talk about a relative reduction of something compared to an absolute reduction. Relative reduction of any data of the tumor size or a relative improvement is always more juicy and more optimistic than the absolute reduction. The absolute reduction is what we should be looking for. Then again, who are these people who are funding the projects, funding these trials? Many of them come from governments, agreed, but an equal number comes from the medical companies as well. So they end up giving you certain, perhaps unwritten, perhaps unspoken, but there is an undercurrent where they do expect positive results. So what are the things that they can do? There can be a distortion in the design or reporting to favor the products of the sponsors. You can then compare two treatment methods and deliberately choose a weak comparator so that you make the investigational drug or investigational method look a lot more stronger than it actually is. And of course, there are many negative reports that are not reported at all. They just don't, if a trial goes negative, they don't even tell you that there was a negative outcome, so they never publish it, so that it never sees the light of the day. And the difference between primary publication and regulatory documents, even now it exists, but they're trying to bridge the gap, is substantial. So what the journals publish and what the FDA or the Drug Controller of India gets are two slightly different kind of data. And so the requirement of the regulatory authorities must be as vigorous as that of the publication, the journal publication, which is peer reviewed. Now, people are working very hard to correct these deficiencies. Agencies are working on transparency of data. The compulsory registration of clinical trials, CTRI in India and across the world, are very important. They are now insisting on reporting of all results, and there is a worldwide move to improve the teaching of EBS, and they're now making it more interactive and integrated to make sure that it is not as boring as people perceive it to be. And this is something which is again a very good initiative. It is yet to see or reach the common end user, but it will come. It is a concept called the eScope team, which has realized that the amount of publication that is happening is enormous and nobody can keep pace with it. And so this information overload is being addressed by this team who sift through a lot of information and give you a distillate, as a summary of what is truly useful. And that would be extremely useful to the clinicians. So ladies and gentlemen, thank you for your patient listening. I think at the end of the day, when we heard so much of the discussion before this talk, what transpires is that the rules are there, the methodology that has to be followed are there, but they're just not being implemented. Now, if we are all honest and truthful to ourselves, and if we're transparent and try to put our minds together and make sure that we are as scientific as possible, as exemplified, if you may, by the use and implementation of evidence-based surgery, these little disadvantages that I highlighted will take a back seat, and good clinical care will be the order of the day. Thank you very much.
Thank you, Dr. Lakshman, for your nice presentation. I think there are many comments over the chat box. But only thinking what I wanted to tell you is it is easy to talk about the practicing of evidence-based medicine. As I told, because of our very lacking in making the data,
Dr.
we
Somsekhar,
are facing in the first step only.
Somsekhar, I think it
There
is
is an
echoing
echo.
a lot. You may be putting two systems on there in your room. It is echoing a lot. Just put one system off and use one. Yeah.
Hello. Any questions?
So still that echo is there. I think you can log out from one gadget, sir. I think Godhi sir wants to add something. Godhi sir, yeah.
No, I really appreciate what Dr. Lakshman has been saying about the evidence-based medicine all these years, and today is a look at it from a different angle, rather downside of evidence-based medicine, evidence-based surgery. But one point I would like to reiterate here, what he brought out in his talk is whenever our postgraduate students read a journal, they do not ask themselves whether that journal article is applicable to their setting. That is what is missing. We always ask them whether this journal article, whatever is brought out in the journal article, is it applicable to your patients? Can you practice it? Taking into account your individual skills and your team members' individual skills and your hospital equipment and your entire setting and the individual patient. Can you apply this? That is a very, very important point that he has brought out, and I really congratulate him for that. Really good talk, excellent talk.
Thank you, Godhi sir. Please identify yourself. Don't, I'm seeing all this gadgets as administrator. I see 1RBK027. Please rename your gadgets. Please put your name. Don't use all this doctor, all that, administrators, all that. Please mention your name. I see one of the participants is HOAC host 1RBK07. Mr. Administrator is commenting, it is like looking at glass half full and half empty. Which side you want? MBAs decide the future replacing Chitragupta?
Sorry, if it is, my name is not seen there. I've already logged in my name.
Sir, please, you'll have to rename it, sir. It
Yeah.
I'm
Jairam Shanai. I'm Jairam
Yes,
Shanai from Mangalore.
Thank you, sir. Thank you, sir.
Yeah, sorry, because I logged in as Jairam Shanai. Somehow there is some technical problem.
Settings, sir. That
Probably
Zoom
my name
account,
is-
you have to rename that. Your Zoom
I'll
account.
go back after the session and try to do that. Yeah.
Thank you, sir. Thank you, sir. Yeah.
Yeah, because I congratulate Dr. Lakshman about it, because this evidence-based medicine he has been professing, and definitely it is a boon to practice. More, somehow I was a little skeptical in the beginning, because I saw that as a defensive tool to protect ourselves against the litigation. But it comes to help when it in complex situations. But in the absence of an honest peer reviewing, where do we stand in our setup? Because what, as he rightly said, we never ask whether this is applicable to our set of people, because most of the peer reviewed ones, RCTs, systematic reviews, meta-analysis, everything, it comes to a level where the documented articles alone are taken into consideration. Person in a rural setup like ours, in a rural setup, he suppose he has done hundreds of that, and he wants to publish. Unfortunately, today's journals, as Dr. Lakshman himself put it, even Elsevier had some poorly rated journals in their blog, but if he wants to present, it involves a lot of money. And secondly, again, quoting Dr. Lakshman himself, a lot of studies, there is a company bias, the sponsor bias. All these are the downside he has rightly focused. That's why I put it as the positive as well as negative. It's like looking like a glass half full and half empty. Now which side we want to look at it. That's why, that's the explanation I thought. Because wherever we go, we find the MBAs breathing down the neck of the medical professionals, Dr. Lakshman.
So I have to very, very humbly disagree with you. It's not half full or half empty. It is 10% empty and 90% full. Because you know, I did highlight these things, but if you saw my opening remarks was that it is the best we have today. Now, if on the basis of some of these, what I would call aberrations, you do not follow evidence-based practice, then God only help us. Regarding the amount of work, I couldn't agree with you more. We do a lot of very good work, but we do not document. The fault is not that of evidence-based surgery concept. The fault is entirely ours. Why do we not actually keep a logbook, get regular follow-ups, see the patients? Even if you get 60% follow-up, that has been our experience in our retrospective studies. 10 years previously, we would have operated on somebody. We call them, they come and they talk to you. 60%. That is good enough. It's better than not following up at all. And you see that what we see in our papers and the abstracts that are submitted, we only keep a core. I did 30 of these, I did 40 of these. And then what happened afterwards? Nobody knows. And that is something that we should get out of. That system, we have to change, get a regular follow-up of as many people as possible in spite of the deficiencies or disadvantages, but we must produce data.
Yeah, I definitely agree. Fully agree with you.
Jaram sir, your name is changed, sir. Thank you for that, sir.
Thank you.
But I still see one of the iPhones, SKA, something like that. It's okay.
Yeah. Can I invite Rajan to expand on his negative comment? He says sorry. Rajan, if you're there.
Yeah, good evening. It's just that comment came to my mind. It is a fact that a lot of the sponsorship of trials comes with an intent to push a particular product and give a bias towards that product. You've seen it with our meshes and our prostheses that come in. Each company says, okay, you do a study on my product, and out of a courtesy, the bias goes from, say, pain score of 5 will become a pain score of 4. The small little variations are made to help that particular product to come in. It is a conflict of interest which is not addressed, which is not being honest about. When we lack integrity of purpose as a universal phenomena, it is difficult to get truth out of trials. If there is a traffic light with no policeman there, many people cut the traffic light, and as if it is just natural. Now, do you need a policeman at a traffic light? No. But if you have integrity, you will stop at the traffic light. So that is the basis of where all our problems are coming, because the innate honesty and integrity is at a slightly lesser level than we would like in research too. And that's why I keep saying that we have to be very careful when we evaluate these things. Lakshman very clearly pointed out that there are so many predatory journals who are coming out with articles. Now, down the line, these articles are taken up and said, out of the 1,500 studies done, at least 200 will be from these kind of predatory journals. And that skews up the results of what we are going to get. So I am a little concerned. So that comment came into my mind. I could not remember who said it. That's why I put it as anon. And that is why we have to take it with a little bit of, a little bit of understanding that it could be a difficult point to actually be true. Thank you.
If I may add to what Rajan has said, one simple question: the fault is not that of the concept of evidence-based surgery.
Yeah.
The fault is entirely with the medical fraternity.
Correct.
Who have fallen for this. And I can respectfully submit that no system under the sun can really fish out and eliminate lack of integrity. That is something, and I keep saying, Salter gave 8 or 9 I's as the letter I as a requirement for a good researcher, and the top of the list was integrity.
Yes.
Okay, and he had other things like incisive, inquisitive, and so many other things.
Intelligence, yes.
But the intelligent, and the top of the list was integrity, and that is something that we cannot measure, and we have to be our own policemen in putting forth honest data.
Yeah.
Last,
So that when that
Sriram
human
sir?
element exists, we have to be a little worried about the accuracy of data. Thank you.
We'll take a last question. Sriram sir. Yeah.
Yeah, Dr. Lakshman, my question is slightly different. See, we have evidences from years together, 10, 15 years also. But the greatest question is how to bring changes in the surgeon's behavior. You still see surgeons giving tetvac injection before surgery, enema before surgery, or shaving the patient and giving antibiotics for weeks together. How do you bring out the changes even we have great evidence against all these things?
$1 million question. I don't think any of us can answer that, but my submission takes the form of 3 concrete steps. Keep on hammering to the new generation. You know, the seniors perhaps would be too fixed in their ways to even listen to you. But if they do and if they change, that's fine. But that's unlikely. But keep banging away to the youngsters to say that evidence is extremely important. Get those evidences in the form of small capsule and keep disseminating. First of all, they must know that they must follow evidence. What is the evidence? Like you said, shaving before surgery, antibiotic use, all that has to be given in small capsules, not huge lectures, just 5-minute reads. Such capsules have to be disseminated in these present days. It's very easy to all the developing surgeons. And 3, you must insist on audits. Every unit, every surgeon, individual or in any big institution, they must audit their work and show to themselves that they are keeping up with the world standards.
Thank you.
So I'll put those 8 I's, sir. It's incisive, industrious, indigeneity, initiative, innovative, inquisitive, integrity, and intelligence. Yes.
Yeah.
Thank you, sir. Thanks, sir.
Yeah.
Venkat, last
Venkat.
question. Yeah.
Venkat, unmute yourself, please.
Yeah, what I wanted to say is that when the ASA issued guidelines to the whole surgical fraternity to follow social distancing and other things for COVID and many other guidelines, whenever they send, people are following the ASA guidelines. So the ASA can also, like the NCCN guidelines, ASA can always come up with guidelines. They can give the recommendations. Now for oncology, we have ICMR recommendations. It may not be accepted all around the country immediately, but as you told that the next, as the younger people are trained, they will understand and they will practice it better.
Yeah, point well taken.
Sir, can we go to the next session, sir?
Yes.
Yes. Thank you. Thank you very much, everyone.
Thank you, Lakshman. Thank you, sir, Somsekhar sir, for chairing that session. Somsekhar SN sir.
Thank you. Thank you.
Thank you, sir.
Thank you.
It was an excellent discussion. So I call upon Divakar. Can you give a brief introduction of Srinivas Pai, sir? Can I do it or you are doing it? Gadi?
I will do that.
Yeah, I call upon Sopimat sir. Please preside over. And Ravindra Bhathe, Chikodi, consultant surgeon.
Yes.
Both of you chair this session. Dr. Srinivas Pai sir is going to talk about diagnostic laparoscopy in limited resources settings.
Yes. Before that, with the permission of the chair, I would like to introduce Dr. S.R. Colgood. Dr. S.R. Colgood, born in 1932. He was 87 years young. Did his MBBS in Pune in 1954. He did his MS from KA Mumbai in 1961. Served as teacher in Hubballi, Mysore and Bellary. He has worked as superintendent of KMC Hospital in 1981, from 1981 to 86. He took voluntary retirement in 1987. He was a visiting surgeon, German Hospital, Dharwad, undergraduate and postgraduate examiner for several universities. His special interests: hydatid cysts, pancreatic surgeries, fistulas, and piles. He was a pioneer in doing omentoplasty in TAO. He is a life member of ASI and IMA, past president of IMA Dharwad, managed first ambulance services in Dharwad for 15 years. He's married to Srimati Kscasicon. He is blessed with 2 sons and a daughter, 7 grandchildren, 2 great-grandchildren. He's a good singer and he's a revered teacher par excellence. Thank you.
Yeah.
So I'll go on to introduce.
Can I give a brief introduction of the presenter?
Yes,
Do
you have that?
Yeah, I have that.
Please
I'll
go
just
ahead.
read out with your permission, with the chair permission.
Please go ahead.
Yes. Srinivas Paisar is completed his graduation from Kasturba Medical College in Manipal 1995 and MS Generalist from same institution in 98. He subsequently worked as a senior resident at Kidwai, Bangalore before joining Kasturba Medical College, Manipal as staff. He then moved on to SDM College, where he has been working from 2000 till date, currently as professor and head of the Department of General Surgery. Pai's areas of interest include pancreatic surgery, esophageal surgery, colorectal. He has over 14 recent publications in well-known journals and has contributed chapter on carcinoma breast in Manipal Manual of Surgery textbook. Dr. Srinivas Pai has conducted and participated in numerous workshops on topics such as hernia repair, good clinical practice, and oral oncology. He has won awards for his papers and the Best President and the Best Branch Awards from KCSI. He has held numerous academic administrative positions as SDM University, including Chairman, Board of Studies, that's surgery, member NAC Coordination Committee, member Patient Grievance Committee, and Chairperson, Board of Studies, Medical, UG Clinical, Surgical, and Allied. And Dr. Bahubali Gadgade from Pediatric Surgery, your student, sir, he talks a lot about you. It's your time, sir. Srinivas Pai, sir.
Yeah, first of all, a big thank you to the ASI for giving me the opportunity to present this talk in honor of Dr. S.R. Kolgud, a senior surgeon here in Dharwad, the city where I also work. Okay. So I work in a university, although this is a semi-rural area. I work in a tertiary care hospital, and our hospital is under the auspices of the Sri Dharmasala Manjunatheshwara University now. So it is located in between Hubli and Dharwad. So I am fortunate to have equipment because I am in tertiary care. I am having CT scan, MRI scan, 3 or 4 lab sets, and also I'm having the harmonic energy sources. But in India, can I have the previous slide, please? Previous slide. Yes. In India, in our country, even now, there is a unique subspecialty. And this subspecialty is defined on the basis of where they are located, basis of geography, with small population, limited technological resources, and limited contact with other specialists. Next slide, please. Now, this subspecialist, I would proudly call them the truly super specialist, not sub. If the word super specialist has to be used, it has to be used for these group of surgeons who work in limited resources, with limited imaging facilities, and they work quite a distance from tertiary care services. Next slide, please. He is nothing but the rural surgeon, and there are many amongst us who practice in the rural areas of India. Now, Mahatma Gandhi, the father of the nation, rightly said, the soul of India lives in its villages. And it's right, because India is not Kolkata, Bombay, Chennai, or Delhi or Bangalore, not even Dharwad maybe, but it is in the 700,000 villages which exist in our country. And because the population is in those countries, our rural surgeons are important, because if we want to improve healthcare in our rural areas, then we must empower our rural surgeons. Next slide. Now I will slightly shift to Greek mythology, from rural surgery to Greek mythology, about a Pandora's box. All of us would have heard it. See, the box is actually a jar. It contained all the evils of the world. It was gifted to a lady Pandora, and she, out of impatience, opened the box, and out came all the evils. But the last thing to come out, previous slide please. The last thing that came out was hope. So, and then she closed it again. But hope was the last thing that came out. Thank you. Next slide, please. So it originated a term to open Pandora's box. It means to perform an action which is small or innocent, but it has detrimental consequences. Next slide, please. So I always say, what if Pandora had been given a laparoscope? She would have been able to put the laparoscope inside the jar, would have been able to see what is there, evils, and would not have let it in. So, next slide. For the rural surgeon and even for the urban surgeon and the surgeon, let's remove rural and urban both out of it. Why I use the word rural surgeon is limited resource setting is the rural areas of India. So the abdomen is the Pandora's box, and to open the abdomen is the laparotomy, and this may have severely detrimental and far-reaching negative consequences. Next slide. And one more thing, unlike us who work in tertiary care, there is no CT scan, MRI scan, maybe not even an ultrasound for the rural surgeon. Next slide. A 32-year-old male, pain in the right iliac fossa, not classical. Clinical diagnosis by the surgeon was made of acute appendicitis. There was non-availability of imaging. So, am I audible to all, or is it a uniform problem? Am I audible to?
You are audible. You are audible.
Okay. Because there's a message there. So, non-availability of imaging. So, as a surgeon training, they did the McBurney's incision, but then found a carcinoma colon. So, he had to close that, make a midline incision, and he did not do justice to the surgery, although he was quite trained in it. Next slide. Next slide, please.
Just a second, sir. It's getting hanged on. Just a second.
No problem. I'll wait. Just remind me at the 28th minute marker, at the 15-minute mark. So, a female patient, again, they thought it is an acute appendicitis. Of course, no imaging. So, it was a McBurney's incision. It was an endometriosis, actually, a lot of adhesions. In the process, a bowel injury took place. And then from a disease which required medical management, it became an enterocutaneous fistula. So, these are two situations where there was no imaging available. But the surgeon, because of his training and instinct, rightly approached it like an appendicitis. But unfortunately, it turned out to be something else. Could these two situations, there are many situations like this, could this have been prevented? Next slide, please. So, yes, because in the 21st century, all of us have the laparoscope, including in the rural areas. And using a laparoscope, diagnostic laparoscopy, we could have avoided these two scenarios where you would have had a complication. So, the talk today is diagnostic laparoscopy in a rural setting, which is nothing but a resource-starved setting. So, what is diagnostic laparoscopy? It is also called as exploratory laparoscopy. If you do it in cancer, it is called as a staging laparoscopy. It's nothing but a minimally invasive method for diagnosing an intra-abdominal disease and diagnosing intra-abdominal disease through direct inspection of the intra-abdominal organs. So, what is the purpose? Tissue biopsy, pus, fluid, necrotic tissue for culture acquisition. Laparoscopic ultrasonography is not available, but I just put it there for the general audience. And if we need be, you can intervene, you can do the proper surgery. It won't be an unplanned incision. Next slide. Diagnostic laparoscopy will reduce morbidity, decreases post-operative pain. There's a shorter hospital stay and unnecessary referral to tertiary care, which involve a lot of out-of-pocket expenses. Next slide, please. So the pioneer of laparoscopy is Dr. George Kelly. Okay, 1901. He was the first one to do a laparoscopy, but he did it on a dog. Next slide, please. The first human laparoscope was performed by Hans Christian Jacobius in a human, and he also developed special laparoscopic examinations for the same. These are the two pioneers of diagnostic laparoscopy. So what are the indications? Although I have put trauma there, I wouldn't advise in a rural setting to go in with a trauma unless it's really necessary. So the common indications are acute abdominal pain, certain chronic conditions, sometimes trauma. We will not encounter ICU patients commonly in the rural setting, and it's experimental, so we won't go there. And staging of intra-abdominal cancers. Next slide, please. So acute abdominal pain is the commonest emergency anywhere in the world across the rural-urban divide. Throughout it is. It accounts for about 40% of these patients. There is no cause. We don't find a cause. And after more than a week, this patient is labeled as non-specific abdominal pain. Next slide. Classically, what is the teaching in the previous decade or previous century? Open, do the exploratory laparotomy or observe. But this takes a lot of hospitalization time. And somebody has just written, CT scan is there in the rural area, but we can't just go one single rural area. But we have to talk about our entire country. In our entire country, it might not be there. So patients will undergo excessive imaging. And when we open, the laparotomy has nothing, a lot of negative findings. So unnecessarily, we have subjected the patient to an incision. And then this is phenomenon of the impatient-inpatient, where patient every 2 days, every 2 hours wants to know what's wrong with them. And we can't find the cause. And we are scared. If we operate, if there is nothing, so what to tell these patients. So all these problems you are facing. So how will our diagnostic laparoscopy help? It will help us to visualize the entire abdominal cavity. If any intra-abdominal pathology is there, it will localize. We can take the peritoneal fluid for culture or cytology, and then we can irrigate the peritoneal cavity and decrease the contamination. And suppose we are able to do the surgery, suppose it's appendix, suppose the skill level is there for we can go ahead with the laparoscopic appendectomy, or at least if we know the advanced surgery, we can make an incision, proper planned incision, and then go ahead with the specific therapeutic intervention. Next slide, please. So how this diagnostic laparoscopy has helped? How has it helped? Is there any evidence? There is sufficient evidence that it improves the diagnostic rate. It has reduced significantly the number of non-therapeutic laparotomies, the so-called negative laparotomies. It has brought down the number of radiological studies performed. It has reduced the delay in the proper treatment, surgical treatment or medical treatment, and it has reduced the overall length of hospital stay. And the evidence is there, which is an evidence-based review in the journal which is mentioned below. Next slide. There is non-RCT, non-randomized control trial, prospective study of 1,320 patients where early laparoscopy is definitely beneficial in acute abdominal pain. Next slide. There's an RCT even lesser number, however, 522, where acute non-specific abdominal pain, definitely early diagnostic laparoscopy is better than clinical observation. Next slide, please. There is even a meta-analysis of RCT, which supports diagnostic laparoscopy in acute abdominal pain. Next slide, please. What about trauma? See, trauma is a tricky one, especially in an area where we might not have the ICU. So I wouldn't suggest, but if possible, if we have that kind of setting, we can do. So the patient, however, should be hemodynamically stable. Hemodynamically blunt or penetrating injuries are ideal candidates. If they're hemodynamically unstable, then we must not, if we know how to do the trauma surgery, then we must go ahead with the open surgery. However, if done in hemodynamically stable patients, one can get an accurate diagnosis and negative laparotomies are reduced. And there is evidence for that also. So high index of suspicion for intra-abdominal injuries after a negative initial diagnostic workup. We are suspecting there is something, but our classical tests, our clinical examination saying there's nothing, but still we are thinking, so laparoscope will help at that time. In a penetrating abdominal trauma, we are not sure whether there is a breach, whether there is a bowel injury or not. So we open and we may get a negative laparotomy. Definitely diagnostic lap is going to help here, provided patient is stable. If patient is unstable, then definitely there is some injury. Even though there is no evidence of that organ injury, we have to go in and operate. Okay, next slide, please. Diaphragmatic injury is one area where diagnostic lab will help. Okay, next slide, please. Always GA is preferred. Local anesthesia and intravenous sedation has been reported. I wouldn't recommend, but GA is the best way to go about a trauma diagnostic lab. Next slide, please. So what are the limitations? So it takes a long time for us to set up the laparoscopic equipment in a trauma case. And suppose surgery was really needed, it might not be possible laparoscopically, so it delays that surgery. And certain injuries such as bowel injuries, retroperitoneal injuries, we may actually miss. Although I said some time back that when there is a penetrating injury, you can see, but it is sometimes difficult to, we may miss colonic injuries, especially the retroperitoneal ones. Next slide. So when we should not do it, if the BP is less than 90 millimeter of mercury, the systolic BP that is, no laparoscopy in trauma. And don't try laparoscopy diagnosis in when there is a peritonitis, when there is a hemorrhagic shock, and when there is evisceration. That requires straight away laparoscopy. If there is a posterior penetrating trauma, then should not, because laparoscope is limited. And if you are not having expertise with the laparoscope. Next slide, please. Chronic conditions, laparoscopy does help. Hepatomegaly with or without splenomegaly, unexplained portal hypertension or cirrhosis, although this is more in tertiary care setting. So, and non-palpable testis. Next slide, please. Chronic pelvic pain, one more very extremely common problem in the female population in the world. Okay, what is chronic pelvic pain? More than 6 months. It's usually commonest causes endometriosis. A lot of adhesions are there. There may be other reasons to other indications are pelvic inflammatory disease and ovarian cysts. Okay, previous slide, please. Previous slide. About 84% of endometriosis can be directly visualized using a laparoscope. One can also perform the peritoneal biopsy and peritoneal lavage. Diagnostic laparoscopy is similar, highly accurate method for evaluating women with PID, and there's sufficient evidence on this. Next slide. So when overall, I'm talking, so far I have covered where it is done, diagnostic lab. Now I'm going to tell you where it should not be attempted. Okay. So when you're obvious for therapeutic intervention, evisceration of bowel, a stab injury which is bleeding, you know there is a definite perforation there, air under the diaphragm on your X-ray. Now these are the cases where straight away we do surgery. So the contraindications are evidence of perforation, frank peritonitis, known intra-abdominal injury. If you're doing for a complication of a previous open surgery, when there is a shock, when there's an abdominal wall dehiscence, acute intestinal obstruction, if on the X-ray you see more than 4 centimeters, then laparoscopy is foolish to do because it will obscure the view if you're not experienced enough. Okay, it's not standard of care that more than 4 centimeters, you may end up causing another bowel, you may actually end up causing bowel injury. Next slide. If there's coagulopathy, if there is a suspected intra-abdominal compartment syndrome, in trauma with, I already said that again, so again I'll say trauma with hemodynamic instability, or there is a evisceration or presence of bile. Next slide, please. There are some relative contraindications like anterior abdominal wall cellulitis, recent laparotomy. So I will skip this because this is encountered more in tertiary care. Next slide. Next slide, please. So how do we do it? How do we do it? We start by, I'm not going to go in technical details of laparoscopy. I'm sure all those are listening in are very good laparoscopic surgeons here. So we create the pneumoperitoneum either by the closed technique or the open technique. We place the port, camera port, and then if we require, we can put additional ports if we require. So the position, 4 positions: supine position, Trendelenburg position, reverse Trendelenburg position, and then we must be able to tilt it left and right. We must be ready for all this when we are doing this. So supine position is self-explanatory. That's when we put the port. Suppose we are doing for a pelvic pain, then patient should be in supine, should be in lithotomy position. Can I have the next slide, please? So this is the lithotomy position with 15-degree Trendelenburg for pelvic diseases. If you're not doing for pelvic diseases, standard supine position is enough. The reversed Trendelenburg, which is 20 to 30 degrees, why it is done? It pushes the small bowel and omentum away from the liver. So we can access that area. So if you want to see the liver area, then give a reverse Trendelenburg with the 10 degrees to 15 degrees left lateral tilt. Similarly, we should be able to be prepared for a right lateral tilt also with a similar degree. Next slide. So examine the entire peritoneal cavity, the relevant structures, that is gallbladder, appendix, colon, ovary, fallopian tubes. Now the list is endless because the abdomen is Pandora's box, but out of the Pandora's box, these are the common ones: cholecystitis, appendicitis. Okay. So what else we look for? Signs of inflammation, signs of erythema, any fibrinous exudates, any adhesions, any acidic fluid, whether it is clear, whether it's purulent. If it is purulent, we are going to take sample for culture insensitivity. Look for frank abscesses. And then suppose we find, like say, example I'll give you. Suppose we find an appendix. We have all images said no appendix, all our clinical examination gone wrong. Then we go ahead with the laparoscopic appendectomy. If you are not confident with that, then we can do the open also. Thank you. So this is a patient in whom, say, I could have put videos, but I was scared about the streaming when it gets delayed. So I put only pictures. So we put a diagnostic lab and we found an appendix, and appendectomy was done. Next slide. This is in a female, which shows a hydrosalpinx. Next slide, please. Intra abscesses in the pelvis, which we were able to collect a sample and send for culture insensitivity. Next slide, please. Endometriosis. Next slide, please. And this is a undescended testis. Next slide, please. So staging laparoscopy, normally probably in the rural setting, we should not do it. We're better to refer if we suspect it. But even then, suppose somebody has expertise, somebody wants to go ahead, they can do it. So they inspect the peritoneal cavity and examine the liver. Mainly it is for inoperable cancers. Next slide. So we may get a finding like this, like liver with multiple secondaries. Previous slide, please. So we may find this one, definitely, and we can take a biopsy from this. Definitely we know this patient is inoperable, and then we can counsel them. We can tell them that nothing can be done for you. Instead of him going all the way to a city for further treatment, we can tell them, there's no urgency. It's a secondaries. Nothing's going to happen. 6 months is maximum this patient may live. Like that, we can counsel. Next slide. Sometimes tuberculosis or peritoneal deposits. Very good diagnostic tool in tuberculosis peritonitis. So we can get the omental biopsies and we can take the fluid and we can send it for the various modern day serological tests which are available. Sometimes we get peritoneal secondaries which we can biopsy. I think, next slide please. So I'm sure all the surgeons, whether, like I said, the rural surgeon is the true super specialist in India. And I'm sure all of them are very well versed in laparoscopy. So they can use, and I'm sure it's not that expensive to have a laparoscopic setup anywhere in India now. So we can use that laparoscope as a very powerful tool for diagnosis. So in a well-trained hands, it's a very powerful, invaluable tool. It's very easy to train. And even the imaging, suppose we don't have the CT or MRI, somebody has written that they do have CT, MRI. Ultrasound is just an extension of the clinical arm nowadays. But even then, most rural centers might not have this. We avoid an unnecessary laparotomy. Suppose we are not well versed with the surgery, so we can plan better or we can refer it. We do not spoil it for the next surgeon. Suppose we do a diagnostic lab and we encounter an organ which we are not comfortable with operating, then we have not made any big damage. We have just pulled out the laparoscope. We have told the patient inoperable, or I cannot do this surgery. We have to be honest. Previous talk was, there is a lot of talk about being honest. Here's we have to be really honest. We have to tell the patient, okay, I'm not well versed with this anatomy. I have to refer you to somebody else who does it. So unnecessary laparotomy is avoided. It can also, suppose in rural center, many of the surgeons are experts. They can plan the incision properly and do it instead of having put a wrong incision. And unnecessarily referral is avoided. Next slide, please. So I thank you for the opportunity given to me. I thank all the chairpersons who are here and the members of the ASI and all the postgraduates who may be listening. Thank you.
Thank you, Dr. Pai. That was an excellent talk. I think Professor Godi wants to make a comment. Yes, sir, please.
Yeah, I think the patients have become more and more litigant-minded nowadays. And if the rural surgeons are planning to do a diagnostic laparoscopy without getting a CT or MRI or ultrasound even in certain settings, they must take it in writing from the patients that they have been explained about this, and the patients have refused to get an ultrasound or a CT or MRI before contemplating diagnostic laparoscopy. They must take it in writing, because patients are, they have become litigant-minded nowadays. If they are not told, not explained about it, they will always blame that you should have told us that I could have gone to a certain place and get the CT and MRI done. That should not occur.
I agree with Professor Godi's comment very much, because nowadays the information days are there. So we need to give a proper information only in when they can't go or when it is needed to be done immediately, then it's okay. Otherwise, I think we need to have a consent of that form. Yeah. Any other comments or anything?
Can I make a comment, sir? Can I make a comment?
Yeah, please, Dr. Bhatti.
Yeah. One of the things is a very good accompaniment of a laparoscopy set is an ETO sterilizer, I believe. And even in rural setup, it can really help in doing high volume surgeries, an ETO sterilizer. And that's something I think which should be thought of for people who are embarking on laparoscopic surgeries in rural setup. This is my personal experience. The other thing is the problem which a rural surgeon faces is a helping hand. I'm sure a lot of times I felt, oh, I wish somebody experienced is around just to help, in difficult situations and to make decisions. So sometimes in some rural areas, there may not be enough help on hand. Thank you.
There is one question. I think Dr. Naz has put it. Yeah, Dr. Shanai, and after that, you can take by Dr. Naz's question. I think you can read there in the chat box. Yeah, Professor.
I just want to add one thing that in a rural setup, especially encounter a lot of fevers, maybe dengue fever, leptospira, all what has been called as polyserositis syndrome nowadays. And they can just come as a right fossa pain and even ultrasound metal probe tenderness. That's the time where this scope is definitely useful, because what happens is doing an appendectomy for a pain, it may be disastrous in a patient who has got already this kind of fever and etc. Again, reminds the clinical examination, and plus so this is one of the extreme use of a diagnostic laparoscope, rather to rule out appendicitis rather than to diagnose appendicitis. Just my experience, that's all.
Probe tenderness has to be taken with pinch of salt, sir.
Yes, 100%. That's the common finding which you find.
Kilogram of salt, not a pinch.
Why you want to take that question?
First, I will answer Dr. Nas Sheikh question. It is not appropriate. To make it very simple, I don't live in a gray area, black and white, not appropriate. Now, let's say you had a patient goes in and had a torsion ovarian cyst. Let us say you have taken up for appendicitis. You're not supposed to do the surgery. You have to come out of that surgery and then tell the relatives, because that patient has to know that her ovary has to be taken out. So the answer is no. Okay. The patient has the decision. If you are told the patient this could be the possibility, then yes, you can go ahead with the surgery, but better not to take the patient in. That is not on.
I think legally there has been a clear-cut ruling that you should do a procedure only for which the consent has been taken, unless it is life-saving.
Yes, yes.
Only in life-saving situation, of course, it is not necessary that you should have taken the prior consent, then you can go ahead. Otherwise, you should have taken. So better is to cover 2-3, that what you are likely to encounter in, if not appendicitis. So 2-3 conditions you can include and take a consent so that you can go ahead if that condition exists. Otherwise, it is always a difficult call to take that because there is a clear-cut ruling that you can't, even explaining relatives will not protect you. Relatives' consent is not valid. It is the adult patient's consent which is valid, except in children and all that. I think parents' consent is not valid. Yeah.
Sir, one question. Dr. Aruna here.
Yeah, please, Aruna. Yeah.
Yeah, sir. But here the diagnostic laparoscopy is done to find the diagnosis, right? We are not sure whether there is appendix or not. So once we go in with an open mind, then I think whatever the thing is there, we have to do it. Like if it is appendix, I do appendix. If it is a ovarian cyst, I have to do that. If it is
you would have a consent for it, isn't it?
No, you should have mentioned.
No, sir, but the diagnostic laparoscopy is for that, to diagnose a condition, right? In a rural setting. That's what was the purpose.
No, the question was, should we call the attenders and show them?
Yeah, because once we have done a diagnostic lab and we have found a diagnosis which is not according to the clinical idea, then we have to show them. We have to call them, show them, ask them on the table, and then go forward. Because most of the time,
Aruna madam, there is a clear-cut ruling from the Supreme Court also that in fact there have been already this one where they did a hysterectomy to save the patient. It was alleged you have to do a procedure only for which you have taken a consent for procedure.
No, sir. No, I'm talking about a rural setup where we're not sure of the diagnosis. That's what the whole talk is about.
No, it depends on whether the patient, how educated it is patient, how litigant it is.
Setup,
so
right,
that depends on your relation with the patient. For example, in our setup and all that, we can't do a procedure for which we are not explained, we have not taken a consent.
That when you're sure of the diagnosis. So here we are talking about
No, not sure of the diagnosis, but we have to take a consent.
Sopimat sir, can we go to the next session?
Yeah,
can we conclude this? Yeah.
And just a comment, our imaging should be science driven and not patient driven. The moment it is science driven, that issue which has brought up litigation may come down actually, but unfortunately, I go back to the previous talk which I was hearing patiently. All the answers were there in that. Somebody can see the YouTube recording. Thank you. Thank you for the opportunity once more to the scientific committee. Thank you.
Thank
you, sir. Dr. Venkatesh, let me come in here, please. If it were to be a real physical conference, we have presented this scroll to Dr. Srinivas Pai. We'll be presenting this virtually this time. We request him to be present during the inauguration so that he will be introduced to the audience again. Thank you, Dr. Srinivas.
Thank you, sir. Thank you.
Thank you, Chairman. Sopimat sir and Ravindra Bhatte sir.
Thank you.
Thank you for chairing the session.
Thank you.
Can I call upon the next chairman, Dr. Harsha Kodliwadmal, he is a professor, SDM Medical College. Please chair the session, sir. We have two eminent speakers, Dr. Mamta Purantagi from Jain Hospital and Dr. Siddesh sir. He doesn't need any introduction. So can we start with session 3? It is 20 minutes. Endovenous laser surgery. Is it standard of care? So a brief introduction of, can we have our first slide? So Dr. Mamta is a consultant vascular surgeon at Jain Hospital. She initiated the Department of Vascular Surgery at KLE's Heart Foundation, Belgaum and Narayanodayalaya, which is a health city now. Founder, executive committee member of VASCA, which is a society in Karnataka Vascular Society. Will take the privilege of being the first lady to be qualified in vascular and endovascular surgery in the country. It's your time, ma'am. Please go ahead.
Hello, everyone. And I really thank the organizing committee for providing me this opportunity to present on an endovenous ablation, which includes both the laser and radiofrequency ablation of the varicose veins. So before going, I just recollect my olden days when I had presented my first workshop in Hubli, which was the first introduction of laser in northern Karnataka, I believe. And after 16 years, I'm presenting today the outcome of this in our status. So definitely there is a marvelous improvement in the outcome of the surgical laser ablation treatment. So let me start with the chronic venous insufficiency, what exactly we are dealing with. It is mainly the hypertension which is occurring due to the venous walls or the venous wall abnormality. And this is mainly measured or organized, well organized by two important factors in the leg. That is mainly the gravitational erect posture, all the way the hydrostatic pressure from the right atrium to the ankle veins through the blood column, and the muscular compartment pressure, which is transmitted through the perforators and the vein directly to the superficial veins. Next slide, please. So the main pathophysiology being the vascular valvular insufficiency, which is refluxive pathology, which accounts for more than 85% of the venous insufficiency, and the obstruction and calf muscle pump failure is the other cause for the venous insufficiency or the venous hypertension occurring at the ankle level. Next slide, please. So these can occur at 3 different levels, that is mainly the superficial system, the perforator venous reflux, and the deeper veins. Next slide, please. So 3 important categories, what I would like to highlight on is the venous reflux at the superficial venous level. Here the calf usually copes up very well and tries to maintain the pressure at the ankle level. The deep venous reflux or the perforator separately also have got a very good management of the hypertension of the pressure at the ankle level by compensating it by increasing the output, and the other being when the deep reflux and the perforators both are being involved, then the control of the tension or the hypertension at the ankle level becomes very difficult, which cannot be relieved by simple procedures. Next slide, please. Next slide, please. Yeah, depending upon the CAP status of the clinical presentations, we have categorized the presentations in CAP classification, mainly the clinical pathology, clinical evidence, that is the class 1 to class 6, based on the presentation of the patient, all the way from reticular veins, telangiectasias to the more morbid conditions of secondary skin changes with a healed or a non-active ulcer. Depending on the evaluation, we have got CAP classification depending upon the clinical, etiological, the anatomical, and pathological conditions. Next slide, please. Next slide, please. So the basic investigation we are dependent is duplex scan and the IVUS. So Doppler ultrasonography is the basic gold standard, which is being utilized routine. Next, please. Next, please. So this is the gold standard, and the venous reflux for the superficial veins is 0.5 seconds for the superficial veins and 0.1 second for the deeper veins. So the once the diagnosis has been made, and always important to rule out is the May-Thurner's, which can be diagnosed by the IVUS mainly, which is being the intravascular ultrasonography, which rules out the external compression of the iliac vein. So once we come to a conclusion of or the diagnosis is being made, then lies the indication of the varicose vein. What is it? So the refractory or the conservative therapy, when the patient is not responding, then we come for bleeding of the varices, the superficial thrombophlebitis, the lipodermatosclerosis, the venous stasis ulcer, or for the cosmetic causes, cosmetic reasons. Next, please. Next, please. So the treatment or the evolution of the treatment started all the way in the 16th century. And by the end of 1990s, that is by the end of 21st century, the procedure of sclerotherapy, ultrasound guided for the varicose veins, and the laser and the radio frequency was completely evolved, and many of the studies already have been started by the starting of the 21st century. Next, please. So coming to the basic of the radio frequency and the EVLT, the radio frequency is mainly the thermal energy which causes destruction of the venous tissues and at the temperature of 120 degrees. And this energy is in the form of high frequency alternate current. And the specificity of this fiber is wherever there is contact of this fiber, the vein gets denuded. whereas the difference of the laser is it is thermally denaturing character, which causes fibrosis. And earlier it was mainly the 980 or the 810 wavelength fibers, which were utilizing the hemoglobin and causing the fibrotic changes. But now the latest one is 1470 wavelength. Radial fibers are radially emitting and are mainly water absorbing laser fibers. All these are done under ultrasound guided guidance, and all are done with luminescent anesthesia, mainly to buttress the surroundings structures and also to compress the vein to have a better effect of our laser or the radio frequency effect. Next, please. So these are the two monitors which we are seeing here: the laser, the EBLT, the biolytic one, and the closure fast. The only difference between these two is the amount taken by a surgeon to do the procedure. The laser has got 1 centimeter distance, whereas that ablation of radio frequency is about 7 centimeters. So the procedure is more. And definitely there is a difference of adjustment in laser, which we have got different modes in that, whereas the radio frequency has got a single heat ablation and it works up at a single setup. Next, please. So this is the initial process where we are introducing the needle under ultrasound guidance. Next, please. Next, please. The sheath is being introduced over the guide wire and the laser fire being traversed along the long saphenous vein, and the tip of the laser fiber is being located at the SFJ, approximately about 1.5 to 2 centimeter, and the landmark being the superficial epigastric vein, the tributary, first tributary of the GSV. Next, please. Before starting the laser ablation, we always infuse the tumescent anesthesia, as I already told. The perisheath injections of saline has been introduced all the way along the length of the long saphenous vein throughout. Next, please. So this is the fiber which you are seeing, and the vein being compressed by the infusion of the saline at the surrounding sheath. Next, please. Surrounding the fascia, please. Here is the compression of the vein being completely, and the SFJ is completely being obscured with your vision. Next, please. But the femoral vein is clearly seen. Once we start ablating, here is the soap bubble appearance, which indicates the action of the laser fiber being activated. Next, please. So what are the advantages of these ablation? Definitely there is no pain, there is no bruising, there is no bruising occurring, there is no analgesic required, as hardly patients have any pain post or intraoperatively or post-operatively. And already we have given the tumescent anesthesia too, which adds up to their analgesic activity. And the hospital stay is very, very minimal, and most of the times it is done as a daycare procedure, and the incidence of DVT, which is very low, is treated very conservatively. And the subjective satisfaction is excellent with this ablation. Next, please. And all these patients, most of the times, more than 90–95%, they have perforator incompetence, which is being simultaneously treated with the sclerotherapy. And routinely what we use is sodium tetradecyl sulfate, which causes the cell membrane damage, leading to vein spasm with the activation of cell cascade, clotting cascade, leading to sclerothrombosis and fibroblast infiltration, ultimately leading to endoluminal fibrosis. Next, please. And all these patients are placed on compression therapy. The simple ulcers are being given with ulcer stockings. The larger ulcers, layered compression bandages. deeper ulcers being assisted with VAC dressing, and platelet-rich plasma also have been used. Next, please. So let me not go to the deepest points of compression therapy. It overall improves in all the levels of the secondary skin changes which is occurring, and ultimately it reduces or compensates the hypertension. And most important is post-operatively, the compression of the target superficial vein is one of the most important action of these compression stockings. Next, please. So the post-operative management mainly is the follow-up of the treated vein and follow-up mainly for the DVT or the paste. That is mainly the endovenous heat-induced thrombosis which we are looking for, and we look for the clinical, technical, anatomical, and cosmetic outcome. Next slide, please. Here are some of the data which we have collected at JIVAS. So all the way from 2015 to 2019, we have been included all the patients who underwent varicose vein surgery, mainly the laser, radio frequency, or the open surgery. So the total number of cases we have done is 908. Around 240 were laser, and radio frequency was 454. Open surgery, mind it was only 34, less than 5% of the total number of surgeries we have conducted. And recurrence of all these surgeries was less than 5%. Almost 99% of the patients were treated with this sclerotherapy, and additional 21 patients underwent iliac stenting, among which only one patient underwent EVLT. Next slide, please. So most of our patients, more than 56%, were presented in the later stages, that is morbid conditions of lipodermatosclerosis, ulcers or a healed ulcer, and about 47% of the patients were with comorbid conditions. Next, please. So the complications, what we noticed overall was less than 0.88%, each one accounting just for 0.11%. For surgery was hematoma and the left groin infection, which we noticed. And the main important was burn at GSV site, ulcer in the lower leg, hypoesthesia at the lateral aspect of the foot, and DVT was only limited at the SFJ, which was treated conservatively and followed for anticoagulation. And thrombophlebitis was only in one patient. So all the patients were followed up later for the evidence of thrombus extension, or if there was any formal DVT. Also was looked for clinical recovery, the edema, excuse me, please. The lipodermatosclerosis and the ulcer healing, which was more than 80%. The technical, as usual, we never had any detailed thing noted. The anatomical accessory GSV, the perforator recurrence, and the follow-up scans with reablation were treated with reablation or the sclerotherapy. If a short segment of the GSV was involved and it was not was asymptomatic, we left it alone and asked for a regular follow-up. Next slide, please. So some of the studies which quoted would like to highlight on these important things, which was done in 2019. It was a very huge study for 43,000 nearly, with 213 institutions. So they followed for 72 hours, almost up to 1 to 3 months, and looked for the DVT with EHT and evidence of any pulmonary embolism. So the percentage you can very well see, very, very minimal of DVT with thrombosis detection. And according to this study, the early detection of the thrombosis and early anticoagulation administration definitely improved the prognosis. Next slide, please. So this was the study done to look for the neovascularization, and the number was around 148 limbs. The recurrence for the open surgery was only for both was almost equal, but the neurovascularization was drastically different, which showed 18% for open surgery, whereas only 1% for the EVLT patients. Next slide, please. So to look for the efficacy and low complications, a study was conducted in 2017, which was followed for up to 5 years. The endovenous surgery and open surgery, almost the outcome was same, which was around 36 and 33%. And there was no difference between the radio frequency or the laser. But definitely there was a discrepancy in the study because the number of follow-up studies were very poor. But definitely there was a faster recovery rate and the lower complication rate observed. Next slide, please. Next slide, please. Next slide, please. So this was another study which was conducted mainly to look for the endovenous heat-induced thrombosis following EVLT. It was done in the year 2014, and it was a long study of 2004 to 2010. So the total number of E-hit was only 5.1%. Only 3 patients had a well-formed DVT, and only 2 patients with popliteal vein who were done with SSV EVLT. So the treatment of patients all was observation, anticoagulation was very much reserved, and the antiplatelet therapy was carried out in a limited patients. And also the treatment lasted for 1 to 7 weeks. And most of these patients were not put on any anticoagulation. The E-hit after EVLT occurs frequently. According to the study, the E-hit after EVLT occurs frequently, but consists of a very low risk of DVT. Next slide, please. So this is the recommendation where anticoagulation is required. The thrombus extension of more than 50% and the complete occlusion of the superficial deep vein is one of the indications for complete coagulation, anticoagulation. Next slide, please. So definitely with this background, I would suggest 3 important points here. Definitely the ablation is less painful, which has got very minimal bruising, and there is very minimized hospital stay. Whether it is EVLT or RF, they are very well proven modalities with success rate of 96% for the treated vein. And the DVT is a complication with a very low incidence and most of the time self-limiting with rare requirement of anticoagulation. Pulmonary embolism is again a rarest complication which can be taken into account. Definitely, yes. Endovenous ablation, either whether laser or radio frequency, is a standard care for the chronic venous insufficiency when we are dealing with the varicose veins. So with this slides, I would thank my chief, Dr. K.R. Suresh, with utmost gratitude, and Dr. Vivekananda for continuous encouragement. And I thank you again for the organizing committee for providing me this opportunity to present on the chronic venous insufficiency, mainly the ablation related varicose veins. Thank you, sir. Thank you.
Thank you, madam. Thank you for the lecture. It was a very informative lecture. We'll open the session for questions. Bodhi sir has a question, sir.
Dr. Mamata.
Yes, sir.
Good evening.
Good evening, sir. Nice, sir, after a long time.
Yeah,
Thank you,
I have a very simple question.
Yes, sir.
The surgical principle of varicose vein surgery is to tackle and ligate all the three named tributaries of the terminal portion of the great saphenous vein, namely superficial epigastric, superficial external pudendal, and circumflex iliac?
Yes, sir.
Do you also tackle all the three veins, all the three tributaries in the endovenous laser therapy? How near is the laser fiber tip to the terminal portion of the great saphenous vein, namely the saphenofemoral junction? And all the three named tributaries are tackled in this endovenous laser therapy, or some of them are left open? If they are left open, there is a chance of recurrence of varicose veins.
Definitely, sir. We normally at the SFJ we take about 1.5 to 2 centimeter, depending on what mode we are using, sir. And always the tributary of epigastric vein is always identified. And we see that most of the times we include that at our ablation site. And all the way from there we ablate the whole length. So the perforator in between also being tackled along with this laser. Whether it is the lower thigh is also being. And we always have a follow-up study of these patients, whether we are looking for any reflux and also recurrence of the symptoms we look for. If there is any recurrence, even if there is many studies of laser have been shown, there is a reflux at the SFJ, but most of the times patient is free of most of the symptoms, and most of our perforators also being taken care. The symptom recurrence and the comfortness and the subjective improvement of the patient is really good, sir. We would tackle only with the ligation of the SFJ if there is a significant reflux in our follow-up studies with recurrence of symptoms.
Now, my question refers to, not referring to perforators, my question refers to the last three tributaries.
SFJ. That's what, sir. At the SFJ, there
and
are
how
many studies.
do you confirm? How do you confirm that they're also thrombosed?
It is again ultrasound guided, sir, and recurrence of the symptoms. Recurrence of the symptoms in the form of edema, in the form of increase in the lipodermatosclerosis, or the presence or ulcer recurrence. We look for this, and with regular follow-up up to 1 year of follow-up, sir, where we regularly do the screening of the vein and look for the SFJ2, the occluded segment. If there is any dilated vein at the SFJ, we will follow up those patients also. And definitely will tackle only if there is recurrence of the symptoms and subjective improvement is not adequate. In such cases, and most of the case follow-up, we do come across the accessory GSV or the new perforator which is activated. In such patients, we do re-ablation. As I told, the recurrence was in 32 of patients of our studies out of 908 patients. So most of these patients were at the segmental opening recanalization of the GSV. The whole segment of the GSV, which we looked in only 1 or 2 patients, which were re-ablated. And most of our patients were with the accessory GSV or the other perforators, which we had tackled with sclerotherapy, or again, we had ablated the accessory GSV. And rarely we have found the proximal circumflex dilatation of the veins, tributaries of the GSV. Though some patients presented with reflux, but there was no outcome or recurrence of the symptoms in the patients, which we had a regular follow-up for 1 or 2 years following the laser too.
Mamta ma'am, thanks a lot for that. We have plenty of questions in the chat box. Harsha, can you just take 1 or 2? We are running short.
Yes, I think Dr. Naz madam has posted a couple of questions. One is regarding the compression stockings. Madam has asked about how long the stockings need to be worn, and also regarding the cost difference between laser and radiofrequency ablation. If you can answer.
Yes, sir. Compression stocking we advise for 6 weeks to 3 months and with the regular follow-up. Maximum, since our patients are, as the cooperation is too low, we usually insist them for 6 months, which hardly that also they don't follow. But strictly for 6 weeks, definitely yes, is the compression stocking what we normally advise. And second question, sir. Sorry.
It's about the cost difference between laser and radio frequency.
No, it is the same. It is the same. It is the same. Only the surgeon's comfort is more with radio frequency. As I told, the time the radio ablation is for 7 centimeters, whereas that for laser is every 1 centimeter. Otherwise, the outcome is the same.
Mamta ma'am, thank you. There are some leftover questions in the chat box. Please answer them.
Sure, sir.
Yeah,
Sure, sir.
Thank you, ma'am. Thank you.
Thank you, sir. Thank you.
Can we go on to the next speaker?
Yes, sir. Yes, sir. Yes, sir.
Today we had the privilege of the president and the vice president together. President-elect Dr. Siddesh, sir, he doesn't need any introduction. All of you know, we are eagerly waiting for his talk. So, Siddesh, yeah. So, just a brief introduction according to his slide only. It's very simple. He's a chief surgeon and endoscopist, Sigma Hospital, Mysore. Formerly, he was a professor and HOD, Department of Surgery, JSS, my wife's college. He's a student there. Dean and faculty of PG Studies in Surgery, JSS Academy of Higher Sciences. He's the Vice President, Association of Surgeons of 2021. Welcome, sir. Siddesh, sir, it's your time.
Thank you, Venkatesh.
Yes, sir.
Thank you, organizers. Thanks, Supi, Divakar, and Lakshman for having given this opportunity to share some of my views on a current, very relevant topic which we come across in our practice. But what I can say is current guidelines for management of sepsis. I would like to invite some comments at the end with the stalwarts who are present here. I'm sure everyone has the way to manage these things, but there are certain current guidelines which has been evolved depending on the evidence, which I would like to share with and with my experience as well. Next. Yeah, next. Yeah, okay. Certain definitions: life-threatening organ dysfunction caused by dysregulated host response to infection. Is very important to understand. More than the infection proper, it is the dysregulated host response that may be sometimes a over response to the infection and its effects, which can result in cell damage and resulting in the bad effects. Next. Yeah, incidents. We don't have any data as such I was looking out for in our country, but the incidence in US is on a rise every year, but up to 750,000 cases of severe sepsis are reported in US with a mortality of more than 10 to 15%. Next. So again, you will look at the both incidence and mortality of sepsis. The graphs show it matches one of the top in these graphs. So you can see it's a very real major disease causing both morbidity as well as mortality. Next. So infection is something which is the microorganism present in the host tissue or bloodstream producing inflammatory response to its presence. Next. These are some definitions. And sepsis is a subgroup of patients with any infection when it's present with there is systemic inflammatory response. And many of them, they end up with severe sepsis, and small subgroup may end up with septic shock with associated very high mortality. Next. See, inflammatory response can be localized or systemic, and systemic inflammatory response is recognized by next presence of any two of these following parameters, which we all know, which will make a diagnosis of presence of inflammatory response systemic. Next. Septic shock is when there are evidence of organ hypoperfusion and is associated with mortality up to 40%. So that makes this a very important thing. When a patient is in shock, we need to intervene early. Any pathogenesis of any sepsis depends, especially infective cause we should know that the result is secondary to presence of presence of the virulence of the organism, the bacterial dose, and most importantly, impaired host resistance. You know, in the recent pandemic, we have understood that, you know, those patients who had comorbidities were the worst affected than these other two factors. Thank you. Next. So let us talk about the pathogenesis in brief. I don't want to go into the details because that is not my aim here. A nidus of infection will result in invasion of the organisms into the bloodstream, which will result in release of inflammatory mediators and peripheral vascular effects, and also myocardial effect, which ultimately results in poor tissue perfusion and cellular injury, ultimately which results in malfunctioning of the organs and may lead to death. Next. Going with little more into the details, ultimately most of these systemic inflammatory response is secondary to presence of endotoxin in the circulation, and which is seen in gram-negative septicemia or bacteremia, and which results in cellular activation that involves the polymorphonuclear leukocytes, macrophages, lymphocytes, and endothelial cells, which can get damaged, which result in ultimately release of many pro-inflammatory mediators like TNF, interleukin 6, interleukin 1, leukotrienes, and even nitric oxide and superoxides, which ultimately result in cell injury, which is associated with the direct cell injury because of the infection, and also because of the activated cascade of coagulation, which may result in severe sepsis, intravascular coagulation, leading to ischemia of the tissues, result in organ failure. So all these factors act together, the end results will be much worse. So one need to be aware of these mediations or the flow charts which can be kept working. I can go on into the details of each one. I don't think that is the scope of this today's talk. Next. Yeah, the laboratory features which may guide us to the investigations which we need to be looking up, other than those which are directed at identifying the source of the sepsis and etc., which are not going to talk, is the leukocytosis, and in few instances there can be leukopenia and severe sepsis. Deranged coagulation profile, which includes elevated prothrombin time, thrombocytopenia, and fibrin degradation products increase also are some of the parameters. Hyperglycemia is uniformly seen, but in severe terminal stages, hyperglycemia can be seen indicative of associated liver cell failure. Slight raise in the altered bilirubin and enzyme changes can be seen in liver cell failure in terminal stages. Next. Continuing investigation, increase in the blood urea nitrogen and also low arterial pH due to presence of metabolic acidosis. Hence, the estimation of lactate early on arrival and on repeated intervals is recommended. C-reactive proteins and procalcitonin levels are recommended to be done at frequent intervals. Ultimately, the lactate estimation will tell about the cell damage, and procalcitonin levels will tell us about the ongoing inflammatory response. Next. SOFA score is something which all of us should know. I would recommend you would find this chart in any of your, you can go to the net and download, and I would recommend this to be pasted in all the ICU or emergency ward for quick reckoning, and it involves mainly evaluation of the systems like respiratory system, estimation of platelets, estimation of liver function, and then mean arterial pressure, and then GCS score and renal profile. So they have been given scores depending on the parameters of individual system, and they can be added up to assess. These scores can help us in predicting the mortality and severity of the sepsis. Next. Yeah, these are simplified SOFA scores where one can see any two of the organs which are showing derangement or more in the presence of infection shows there is presence of severe sepsis. Next. As I told earlier, the SOFA score, when you add up the parameters individually, can give a score which can also help in predicting the mortality. And when done serially over the next 48 hours after initiating the treatment, then can also help us whether what we are doing is correct or we need to change the type of treatment. Next. Yeah. Quick SOFA score is something which is purely based on clinical assessment, bedside. One can just assess the presence of hypotension, altered mental status, and tachypnea, which can be done as frequently as possible. Any two of these present will show presence of a severe sepsis and can be done on the bedside very easily. Next. American College of Emergency Physicians thought to do something to bring out broad guidelines with a consensus of global campaign. They called it as Surviving Sepsis Campaign. Next. And they called about to arrive at a global consensus. A lot of countries responded to this, and they met first time in 2004, and subsequently every 4 or 5 years they have been meeting and they're revising these recommendations. And the steering committee, which was so formed, has recommended initially a 6-hour bundle and a 24-hour bundle. Next. Yeah, and the same committee further on has brought in what is called as a 1-hour bundle, which includes on arrival measurement of a lactate level, obtaining blood cultures before administering a broad spectrum antibiotic, and a rapid infusion of fluid to resuscitate, and use of judiciously vasopressors earlier when indicated. Next. Going to the details of this, lactate levels on arrival estimation can be done, and then again within 2 to 4 hours they are remeasured. Whatever measures you have taken within the first hour have brought in a change, would have shown by decrease in the lactate levels. That's what your aim should be. And if it is not happening, one need to aggressively re-strategize your management within the first few hours itself. Blood cultures should be taken, at least 2 samples, one from the percutaneous axis, that is blood sample, and also from the previously existing IV line. If it is there, one should take, and then one should take these blood cultures before administering the first dose of antibiotic ideally. Next. So antibiotics profile, I will talk a little later. And then administration of IV fluids, the recommended dose is 30 ml per kg to be administered for the first 3 hours and can be revised later. I will tell the guidelines later. And then the vasopressors has to be thought of within 1 hour itself. If the desired level of mean arterial pressure of 65 or more is not achieved with the infusion of crystalloids, one can think of administering vasopressors early. Next. Initial resuscitation goals. The next 6 hours, what has to be done, what is recommended is establishment of a central venous pressure line, and if possible an arterial line also, and a urinary catheter to be placed to monitor the hourly urinary output, so that you can monitor. These will give a guideline of further infusion of fluids, as well as measures like resorting to ventilatory support. Next. Antimicrobial therapy should be started within the first hour of arrival and should be based on, if you have a hospital protocol recommended by an infection control committee, that should be started, or else using the clinical knowledge of yourself, one should start an empirical monotherapy or a combination therapy. Combination empirical therapy is recommended in neutropenic patients and severe septic patients, and those where you expect multi-drug resistant bacteria causing the sepsis. Next. There are various recommendations which are given depending on the site of the primary sepsis. If you have an indication, one can think of using various combination of empirical therapy. Should be administered. Empirical therapy should be continued for 3 to 5 days, when one should aim at identifying the source of the sepsis and doing an action to control the sepsis and de-escalate as early as possible. Duration of therapy can be extended up to 10 days but sometimes it can be even extend beyond that. Like in case of pancreatitis, necrotizing infected necrosis, one need to give for a couple of weeks itself. Next, depending on the patient. Microbial population present in the human gut, one should have a knowledge of these things, which can indirectly guide you to selection of antibacterial therapy empirically whenever a GI tract is a cause for the sepsis. Next. And there are certain other examples here. Next. So one can follow these guidelines to choose the empirical antibiotic therapy. But in patients who have got where the source is unknown, next, broad spectrum beta-lactam, next please. Yeah, unknown, this one, anti-pseudomonal broad spectrum extended beta-lactam coverage with vancomycin or fluoroquinolone is recommended as an empirical therapy. But again, this needs to be revised every day depending on the biochemical parameters as well as the clinical parameters, and your aim should be to achieve source control again. Next. That's what I say. You should aim to achieve source control. Having given very high combination of antibacterial, one should get committed as a surgeon to find the source of sepsis and control it, because even if you give a very good coverage of antibiotic treatment, these patients can develop, the organisms can develop plasmid mediated resistance within 48 hours, which has been shown. So one need to aim at achieving good source control as early as possible. That is a commitment one should take. Except in patients like in necrotizing pancreatitis, a delay in surgery is recommended as much as possible, up to 3 weeks. But sometimes when it is really necessary, one has to think about performing a percutaneous drainage under radiological guidance. Next. I would like to give some examples here. We can see the presence of a necrotizing spreading cellulitis. This patient arrived in septic shock, where with IV sedation within hours of arrival, having done a fasciotomy, within 48 hours, the patient has recovered. You can see the result. Next. And this patient, you can see the presence of blackish discoloration in the perineum with crepitus, severe sepsis in shock. Once having done a initial resuscitation, within an hour, this patient was taken up in our hospital in the casualty OT under IV sedation with airway control. This patient underwent an extensive debridement. Ultimately, what saved his life is chop, and debridement and drainage of this. And you can see within few days, next, you can see the result. So what saved the life is the source control on arrival, instead of waiting for the lab reports, getting physician reference, controlling diabetes, all that can be done. But what saves life is prompt action of source control. Next. Yeah, being an endoscopist, I get frequent references for patients with biliary sepsis, and you can see what we do is at least drain the biliary system without worrying to treat the cause of the obstruction. Even if you place a good drainage, one can save lives. And see the color of these biliary aspirates, they can vary. It can be a thick pus, a greenish, dark greenish, or blackish bile. And yeah, I term it as drainage of an abscess cavity, not draining a biliary system. So this is how, and most of these patients recover within first 48 hours, whatever antibiotic. Of course, we depend on the further de-escalation depending on the culture of these aspirates. Next. Fluid therapy, I would like to further add a few words. After having started at 30 ml per hour per kg within 3 hours, further our goal should be to maintain 65 millimeters of mercury of mean arterial pressure, and also should keep in consideration the central venous pressure, the cardiac status, cardiac output. One has to do getting a assessment of the cardia by doing what you call get a cardiologist opinion in the ICU itself. One can think of doing a mapping of the cardia, and also looking at the renal parameters. One need to be careful in further fluid therapy. Albumin usage has been recommended in those patients where in septic shock, which are refractory, and 100 to 200 ml of 20% human albumin is recommended in the initial stage. Next. Next. Yeah, inotrope and vasopressins are recommended, as I told, in the initial period itself when indicated. Ideal drug of choice in septic shock is noradrenaline, and sometimes a combination therapy using other drugs have been recommended like adrenaline and vasopressin, but dopamine is discouraged for usage. My intensivist uses dobutamine. Next. Dobutamine in selected patients who have cardiac illnesses, he uses them in combination with noradrenaline. Next. And this flow chart will give a guideline of how one can step up the usage of vasopressor usage and the agents and the dosage, but that can be found in references. But ultimately, it is the clinical response. One has to decide what has to be given and how much to be given. Next. Steroid usage has been generally not recommended. There has not been any strong evidence to suggest that steroid helps in treating the shock, but when it is refractory shock, not responding to fluid therapy and other measures, hydrocortisone in the dose of 200 milligram per day has been recommended and used in some patients. Next. Other supportive therapy, one should know when the patient is in ICU, should take care of further infections occurring by encouraging frequent hand wash, prevention of ventilator associated pneumonia, because when the patient stays for more days in the ICU on ventilator, there can be deaths due to ventilator associated pneumonia, not by the primary infection proper. Blood products, as far as possible, should be avoided unless really when there is an indication, has to be very choosy. Next. Administration of platelets should be used only when there is an active bleed in evidence and or when the platelets drop below 10,000. Otherwise, routine use of platelets in thrombocytopenia is not recommended. Next. Mechanical ventilators. Today, I would say we have come through an era of lot of developments, both in the technology and the technique of using these mechanical ventilation to these patients. Non-invasive ventilators are being used more frequently in my setup. And another important development which I have seen is many patients, our intensivist starts using a prone position. They find better results and early recovery for these patients with sepsis. Next. Weaning protocols had to be drawn out depending on your intensivist. They have their own parameters, and there are certain things which can be kept in mind how to do this weaning from the ventilatory setup. Next. Glucose control is something which has been stressed upon by all, especially to our target should be to aim at keeping the blood sugar below 180 milligrams per deciliter. And in severe sepsis, it is recommended to monitor the glucose level every hour or 2 hourly to have a better result. And it has been found to be advantageous. Bicarbonate usage, if at all is recommended, has to be given very slowly and should not be rapidly given. Next. DVT prophylaxis and stress ulcer prophylaxis, I'm sure all of us are aware, it should be given uniformly for all patients who are in stress, including sepsis, who are in ICU. Nutrition is something which is often neglected. We are aware of DVT, we are aware of peptic ulcer, we give them these treatment, but nutrition gets often neglected. That's what I have seen. And it should be, and you have to pay attention when the patient is in requires continued assistance more than 48 hours in the ICU. One had to think of starting the enteral feed more than the TPN if it is feasible. And if the patient is not awake fully, one can think of administering enteral feed using nasojejunal tubes, which can be easily placed under fluoroscopy guidance. Next. Well, friends, I would recommend if you are routinely getting patients with sepsis, severe sepsis, and you would wish to treat them, you need to collect data, go about studying how to manage these things, go get attached to an institute where you can get to know more how they routinely they manage the septic patients, and then you come back, draw out your action plan in your setup and start practicing it. And not only that, you start analyzing collecting your data and do auditing your data frequently And if you find that your changes which you have brought in has not resulted in much of improvement, go back to your lab, again go back to your seniors, go back to institutes, further refine yourself, come back and start a modified plan of action and start practicing that. Ultimately, it is this approach of revision and re-improvement and meeting the challenge which help in helping your patients. Next. So in future, friends, a collaboration between the emergency medicine and critical. I'm sure many of the teaching institutes have got established emergency medicine departments where early institution, as I told in the first hour bundle, they are well regulated. If you have a very good emergency department established, they can look into it. Or else we need to draw out a protocol how to recognize sepsis early and then institute these protocols early enough to have a good result. Establishing new format to bring in clinical practice change and improve the outcomes. Next. And this is the summary. I can just go back to, but I would like to end by telling one sentence. Next. That is, prompt source control saves lives in sepsis. Think sepsis, act fast. So this is my message for today. And these are a couple of references I could find. Next. Sir, thank you all. But I would like to again stress, it is the early institution of antibiotic, early starting of fluids, resuscitation, vasopressor, enteral feeding, insulin therapy, and avoiding deep sedation, and then lung protective measures. So these are things which can help in bringing out a good result. If you have a 2 minutes time, I would like to, chairperson, sir, I can go for Venkatesh for one.
Sir, then there won't be any question answer, sir, because the next speaker is
No, then I can end. Thank you. I will leave it to the house for discussion. I would be happy than going for my case scenario, which would have given the same message what I have told. Thank you.
Yes.
Thank you so much, sir.
Questions, sir, if there are, Harsha, if there are no questions, sir can give a case scenario for one case scenario, 2 or 3 minutes.
We can go with one. We can have.
Yeah, I will go to the second one straight.
Only one case.
Next slide. Not this. Yeah. Wait, go back. Yeah, we have a 24-year-old female lady, a female with a pain abdomen, loss of weight on and 3 months, presented with acute onset of pain abdomen, fever, vomiting, evidence of systemic sepsis in shock, pallor was present, signs of hypoproteinemia, her abdomen, evidence of generalized peritonitis, dullness in the flanks, and frank evidence of sepsis. So next, what we did next. She was admitted to ICU, started on IV crystalloids, inotropes, dopamine, a combination of norepinephrine and dopamine, empirical broad-spectrum antibiotic therapy, a salvage procedure after doing a time. We went ahead with placing bilateral flange drains under local anesthesia within the first 24 hours. A ventilator support was instituted. Patient was stabilized over next 2 days, but the fever persisted on and off. Percutaneous drainage continued 1 liter per day. Next. Within 48 hours, we started on TPN. So nutrition taken care of, but our physician thought it is an aftermath of a pre-existing tuberculosis in the lung. So we started on streptomycin and amoxicillin, and then in addition to the broad spectrum antibiotic, we waited for 2 weeks with these supportive measures. Patient gradually improved. The drain fell back to 100 ml per day. Patient did not have fever now, but gradually weaned off the ventilator support. TPN has continued because the abdomen was still not very sure of the enteral status, and oral fluids could be started only at the end of 2 weeks. But what happened? Patient was about to be discharged. Patient developed severe pain and was readmitted with the abdominal pain and peritonitis. Next. You see, we did an emergency laparotomy. This patient at this time was fit enough to go through a laparotomy, and we found a perforation with gangrene, and then resection was done ileal. This was tuberculosis, as usual. Then next, so we did a covering ileostomy. So the emergency laparotomy, and that's what. Next. I will end this. So this is what the end result. So what the message I want to say is, even though early source control is important, you have to stage procedure. You have to think what procedure is required at that particular stage. You can tide over the crisis. bail out the patient, then you can plan for a definitive procedure. So you need to be depending on your clinical knowledge, the support of your intensive care, as well as stress on nutrition. These are the messages I wanted to convey in this case. Thank you, Venkatesh.
Thank you, sir. Thank you, sir. It was a great talk, sir. So I thank Dr. Mamta and Dr. Siddesh, sir, for their very good talk, very useful. So, and I thank Dr. Harsha Kodliwatmat from Dharwad for chairing this session. Thank you, Harsha.
There are no questions in the chat box?
Sir, they can, you can answer in the chat box, sir, if there are any.
Okay.
So I call upon the next session chairperson, Dr. Ramappa, is a consultant surgeon from Raichur. Are you there, sir? Ramappa, sir? So I call upon Dr. Muralidhar S. Khatalgiri, the consultant surgeon, Fortis Hospital, Bangalore. This is Dr. Muralidhar and Dr. Ramappa. They'll be chairing the session. And I call upon Dr. M.B. Patil, sir. He is talking about what is rational antibiotic use. Dr. M.B. Patil, he is a professor and HOD, Department of General Surgery, BLDE, Sri B.M. Patil Medical College, Vijaypura. Sir is a gold medalist and topper to the university in MS exams. He has got 24 years of UG and PG teaching. Sir, it's your time, sir. 20 minutes.
Yeah, go to the first slide. Good evening, all. I am privileged to give this talk on rational antibiotic use. As all of us are aware, not only antibiotics, literally everything is used irrationally. So we need to look at the broader perspective wherein all the drugs that are available to humans should be used rationally. But my talk will be limited to rational antibiotic use. Next. As all of us are aware, antibiotics are substances that are antagonistic to the growth of. I'm not able to see the entire screen, sir. Okay. Antibiotics are substances that are antagonistic to the growth of life of other microorganisms. As infection is one of the most important cause of morbidity and mortality. 10 to 40% of the budget in most countries is meant for medicines and a waste of national health budget. Next. Globally, 2/3 of antibiotics used are on animals. In USA, 23 million kilograms of antibiotics are used annually. Global antibiotic consumption, according to WHO data in 2015, is 42.3 billion definitive drug doses, among which 10.7 billion definitive drug dosages are in high-income countries, and 31.6 billion definitive drug dosages are in low-income countries and medium-income countries. Recent studies indicate annually 2 lakh babies die as a result of antibiotic overuse globally. Next. See, it's found that 65% rise in antibiotic consumption between 2000 to 2015 globally. There's a 39% rise in the rate of antibiotic consumption. In India alone, the antibiotic usage accounts for 15.7% of drugs, and in United Kingdom, it accounts for 19% of drugs, which accounts to 40 to 50% of hospital expenditure. In India, antibiotic usage has increased by nearly 30%, according to the Washington-based Center for Disease Economics and Policy. Next. Data published by WHO in November 2018 from 65 countries showed various discrepancies from in terms of definitive drug doses, starting from 4 per 1,000 persons per day to 64 DDDs per 1,000 persons per day. In European regions, it is recorded 17.9 definitive drug doses per 1,000 per day. So there's a lot of discrepancy in the usage of antibiotics among various countries. And it's found that antibiotic resistant infections affect nearly 2 million people and cause 23,000 deaths per year in USA. Annually, more than 50,000 newborns are estimated to die from sepsis due to pathogens resistant to first line of antibiotics. While exact population burden estimates are not available, neonates and elderly are thought to be worse affected. 2 million deaths are projected to occur in India due to antimicrobial resistance by 2050, also because of the irrational use of the drugs. Next. As you can see in this picture, the pharmacy should be towards quality care altogether, use antibiotics wisely. Next. Little bit of history. For hundreds of years, molds have been applied to wounds. The human body, which contains 10 raised to 13 cells, routinely harbors 10 raised to 14 bacteria called as normal microbial flora. In 1928, because of this great person, Sir Alexander Fleming, who discovered a substance called mold juice, later he named it as penicillin. Subsequently, in 1938, Florey and Chair prepared penicillin and defined its systemic effects. Next. Penicillin played a major role in the control and cure of infections till 1970. Subsequently, the effect declined because of risk of the use declined because of risk of anaphylaxis and resistance. Much of the progress in modern medicines has evolved under protective umbrella of antibiotics. Since 1970s, a lot of research led to introduction of newer antibiotics, but due to lack of knowledge and irrational use is causing increasing morbidity and mortality. Next. Because of various factors, the antibiotics are maximally abused drugs leading to irrational use, accounting for nearly 40%. To date, 4,000 antibiotics are isolated from culture of microbes and 30,000 have been prepared synthetically. However, only around 100 drugs are used in practice. The misguided thinking among physicians, healthcare givers, that is better safe than sorry, is absolutely wrong, because what has happened is many times we feel that because the parents pester us or why to take risk, let the patient go home, all right and all, we try to overuse antibiotics and that will result in irrational use. Next. The overuse of antibiotics can cause various complications like antimicrobial resistance, which is the main problem which all of us are facing. The other factors being underuse, inadequate dosing, poor adherence, and use of inadequate drugs. Because of this, across the world, November 18 is observed as Awareness Day for rational use of antibiotics. Greek physician Herophilus told, medicines are nothing in themselves if not properly used, but the very hands of gods if employed with prudence and reason. Next. Okay. What do you mean by the rational use of antibiotics? That's also applicable for rational use of any drugs. Patients receiving medication appropriate to their clinical needs in doses that meet individual requirements for adequate period of time and at low cost. This is according to a definition of WHO Conference of Experts, Nairobi, 1985. Next. Why we should worry much about rational antibiotic therapy? This is basically for the better care of patient, combating antimicrobial resistance, prevent misuse of drugs, to control and decrease the cost of treatment. And having said that, 30 to 60% of patients receive antibiotics, twice of that is needed clinically. Our present WHO Director General, Tedros Adhanom, said, together with our partners, we are stepping up the fight against antimicrobial resistance, one of the most urgent threats of our time. Next. When it comes to rational use, as you can see, handle antibiotics with care, we need to look at certain things. Whether this patient is appropriate. Are we using these antibiotics for the right patient? Is there a proper indication or appropriate indication? Are these drugs appropriate for this disease? Are we doing or going for appropriate administration, route of administration? Then the dose that we are giving, many times we see in the periphery, they take one dose of amikacin, another dose of ceftriaxone, and nowadays we are seeing that people are getting even piperacin tazobactam, 1 or 2 doses they come. So what's going to happen to these patients? Okay, then the duration, and all of us know that lately people are going for no antibiotic policy, prophylactic antibiotics, and sometimes prophylactic and one post-op, and they're cutting down. So ultimately, this is all resulting in decreased use of antibiotics. Whether are we into appropriate combination? And of course, lastly, since especially in our country, being a developing country, because of various cost factors, and as I told you, 40% of the drugs that are used for a patient come in the form of antibiotics. So we need to also look at the cost factor for these patients. Next. We need to follow certain principles when it comes to rational antibiotic use. For example, patient comes to us with fever. Is the fever because of infection? If infection, is it bacterial or viral? If bacterial, what is the organism? Okay, are we into right dose, frequency, route, and duration? And also, we need to look at the adverse reactions. Next. Okay, so when we go for rational therapy, we need to follow certain things, like the instructions need to be given to the concerned physicians, nurses, patients, and also need for completion of treatment. Whether we have made a proper diagnosis. Many times blindly patient is having high fever, we give antibiotics without knowing the source of infection, and aptly told by my previous speaker or Vice President, Dr. Siddesh, wherein he highlighted the role of antibiotics aptly to all of us. And decision regarding guidelines of treatment of various infections, a rigid prescribing policy need to be followed. Next. If you can see here, there are many factors which influence the use of medicines. This also applies for the use of antibiotics. The first one is the intrinsic factors that we usually make a decision. That's whether prior knowledge of the drugs, whether we are aware of the existing drugs available for existing disease. And the habits, many times I feel that levofloxacin is good for urinary tract infection. I feel X and Y Z antibiotic. I always claim, oh yeah, I feel I'm happy, I'm comfortable, I found good results, right? That should not be there. We should always follow certain protocols for which disease, what antibiotics has to be given, has to be rigidly followed. Social and cultural factors, economic and legal factors. Especially in our country, legal isn't into much vogue, but you never know, anybody can go to court saying that we are neglected, we didn't put proper antibiotics and all. And work group is very, very important, because we need to have proper relations with the peers. And since we are all surgeons, we learned a lot of things from seniors, and we need to pass on the skills also. Similarly, when it comes to usage of drugs, especially antibiotics, we should always discuss and plan what is best for the patient. And there has to be proper authority and under supervision. Then workplace. So many times it so happens that because of overwork, workload, and understaffing and all, so we tend to miss the doses. Instead of giving 3 times a day, we end up giving only 2 times a day. And infrastructure, again, that accounts to the staffing and availability of adequate materials. Then information. So information is very, very important when it comes to the drugs. We should be updated about the recent advances, recent launches of drugs. Many times the pharma people come and say, sir, this is very good, this, that, and all. But we should always ask for the booklet about the details of detailed information of this drug, pharmacokinetics, pharmacodynamics, all the details we should read before we proceed and use these drugs. Next. If not properly used, what can happen? Invariably, it will give rise to antimicrobial resistance, adverse reactions, treatment failure, and obviously leading to opportunistic infection. And many times it so happens that the infection is masked. Patient feels okay, but there's an infection inside, deep inside. Next. Yeah, you can see this picture, a very alarming picture. Deaths attributable to antimicrobial resistance every year by 2050. If you can see, this is a survey carried about the antimicrobial resistance. Nearly 4.73 million people are likely to die of antimicrobial resistance across Asia, 4.1 million in Africa, followed by Latin America, which will account around 4 lakhs, then Europe another 4 lakhs, and in North America almost 3 lakh plus. So which is a significant number when it comes to antimicrobial resistance, and this is all because of irrational use. Next. Yes, same thing. Apart from that, so patients, many times it so happens that we prescribe antibiotics for a certain course of treatment. For you just take example of ofloxacin ornidazole for loose motions. They take 1 or 2 tablets, they become all right, they stop the treatment, but they end up in, instead of acute amoebiasis, they end up in chronic amoebiasis. Okay, and another drawback of this is lack of new antibiotics being developed. If you look at the other class of drugs, very few antibiotics are being developed lately. You take anti-diabetic drugs, antihypertensives, so many analgesics and all. That is another drawback which we are all facing. Next. Next. How common are resistant organisms? If you can look here, E. coli in a study done between 2000 and 2007, the UK has seen increasing resistance, nearly 12-fold increase to cephalosporins, 5-fold increase to quinolones, and 3-fold increase to aminoglycosides. And as you can see, the second sentence, MRSA is another resistant organism with a prevalence of 53%. And MRSA, as all of us know, is playing a significant havoc, and many of our patients are getting infected. And you can see here, Staph aureus, invariably 60% of these are now methicillin resistant Staph aureus, and not many institutions or labs are doing MRSAs, but I think it should be made compulsory and rigid policies should be followed. Next. Just going further, enterococci, that is another gram-positive organism which are 10% of our resistance. And I would like to make a note here, Clostridium difficile, which can cause debilitating diarrhea. So it causes CD, AD, and severe disease may lead to colonic perforation and sepsis. And why this happens? Many times we put the patient on some antibiotics, they take for a day or two, then they come to us with diarrhea, loose motions. And we know that it is because of antibiotics. We put them on Sporolac and so many other things, and they become all right. But if you see here, 90% of the infections follow antibiotic use, right? So initially I highlighted the role of the organisms in our GIT. Okay, so in intensive care units and high density units, there's another problem. There always appears to be a unique bacterial flora, and there's a prevalence of antibiotic resistant organisms because of antibiotic history. And already when these patients end up in ICU and HDU, they would have received substantial quantities of higher antibiotics. That will make the things much worse. And by the time patient has come to ICU, already he would have received higher antibiotics. So a surgeon doesn't have much choice to which antibiotic to go, because many times we may have to go for empiric therapy. Next. Yeah, very important. A few years back, there was a lot of hue and cry saying that India is the capital of superbugs and all, but I don't agree with that, because superbugs are everywhere and it's across the world. Only thing is, in India there are no proper studies to identify what is a superbug. A superbug is a type of bacteria that over repetitive exposure to antibiotic drugs becomes resistant to the drugs where it is no longer effective. In US, though data is a little old, at least 2 million people contract superbug a year. Next. How to overcome AMR and choose correct antibiotic? So as I was telling you, there's something called empirical therapy. Empirical therapy is something like, as we always give when you suspect appendicitis, so we always plan a gram-positive, gram-negative, and anaerobes. So the current antibiotics that are followed in a particular institution based on the institutional hospital antibiotic policy, then we need to plan what is called as empirical therapy. So once you operate, send the pus for culture sensitivity, get that culture sensitivity report, then you can always shift to the other antibiotics. Then there's something called targeted therapy. Then the route of administration is very important. Intravenous administration is a must for these patients to control the sepsis. The duration, as I was telling you, it depends on whether we are planning surgery on elective basis or emergency basis, whether it's a clean case or contaminated case or a dirty case. Depending on that, we need to plan the antibiotic. And the most important thing as a surgeon, I would say, is the septic foci. Wherever there's a septic foci, unless we drain it out, we clear it out, so no antibiotic is going to help. And we need to drain this flow. And many times if processes are infected, we need to take them out. And always we should keep a watch on local epidemiology, the epidemiological factors of these diseases. Next. 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 Okay. Next. Okay. In Western countries, to combat these problems, there is something called as antimicrobial stewardship. It's a program offered in most of the developed companies in a step to coordinate the efforts needed to minimize the misuse of antibiotics. Various studies done. There's one Mr. Gujin Surat et al. From University of Würzburg, Germany, in a study from January 2016 to January 2020 found that antibiotic therapy reduced from mean of 6.1 days to 4.8 days for abdominal infection after the stewardship. Post-operative antibiotic therapy decreased from 56.8 to 45.2%. Sartelli and colleagues found that an educational program, this is for the physicians or the surgeons and all the people involved in the care of the patient in general and emergency surgery, found that there's a significant, there had a significant impact on antibiotic consumption rate because of this stewardship. Next. Yeah, 12 steps to prevent antibiotic antimicrobial resistance, starting from below upwards. How to prevent infection? The first and foremost should be to prevent infections. How? Vaccinate, get the catheters out, diagnose and treat effectively by targeting the pathogens, access the experts who are pioneers in these antibiotic policies, use antimicrobials widely. How? Practice antimicrobial control, that is again hospital infection policy, antibiotic policy, use local data, treat infection, not contamination, treat infection, not colonization, know when to say no to vancomycin, stop treatment when cured. So many times it so happens that I give antibiotics for 2 days, patient is absolutely fine, I discharge third day, hernia, I put him on antibiotics for 5 to 7 days. So this, most of us do this we need to seriously look into and try to minimize the use of antibiotics. And lastly, prevent transmission by isolating the pathogen and breaking the chain of transfer of infection. Next. Okay, what are the strategies to promote rational antibiotic use? Okay, we need to follow these 10 steps, which all of us should judiciously follow this. Evidence-based standard treatment guidelines, essential drug list based on treatment of choice, drug and therapeutic committee in hospitals, problem-based training in pharmacotherapy in undergraduate training, continuing medical education as a licensure requirement, independent drug information, that is bulletins and formularies, supervision, audit, and feedback, public education about drugs. So we never give any education to the public about drugs. In this we are failing, so that also we need to look at. Avoidance of perverse financial incentives, appropriate and enforced drug regulation. Next. Next. Let us all be proud to support this initiative, what is called as Be Antibiotic Aware and prevent the irrational use of antibiotics. Next. To conclude, it is possible to achieve a significant change in antibiotic use at the national level. To be sustainable, political, financial support is needed, and there needs to be a multidisciplinary coordinating body with broad engagement of stakeholders. Besides rational antibiotic use, the prevention of bacterial infections and their spread are essential in the containment of antibiotic resistance. Current and future generations should have access to effective prevention and treatment of bacterial infections as part of their right to health. Next. Do not share your unused antibiotics with your family. These are the placards or posters which we need to stick everywhere, even in hospitals. And also, antibiotics are not candies. Don't share with others. Next. Next. Get well soon without antibiotics. Thank you very much.
Muralidhar sir, there are some questions in the chat box. We have 6 more minutes for the question answers session. That was a nice talk, everybody, sir.
Video start.
Can I ask some?
Yes, sir. Shall I, sir? Please go ahead.
Dr. Patil, very good and simple, lucid presentation. Very nice indeed.
Thank you, sir.
I just want to have probably all seniors like during the rounds, my job is only to find out to reduce the number of days of antibiotic, always. That is one. Second thing is, as for juniors and postgraduates, in the hospital, especially breast abscess, moment it comes as MRSA, there's a tendency to put on, vancomycin, etc. But I think we should hold on to it because there are many drugs which are available. So these two things. And lastly, another comment is about healthcare associated infections. These are, these central lines, catheters in the septic area and all, some fungal, infection. And so every hospital, as you are rightly pointed out from the beginning, have that antibiotic policy. That's all my comments. Thank you, sir.
There is a system-wise antibiotics also, sir, along with the institution protocol for antibiotic, like GI system, hepatobiliary, like that. System-wise also there is a protocol, sir.
Can I, Venkatesh?
Yes, sir, please.
No, that's what in my talk also, I try to cut down my choice of antibiotic because MB was going to talk subsequently. It is covered. It depends upon what type of infection you're looking at. See, today we had a patient where the organism isolated came as only sensitive extended beta-lactam antibiotic profile. But there are no clinical signs of spreading inflammation. The ulcer has started healing. The culture as report has come. By that time, there are already signs of improvement. I think there is no role for increasing, stepping up the antibiotic at this level. I think Rajgopal was trying to tell the same thing. So after there is adequate surgical treatment which has been done, I think the antibiotics have a very little role to play. We need to use your clinical acumen more than the laboratory values.
Sir, sorry to tell you this. See, what has happened is more than a patient's indication. Lately, the antibiotic usage is more of surgeon's indication, sir. Because in our institution, we are seeing that some units are following the single antibiotic prophylactic, and some units are not following. But as I told you, we institutions need to have a uniform antibiotic policy where it should define the duration, the choice of antibiotics, and all these things. And I think this should come from the highest level.
Sir, most of it is now NABH, all that, and it is a mandatory to have an antibiotic policy. I mean, an institution.
Yes.
Okay. Muralidhar sir, you want to add something?
Excellent presentation, Dr. Patil. I think it's already pointed out very well, the clinical signs and symptoms are way more important than just the culture sensitivity. We do get, like already pointed out, we do get MRSAs, but when the wound is already healing. So I think this is what we get to be very careful about. And and at the same time, we also need strict regulations for OT, over-the-counter antibiotics. That's something a major issue. I have seen innumerable times where patient just just give one tablet. So 2 doses of antibiotics will be given. So I think the policy-wise, antibiotics should not be dispatched without a proper prescription is something that it doesn't happen. We all know that, but I think that's something that is extremely important aspect.
This happens quite often in pediatric groups, sir, wherein a child comes with a cough or fever and all. Many times, as we know, it's viral. But doctors are forced to give antibiotics because there's a parental pressure. That's why I put it as societal. Yeah. So it does happen.
No, and, even that, and also the pharmacy is dispatching medicines. Cold, cough, fever, diarrhea. 50% of them never come to a doctor for treatment. They would have gone to a pharmacist, and a good percentage will never come. So that's also another reason why we are seeing a more of resistance. And what is also interesting point that I have noticed some time back is it is turning back in circles. So I am finding a lot of cotrimoxazole sensitivity of late. We are getting a lot of bacteria which are sensitive to cotrimoxazole, and I've had fantastic responses with simple cotrimoxazole. Some of the infections, I really didn't have to go any big antibiotics. So
another thing, sir, because we have Dr. Sudesh and all the other seniors here. See, like if you in US, if a person has to buy antibiotic, he can only take it from India when his relatives come here. So see, very few drugs are available over the counter there. So recently, my relative came and she took a good amount of antibiotics. So that is really appreciable and it is good. which will eventually reduce these all these irrational use, antimicrobial resistance and all.
MB, on the other side, when I visited US, I was carrying antibiotics, which I gave it to my relatives there.
That is wrong. That is wrong,
The other way.
With the permission of the chair, can
Sir,
I?
don't mention
Yes,
it, sir.
please.
This is a
Yes,
national
please. I
forum
think
which is live
will-
on YouTube.
Sir, we
Everything
will.
is online, sir.
Yeah.
Getting
Ask a
recorded. Paisar, Srinivas Paisar.
Yes, sir. Please.
There's a unique
Last
problem
question.
in medical college. There's a department of emergency medicine now. I'm sure all of us have the problem. These guys follow American guidelines. Put the highest antibiotic which comes, which is very difficult to de-escalate. Anybody can share, is everybody having the same issues or is it unique to only me?
Sir, like we do have emergency department and recently we have started post-graduation.
Patil sir, we'll conclude this. You can just
we'll go to the
answer in
next
the chat box if there are any questions. Thank you.
We'll go to the next session.
Thank you
Patil
very
sir.
much, sir.
Yes,
Excellent presentation. Thank you.
do we have Ramappa sir also here, the co-chairman from Raichur? It's okay. Jaka, Rajshekar Jaka is my friend. Okay, I'll just give a brief introduction about Rajshekar Jaka. He's talking about current treatment of OG junction cancers. Jaka is from our Surgical Society, Bangalore. He is a consultant surgical oncologist and a robotic surgeon. He's head the Department of Surgical Oncology, SS Perch Hospital, Bangalore. Jaka, it's your time, 20 minutes.
Yeah, thank you very much, Dr. Venkatesh. I thank the organizing committee and everyone for giving me this opportunity. Yeah, the current management, first we should understand what is esophagogastric junction. We all know that it is a histological transition from squamocolumnar junction between the esophagus and stomach. But in clinical practice, what we see is this tubular esophagus changing into the longitudinal folds of the stomach. Next slide, please. Next, please. Yeah, but all over the world, we follow this CWAT classification, which is very standard. And it says any tumor within 5 centimeter on either side of Z line, whether into the esophagus or into the stomach, are taken as G junction tumors. And it is classified as type 1, which is 1 centimeter above Z line to 5 centimeter into the esophagus. And 1 centimeter above and 2 centimeter below this Z line is type 2, and 2 centimeter below to 5 centimeter into the stomach is type 3. Previously, it was classified in AJCC 7th edition that all these were included in esophageal cancers and treated like esophageal cancers. But in 8th edition, the CWAT 3 is classified as gastric cancer and treated likewise. Next. I have put this slide so that we can understand a little more better about hereditary, which we usually neglect. And there are a few hereditary factors which will lead to this G junction tumors. That is Palmar-Plantar keratosis, that is related to RHBDF2 gene. And the important thing is we should start screening the family members from endoscopy with upper GI endoscopy at the age of 20 years. And the next one is familial Barrett's esophagus. Though the definitive gene is not identified, but here also the family members with GIRD symptoms should be started screening from the age of 40 years. And the third is Bloom syndrome. Here also we have identified a gene, and the family members needs to be screened as early as 20 years from with upper GI endoscopy. And even in Fanconi's anemia, we need to screen the family members with this. Next. Now we need to understand to manage this tumor, the basically T1 and T2, which is more important because that differentiates the management here. T1, as we know, it involves the mucosa and submucosa. T1A is only mucosa and T1B is submucosa, and T2 is muscle, and on T3, T4, and it goes on like that. Similarly, in the lymph node category, N1 is involvement of 1 to 2 lymph nodes, and N2 is we have 3 to 6 lymph nodes, and N3 is more than 7 lymph nodes, 7 or more than 7 lymph nodes. Next, please. Why this is important is, we can do a direct surgery here, G junction tumors, when it is T1A, B, and up to T2, that is T2 low risk. When we call T2 low risk, when it is N0 and less than 3 centimeter, and it is a well-differentiated tumor. But if at all it is anything more than this, then we need to give pre-operative neoadjuvant treatment. It can be chemotherapy if patient is not that fit, or it can be chemoradiation. Chemoradiation in the recent trials have been shown to be better than just chemotherapy. And the standard chemotherapy which we follow is FLOT regimen now, 4 cycles of chemotherapy followed by surgery and then 4 cycles of chemo. Or else if at all we are considering chemoradiation, then chemo with radiation. We consider when it is T2, that is muscle involvement of the esophagus, and it's a high risk category, that is lymphovascular invasion is present, more than 3 centimeter of tumor size, and it is poorly differentiated, or higher above this, that is T3, T4 and all this, and any lymph node involvement should be treated by chemoradiation preoperatively. And after 5 to 7 weeks, you assess with a FDG PET CT scan to know the response and take a call of next treatment. Now, surgery is the mainstay. It can only give the overall survival, which is maximum. So all tumors should be considered for resection if they are resectable. T1A, only mucosa. Sometimes we consider this endoscopic mucosal resection, but otherwise in all practical purposes, esophagectomy. And T1B, that is from submucosa involvement, it is a standard procedure, that is esophagogastrectomy or esophagectomy. And T4A are also resectable. If they are involving pericardium, pleura, or peritoneum, we need to resect that also. The only unresectable tumors are when it is T4B, like involvement of heart or great vessels, or multi-station bulky lymphadenopathy, or there is a supraclavicular lymph node involvement, or if there is a distant metastasis. So this esophagogastrectomy, we have different surgical approaches. It can be Iverly's esophagogastrectomy, where we first do laparotomy and then right thoracotomy, or McEwen, where right thoracotomy followed by laparotomy and cervical anastomosis. Transhiatal esophagogastrectomy. Each thing is used in a different setup according to the risk of lymph node involvement, which I subsequently will tell. And now, because of minimally invasive surgeries like laparoscopy, thoracoscopy, and robotic, the morbidity has really come down. Next. This is what we need to know. Mediastinal lymph node metastasis. We see the mediastinum is divided into upper, middle, and lower azygous vein and inferior pulmonary vein that divides it. And upper esophageal mediastinal lymph node, see, the involvement of that is very less if the tumor is less than 4 centimeter. Even middle mediastinal lymph node involvement is very less. But if at all the tumor is more than 4 centimeter, all upper, middle, and lower mediastinal lymph nodes are involved. This indicates that if tumor is big enough, we need to clear all the lymph nodes in the upper, middle, and lower. So you need to do thoracotomy, or you have to go into the thorax with the minimal invasion to clear all these 3 stations. But if at all tumor is very small, probably you can get away with the lower mediastinal clearance. Next. See, this is when do we do lymph node clearance? When we suspect that the involvement of this lymph node is more than 10%. Sometimes 5 to 10% also we do lymphadenectomy, but when the suspicion is less than 5%, the risk is less than 5%, we usually don't do lymphadenectomy. These are all according to the recent multi-center studies. Next. And one more interesting thing is when it is a squamous cell carcinoma, the involvement of mediastinal lymph nodes is very high. So we need to clear all 3. So we have to go transthoracic. But when it is adenocarcinoma, the involvement of is very less. So then we choose whether to go for upper or middle mediastinum or not. Next. Here is a brief report of few studies which have reported that mediastinal lymph node metastasis. In CVAD 1, there is 46%. But in CVAD 2, it is 30%. And CVAD 3, it is very less. That is only 9%. So in CVAD 3, probably you don't have to do upper and middle mediastinal lymph node clearance. So that is how we have to approach our surgical this one. Abdominal lymph node metastasis, you see that most of the abdominal lymph nodes are involved in CVAD 1, 2, and 3. So accordingly, but the station of lymph nodes which we remove differs. In CVAD 1, we don't remove in the distal part. In CVAD 2, we remove, we go a little deeper, like hepatic, common hepatic, celiac, and splenic artery. Along with that, all the lymph nodes are removed. And in CVAD 3, all the lymph nodes around the stomach are removed because there is a high rate of abdominal lymph node metastasis. Next. So according to the recent guidelines, at least 15 lymph nodes needs to be removed. for an adequate staging. And 5-year survival rate, if there is a METs of upper and middle mediastinum, is only 16%. So it's very important that we recognize this. And length of esophageal invasion, this is very important. If it is more than 3 centimeter, there is a high rate of upper and middle mediastinal metastasis of the lymph nodes. So we need to address upper and middle mediastinum. And whenever there is a celiac lymph nodal involvement, we have to address along with the surgery, either chemotherapy or radiotherapy. Next. Now, this is an important thing which is ongoing debate. Now, there are some trials which are going on. Should we dissect para-aortic lymph node? Only in severe type 2, there are so many papers which say that it directly goes to lymph node 16A, that is para-aortic lymph node between upper margin of origin of celiac artery and lower border of left renal vein. There is a 14% rate of involvement. So we need to address this. If at all it is severe type 2 and imaging is showing that there is something wrong over there, because it is an important prognostic marker also. So there is an ongoing trial which is going on in Japan. Next. Now, another surgical aspect is, apart from lymph node, if it is clinically T3 or N+ lymph nodes are involved, always preferable to do staging laparoscopy and take a peritoneal wash, because sometimes we may have peritoneal micrometastasis and cytology may come positive and suddenly it goes for stage 4. And as usual, feeding gynostomy for post-operative nutrition, because it's a very major surgery. So we can't wait. Patient needs to be nutritionally good for the anastomosis to heal better. Otherwise, there will be a lot of morbidity. Next. So this is a brief algorithm which really explains very well. This is followed in Japan, and there is ongoing trial also. If the epicenter of the tumor is 2 centimeters above and 2 centimeters below the G junction, classically Sievert 2, but they have taken 1 centimeter above. And clinically stage 2 and more, if at all you are considering a curable resection, then if it is squamous cell carcinoma, you have to go for right thoracic approach, because you know that squamous cell carcinoma involves upper, middle, and lower mediastinum lymph nodes. But if it is adenocarcinoma, then comes how to go about it. If esophageal invasion is more than 3 centimeter, we know that upper mediastinal lymph nodes are involved, so right thoracotomy approach. And if esophageal invasion is less than 3 centimeter, but imaging is showing that there are already lymph nodes, then again you have to go with the right thoracic approach. But imaging doesn't show any upper and middle mediastinal nodes, and less than 3 centimeter tumor, you can still get away with transhiatal, because you can dissect only lower mediastinal lymph nodes. So these are the lymph node stations which needs to be dissected when we do transthoracic or transhiatal, this one. Next, please. So the type of surgery depends on the Sievert type. Basically, which lymph nodes you want to address in the mediastinum and which lymph nodes you want to address in the abdomen. Sievert type 1. Now, mediastinal lymph node addressing, we have to address upper, middle, and lower. So right thoracotomy approach. And in the abdomen, it goes to 1, 2, that is cardiac level, right and left gastric level that side, and 19 and 20, that is infradiaphragmatic and the hiatus where the esophagus enters into the thorax, that is 1920 is must in all the surgeries. But the amount of stomach we remove is only partial gastrectomy or proximal gastrectomy, because lymph nodes metastasis is only superior. When it comes to Sievert type 2, now we have to divide this, whether esophageal involvement is more than 3 centimeter or less than 3 centimeter. More than 3 centimeter, we know upper and middle mediastinal lymph nodes are involved. So again, right thoracotomy approach, and we have to clear the lymph nodes. Less than 3 centimeter, transhiatal can be taken, because only lower mediastinal lymph nodes need to be cleared. And abdominal, again, it is partial gastrectomy, that is proximal gastrectomy. But here we need to clear the left gastric, common hepatic, and splenic artery lymph nodes. And if it is Sievert type 3, more into the stomach, then the thoracic approach is transhiatal, because we can clear lower mediastinal lymph nodes with this. But abdomen, we have to clear whole lymph nodes all around the stomach, right, left gastric, right gastropyloric, greater curvature, lesser curvature, everything. So here total gastrectomy is required so that we can clear all the lymph nodes. Next. So each approach has got a different advantages and disadvantages, right? Transthoracic approach, we can dissect upper mediastinal lymph nodes and we can get a sufficient proximal margin. And disadvantage is surgical stress and intraoperative, you need to change the position of the patient. Left thoracoabdominal, though you don't have to change the position of the patient, but usually upper mediastinal, middle mediastinal lymph node approach is very difficult in this case. So most of the times we don't practice this now. And transhiatal approach, yes, here surgical stress is significantly less. Intraoperative change in body position is not required, but lymph node dissection is very poor in this. Each one has got its own advantages and disadvantages. Next. When do you consider after the surgery an adjuvant treatment? When do you send for adjuvant treatment? In squamous cell carcinoma, if at all you have already given neoadjuvant, if there is a complete pathological response, there is no treatment required. But if there is a residual tumor, this immunotherapy, nivolumab, you can give it. And if there is no neoadjuvant treatment given, and if it's R0 resection, even if there is a tumor present, we put on surveillance. But this is not the case in adenocarcinoma. Next slide, please. In adenocarcinoma, if at all I have treated the patient with neoadjuvant CT-RT, if there is a complete pathological response, there is no treatment required post-operatively. But if there is a residual disease, again, we go for immunotherapy. And if there is no neoadjuvant treatment given, N0, there are no lymph nodes in the specimen which are positive, then surveillance. And if there are lymph node metastasis, then chemoradiotherapy is required. Next. Now, this is an interesting thing. In a metastatic disease or locally advanced disease, we need to do a few more investigations in this. That is MSI, which is done by PCR, or MMR, the microsatellite instability, or MMR by IHC with a simple test, or PD-L1, that is programmed death ligand test for the immunotherapy, and HER2/neu. This also receptor we need to study because we have a targeted therapy. And few patients may have fusion gene, abnormal fusion gene, that is NTRK, tropomyosin receptor kinase, because we have a treatment for this now. Next. So locally advanced recurrent or metastatic cases, MMR interpretation is done by like DMMR. There is a loss of nuclear expression or no evidence of DMMR. That means there is no loss. So these are useful because, see, even in MSI stable, low or high. High, we know that chemo doesn't work, so we have to go for immunotherapy. In MSI stable and low, chemo works. So like that we differentiate. And PD-L1 test, this is for the immunotherapy. If it is positive, even if it is 1%, then we know that we can give immunotherapy. Next. So this targeted treatment, that is, we have newer drugs, ramucirumab, which targets the VEGFR antibody. It is used in adenocarcinoma. And nivolumab, as I said, it's an immunotherapy used in squamous cell carcinoma. And pembrolizumab, this is given for 2 years. In case if it is MSI high or deficient in MMR, or squamous cell carcinoma, which is expressing PD-L1 more than 10%, or adenocarcinoma, which is expressing this PD-L1 even more than 1%, this drug is very much useful. And if there is a gene fusion, which we have found, then entrectinib and larotrectinib are used. Next. This is an interesting thing which I found in recent guidelines, the grading of dysphagia. Grade 0 can eat solid food of any size. Grade 1, they are able to eat solid food only which are cut less than 1.8 centimeter in size and which are thoroughly chewed. Grade 2 is able to swallow semi-solid food. Grade 3 is able to swallow liquids only, and grade 4 is able to swallow, not able to swallow even liquids and saliva. This is important in a palliative setup and also sometimes curative when a patient comes with dysphagia, unable to take, but there is no spread of the tumor. We usually do stenting if it is a palliative case. But curative resection, when it is anticipated, we don't put a stent because there will be a lot of inflammation in the surrounding region. Then we use other methods. This obstruction can be tumor per se, or sometimes the infiltration in the submucosal region can cause a dysmotility of the Next slide. So surveillance. So first 2 years we do with a chest CT, a contrast CT, and chest of the abdomen every 6 months, and endoscopy every 6 months if treated by definitive chemoradiotherapy. Next one. So survival. Now Sievert type 2 and 3. are having better survival than the CWAT type 1. We know that these are the two randomized control trials, that is the Dutch trial and the JCOG 9502. If you look at the 5-year survival of CWAT type 1, type 2, type 3 here, in type 1, you can see that this is either transthoracic or transhiatal. Transthoracic, you can see the 5-year survival rate is 51, but transhiatal survival rate is 37. Though statistically it is not significant, but there is a definitive difference. So there is a significant value change which you can see. So we say that definitely lymph node dissection is going to help in a subgroup analysis. So that is why, at least in CWAT type 1 transthoracic approach is indicated according to this Dutch trial. And even in JCOG 9502, here we have compared left thoracoabdominal and transhiatal. Here it has not shown any difference. Next slide. So what is important? What is the take-home message here is, if at all a tumor is CWAT type 1, then we know transthoracic we should go, and we have to dissect the upper, middle, and lower and abdominal lymph nodes. If it is CWAT type 2, then depending upon 3 centimeter, less than 3 centimeter, more than 3 centimeter, we dissect the lymph nodes and take the surgical approach. And if it is CWAT type 3, then our dissection will be limited to lower mediastinum, and we will be concentrating more on the abdominal lymph nodes. Thank you.
Yes, Dr. Godi.
Yeah,
please, sir.
Are you able to hear me?
Yes,
yeah,
sir.
we are
Yes,
able
sir.
to hear you.
Yeah, go ahead, sir.
Nice talk, Dr. Rajshekhar. Very comprehensive talk on a very big topic.
Thank you, sir.
But I just want to clarify one doubt which I have, is that I heard you talking about a transhiatal approach in a certain indication. But I thought, to my understanding, after the advent of thoracoscopic approach to the CA esophagus, transhiatal approach has taken a backseat. I thought like that. Kindly correct me if I am wrong.
No. You are right, sir. But if at all there is a CWAT type 3 and most of the lymph node burden is on the stomach side, abdominal side, then still we can practice depending upon the morbidity of the patient. If at all we are able to clear lower mediastinal lymph nodes, only then we should do it. If at all we are unable to clear lower mediastinal lymph nodes, then definitely we have to go transthoracic. As you have pointed out, I do robotic surgeries, all esophagus I do robotic surgeries, and most of the cases I do transthoracic because there is no morbidity like open transthoracic. Definitely lymph node clearance is far superior. Means visibility is better, so definitely you will be tending to clear more lymph nodes. So that is why transhiatal is taken a backseat, because now newer modalities have come. You are right, sir.
Thank you.
Mulidhar sir, is there any other questions?
There doesn't seem to be anything in the chat.
From your
Very
side.
good. Yeah. Good presentation, Dr. Rajshekhar. Excellent. Very comprehensive presentation on such a large topic, actually. You covered most of the points.
Venkatesh, if there is if any senior wants to make a comment, because the Rajiv Lochan has not joined.
Hey, he has joined.
He's online.
He has joined. Okay,
yeah,
fine. Sorry.
He's there. I saw him.
Okay, fine.
Dr. Raju is here.
Okay, if he's there, we'll start with his.
We'll go to the next session. Thank you, Dr. Rajshekhar. Thank you very much.
Thank you very much.
Raju sir, are you there?
Yes, sir.
Yeah. Hope you remember me, Surgical Society Bangalore. Recently we had a CMB with you. Yeah. So Raju sir is he has done his MS, MD, FRCS, Edinburgh, FRCS, CCT UK, European Transplant Diploma. He's a lead clinician, hepatobiliary and pancreatic liver transplant surgeon, integrated liver care group, and he's associated with Aster RV and Aster CMI. It's a brief introduction, sir. Everybody knows about you. So please start your talk on current concepts of fluid management in ICU, sir. Yeah.
Sure, sir. Should I share my screen, or is there a screen?
Yes, sir, you can share. You can share.
We are sharing, sir. If there are no videos, we can continue with
sir,
this.
Your comfort. You want to share your thing? You'll be made a co-host.
It says you can't start screen share while other participant is sharing. Maybe somebody needs to.
I think the previous speaker, Jaka, have you logged out?
No, I am here. Only video is. I think.
No, yeah.
You're on. Yeah.
Thing is, you have to close your PPT.
He's sharing. I think Raju's screen is seen.
Screen is seen. Yeah.
So we are sharing.
Dr. Rajiv Lochan, I have made you a co-host. You can share your screen. I'll stop sharing your screen.
Okay,
You
sir.
can do it yourself, sir.
Yeah.
You have 20 minutes. Yeah.
Yeah. Thank you so much to the organizers and all my seniors and colleagues for giving me this opportunity. So after some really high-tech surgery, we're now back to basics. And I mean, this is a particular topic close to my heart, surgical care, intensive care for surgical patients. So my remit over the next 18-20 minutes to just briefly discuss the current concepts of intravenous fluid therapy in the ICU, which is relevant to surgical patients. So I would attempt to just touch upon a few randomized trials. I'm sure a lot of us are aware of these trials, but just to refresh our memory and just drive home one or two very basic concepts of fluid therapy in acutely ill surgical patients. Really, that's my aim. So just to recapitulate, why are fluids administered? Generally, when patients are not able to drink adequate amounts of water, in the surgical relevance, when they are nil by mouth for various investigations, endoscopies, operations, or after operations. And there is also the situation when the gut cannot absorb fluid and electrolytes, when there is ileus, for example, or there's interstitial obstruction. And in another situation, when you need to fill the intravascular compartment rapidly, when there is blood loss, either because of trauma or during surgery, and when there are ongoing GI losses. So these are all various surgical scenarios, in which we actually end up giving IV fluids. Now, so a very common scenario for surgeons, there is an increase in heart rate, there is a low blood pressure, or there's a low MAP, and then there is decreased urine output, and then the surgical response is actually give some fluids. Now, why do we do this? We do this because we want to test the fluid responsiveness of the patient, because we want to know if they're hypovolemic or not. But there was numerous studies have been done which show that only 50% of such patients increase their cardiac output and increase blood pressure, decrease heart rate, and produce urine, generally across the full surgical gamut spectrum of patients. In the remaining 50% of patients, it leads to hypervolemia, which increases morbidity and mortality. This is one particular concept that I want to drive home during this talk. And hypervolemia is something which the body is not evolutionally, equipped with. The human body can deal with hypovolemia by increasing heart rate and increasing stroke volume, but hypervolemia, which is come about because of modern medical treatment, is an iatrogenic problem. And like our intensive care colleagues tell us, it is something that we have actually created. And this is one particular thing which I'll talk later on in the talk. So we all know, the fluid compartments in the body, intravascular, interstitial, intracellular, and 60% of the body weight is made up of water, and the total body water is around about 42 liters. And we know that the intravascular volume is around about 3.5 to 4 liters. Interstitial is 10.5, and the intracellular fluid is actually, forms a very, very large proportion of the water in the body, which is around about 28 liters. And the goal of fluid therapy, in whatever the situation might be, is to actually deliver oxygen to the mitochondria, isn't it? I mean that's exactly the reason why we give fluid, to increase the blood pressure. And if the blood pressure is increased, there is oxygen which goes into the mitochondria, and then the intracellular milieu is actually maintained. And now. One particular concept, what I want to say, and I'm not going to get into the details of the ions moving around, because even I really don't understand them that much. But the important thing is that sodium gives a clue to the volume status. Now, when we administer some fluid, where does the fluid go? I think this is very, very important to know before we can even think of talking about what fluids to give. Isotonic fluids, where the tonicity is similar or slightly more than the body, if you give 500 ml of fluid, 375, most of it goes into the interstitium. And this leads to hyperchloremic acidosis and hypernatremia. Whereas hypotonic fluids, ringer lactate, very well-known fluid, significant amount, goes back again into the interstitium, but it ends up causing metabolic alkalosis, which is actually a little bit better than the hyperchloremic acidosis which occurs. And colloid, as we all know, quite a significant amount stays within the intravascular volume. But hypotonic fluid solutions or maintenance fluids like half normal saline, I mean, this is a fluid which we all have kind of forgotten, I think. So if you give 500 ml of fluid, a large volume of it again goes into the intravascular, but then goes intracellularly and causes hyponatremia and gives a better urine output. And I'll show how that occurs in the coming slides. So just briefly, I just want to touch upon the topic that gut is the motor for sepsis. We all know that, and whenever we cause hypervolemia, there is gut edema and there is translocation, there is anastomotic leaks, and we know that so causing gut edema is not really good. So with this background, now I'll spend the next 10 minutes talking about what fluid to give and sort of how much fluid and what evidence there is for these two ideas. So this is a list of all the fluids that we use in daily practice. This is a slide courtesy of Dr. Chandrasekhar. Quite a few slides here are Dr. Chandrasekhar's slides. He is the lead intensivist in Bangalore Medical College, and now in IGOT, a close friend, and runs the ASPIC course along with me and Dr. Prakash Doraiswamy. So the blue fluid is actually hypotonic fluid, which is half normal saline and dextrose water. I just want to draw your attention to the chloride content in them. It's 77, one of the lowest, and I'll tell you why this is important later. And you look at the hypertonic fluids, which are in yellow, and you can see that the chloride content is really, really high in these fluids. And the hypertonic fluids are 3% saline, dextrose, ringer lactate, 7.5, bicarbonate. Bicarbonate is actually not very good fluid to give at all. But the isotonic fluids, which is normal saline, and the other ringer lactate and plasmolite, they all have a sodium of around about 154, but half normal saline is really good because its chloride is actually less. So now, there is this recent concept of balanced solutions. So all these solutions that we looked at now, are compared against normal saline, which is not a balanced solution. So balanced solutions include crystalloids and colloids with minimal effect on the homeostasis of the extracellular compartment, and mainly with a low chloride content, equal or lower than 110 milliequivalents as compared to sodium chloride. So these are the balanced solutions. So why has saline actually fallen out of favor in the recent past? That's because of these sort of evidences which are there. This is a paper from 1979 in hypertension. Sodium chloride caused a dose-dependent higher degree of acidosis and raised chloride levels, which led to contraction of vascular smooth muscles, reduced renal perfusion, and then kidney injury. This is a reasonably old reference. However, there is new evidence too for a very similar effect. Sodium chloride reduces renal artery blood velocity, renal cortical perfusion, decreases urine output, and causes kidney injury. So this is in Journal of Critical Care just about 4 or 5 years ago. Now, because of this and these other trials which kind of compared balanced solution, one of which is plasmolite, the other one is actually ringer lactate. Ringer lactate is also a balanced solution, but this trial, which was driven by the pharma, obviously used plasmolite and compared it to sodium chloride, and by giving similar amounts of fluid on the first day after major abdominal surgery, and found that there was significantly less renal failure and lower need for dialysis with plasmolite, which is actually a balanced solution as compared to sodium chloride. So this was actually not a randomized trial. Are there randomized trials to, which is one of the highest levels of evidence for us to, talk about this? Yes, there are. There is the SPLIT study, which was published in 2015. This compared plasmolite again, which is a buffered crystalloid, along with the saline. But this was a relatively small number of patients, only around about 2,000 I mean, it wasn't really powered adequately. And this study did not really reduce the risk of acute kidney injury in buffered solutions. However, there was the SMART trial in 2018. This is a very, very important trial, just published a couple years ago. It looked at critically ill patients, about 15,000 patients, and used a crystalloid solution, which is, I mean, it was actually plasmalite, but because of, because it was the NEJM, they did not put in the trade name, and use of a balanced solution resulted in a lower rate of this composite outcome of new renal replacement therapy or renal dysfunction compared to saline. Now, the very same authors in the same journal issue published non-critically ill adults treated with IV fluid in the emergency department. And in this, there was no difference between using balanced solution versus saline. So this is a very important point which I want to drive home here, is that, there was a difference only for critically ill patients for the use of balanced solutions. And in the non-critically ill patients in whom probably the volume of fluid used was smaller, there was no difference in outcome or renal replacement therapy or renal dysfunction. So now what is the place of balanced salt solutions in clinical practice? So, I mean, it is kind of fair to kind of comment that, fluid-induced metabolic acidosis and excessive chloride loading can be reduced by using balanced solutions. And we know that excessive chloride administration has a detrimental effect on renal function, even on low doses. Just 2 liters of normal saline can cause acute kidney injury when used in the immediate postoperative period, as shown in the trials. Therefore, balanced solutions, when particularly in patients who need a significant amount of intravenous fluids, probably patients who are unwell, seems to be a reasonable pragmatic choice. Now, what is the role for sodium chloride, or saline, 0.9% saline? Saline may be an intuitive choice for patients with hypovolemic hyponatremia or metabolic alkalosis. And in any other setting, especially in our situation here in India, where we need to try and reduce the cost, the economic cost is probably, welcome. And even this very big review article in, just a couple of years ago accepted this. However, the important point to drive home is that the patient's serum chloride level and the severity of illness is an extremely important factor to determine the appropriate type of fluid, selection. So I think chloride, to look at in an acid-base, report printout, or even in the serum electrolytes is actually, going to be really, really important for our surgical patients. I will not touch too much on IV albumin. I mean, the role of albumin has been debated quite extensively, and as a maintenance fluid, it probably doesn't have too much role at all. I would draw the attention of the audience to these trials here. There's the SAFE trial, the Crystal, and the Albios, which all looked at albumin. These are all randomized trials, and we use it in the liver setting, especially for hypoalbuminemia, and also to protect the kidneys in hepatorenal syndrome. We use that in the wards, but there's not much evidence to use it on a regular basis. So this is about what type of fluid. Now, how much fluid are we supposed to give? We talked about hypervolemia earlier on, and I think that's really, really important. We need to understand that fluids are drugs. And so the same rules and the same type of stewardship which applies to drugs should also apply to fluids. So the right amount of fluid, the right dose, duration, and most importantly, de-escalating at the right time. So we know that when people are ill, when patients are ill, the first phase is the resuscitation phase. Then there is a maintenance or homeostasis where you support the organ. And then there is a stabilization. These actually overlap. And then there is the evacuation, this was in Bailey-Lau and in Schwartz, this is called the ebb and the flow phases. So now they've given this fancy name as ROSE. And I think this is very important for us to remember all the time. And the first inflammatory insult, we give lots of fluid, and we talked about what sort of fluid we need to give with saline or balanced solutions. And then there is a period of organ support where we give maintenance fluids. And then in the next few days, there is no shock. We need to get the patient back into neutral or negative balance, and then avoid hypovolemia. So this is extremely important. And as this ancient Greek philosopher said, the dose is what makes the poison. And as we say in Kannada, amritano jasti tagondre visha agate. So that's the main problem with IV fluids, I think. De-escalating and withholding fluids when they're not required is actually the most important thing for us, and not to overload the patient. So regarding how much fluid is needed, this question was also answered by a trial, and this was published in the New England Journal of Medicine. So we know that in hypovolemia, tissue perfusion is altered. The same happens in hypervolemia as well. There is edema, intra-abdominal hypertension, fluid accumulates in the lung, there's impaired healing, and people are not able to walk around because they become very heavy. And so avoiding hypervolemia is actually very important. So this was a multinational, multicentric, randomized trial, and this is the very well-known paper. Around about 3,000 patients undergoing major abdominal surgery. They compared a restrictive regimen of fluid versus liberal regimen of fluids during and the first 24 hours of surgery. So what is very important is that if you restrict fluids in the first 24 hours, you end up having patients with acute kidney injury. So there was a significantly higher incidence of acute kidney injury, and the first day positive balance was not related to mortality at all. So we don't need to worry about giving fluids in the first 24 hours of surgery, and having a positive balance up to 2 liters is actually what this trial recommended actually. What is important is that just like in the sort of Goldilocks story, the porridge should be just right. It should not be too hot or too little, too cold. And very similarly, the fluid should not be too much or too little. And finding the right balance is actually what is very important. And therefore, just like our intensivists say, in spite of all these trials, it is still, left to sort of, judgment, when you see patients in the ICU as to what fluid to give and sort of, how much fluid to give. So this is just a brief slide about sepsis patients. And there's one patient with appendicular perforation and another with necrotizing pancreatitis. I mean, the fluid is nearly the same for these, for both these patients. The normal saline about 1 liter to begin with is absolutely fine, and even ringalactate, as long as you're not using too much. But if you can, and the patient can afford plasmolite or stereofundin costs around about 1,000 rupees. Plasmolite is around about 300, I think. Stereofundin is around about 800, 900 rupees, and this compared to normal saline and ringalactate, which hardly costs 20 or 30 rupees. That can be used. And maintenance fluid requirements, this is what it is. I won't go into too much of detail on about this, because this is all common knowledge. But what I want to say is that it's very important to know that a patient can move from one phase to another. So a patient with a appendicular perforation who was resuscitated, becomes stable with inotropes optimized, then he has an operation, but then 4 or 5 days later develops a leak and develops an intracutaneous fistula, and then he goes back to resuscitation phase again. So this is very important to actually remember. So basically, I'm just coming to the end of my talk. So the fluids in a nutshell: if there is hypernatremia and there is hyperchloremia, please avoid normal saline. Ringalactate is better. If there is hyponatremia, and we should avoid ringalactate, and we can use normal saline. Replacement fluids, plasmolite can be used. DNS or ringalactate is absolutely fine. Maintenance, this is very important. So there's a difference between replacement and maintenance. We do not recommend normal saline for maintenance fluids. It should be half normal saline or half normal saline plus actually 5% dextrose. So this is the particular, this particular slide, I will not really go into too much of a detail. So these are the few basic rules, that I just want to, mention. Fluid should be given only when there is an identified reason for it. If the patient is hypovolemic, do not increase maintenance fluids, but give fluid boluses. This is very important. And patient's response should be monitored, and I'm not going to talk into how to monitor that. There's actually lots of ways of doing that. Presence of edema does not exclude hypovolemia. I think this is extremely important. And if fluid administration does not benefit the patient, stop it immediately. There's no point continuing to give boluses and boluses, of more than 1 liter of fluid. And then you've got to think of vasoplegia, the heart being a problem, leaky capillaries, sepsis, and maybe getting the patients on to inotropes early. I'm not talking about inotropes now, because that is actually a completely different area. So if patients not improving, please think of other reasons. So hypotension continues to be a problem. Patient not responding, think of other causes. Sodium gives a clue to the volume status of patients. Balanced solutions are better than normal saline, generally speaking. Well, we should not say normal saline, actually. We should say saline. In well-resuscitated patients, you need to use the SVR and fluid challenge test before giving fluids, and only 50% of patients respond to fluids with increasing cardiac output. And I just want to acknowledge my intensivist colleagues, with whom we work every day, Dr. Prakash Doreswamy and Dr. Chandrasekhar, who helped me in making this talk and contributed lots of slides. And they're also a part of this ASPIC course. We did hold this course last year, but this year we probably will do it in an electronic format, or maybe do it physically once, because there's lots of hands-on involved in this course. And and it was supported by the ASI Bangalore City chapter last year, and I'm very grateful for that. Thank you so much. If there are any questions, I'll be happy to answer.
I think Dr. Ramappa sir, you're the chairman for this session. Do you want to coordinate, sir? There are some questions in the chat box. Murli will take up. Ramappa sir, you want to ask some questions?
Dr.
You can unmute yourself.
Yeah, you have to unmute, sir.
Yeah.
Ramappa sir.
Please unmute Madi. Ramappa sir, unmute yourself. On the mic irutte nodi adu unmute Madi.
Sir, good evening. Nice presentation. Sir, this IUPIDS question to Dr. Rajiv sir.
Yes, sir.
See, the old teaching, sodium stays, potassium flees in early post-operative period.
Yeah.
So it's a nice thing you have brought out. So what is the ideal fluid, particularly in GI surgery, post-operative anastomosis has been done?
Yeah. So I mean, basically, balanced solutions are ideal for actually maintenance, sir. So basically, what we use is actually half normal saline or plasmolite. We alternate them. And ringalactate can also be used. So for maintenance fluids after any major abdominal operation, we would use balanced solutions, not 0.9% sodium chloride, but half normal saline or plasmolite if the patient can afford it, and ringalactate too.
Yeah. Because following the GI anastomosis, because of the mineralocorticoid effect, usually they go for sodium retention, then sutural edema, leak, all these things are there. So what is your advice, which eye fluid you would like to?
Yes, absolutely. The half normal saline is absolutely fine, sir, because the sodium chloride content in that is very low, and the chloride content is also low in that. And that would be very good. I mean, ringalactate too. So basically, the idea is that along with sodium, chloride is becoming very, very important, and having too much of chloride can cause renal dysfunction, and that also leads to accumulation of fluids, accumulation of water in the body, because the kidney is not working fine. So that's another very, very important thing. And the fluids that we mentioned, just now, the balanced solutions, especially half normal saline, ringalactate, their content of chloride is low. Ringalactate has kind of fallen out of favor because of the word lactate in it, and the assumption that it has lactate and it causes problems. But it's actually a great fluid, and it has low chloride in it, and we do use it quite a lot.
Oh, nice, sir. It's a nice presentation. Thank you, Dr. Rajivji. Thank you. Thank you very much.
Sir, you take this compliment. Your presentation was crystal with crystalloids.
Dr. Rajiv, great presentation. There are a couple of questions there. I think we are almost running short of time, are we?
Yeah, please go ahead with 1 or 2 questions in the chat box. Sir will answer in the chat box.
We still have 10 minutes, sir.
Oh, we still have 10 minutes. Excellent.
Finish whatever is in the chat box.
Yeah, so there is this one question that the preloading of IV fluid before giving spinal anesthesia, regarding that, someone has put up question. And also, what is the ideal fluid in the perioperative phase? I think that you already answered it. The preloading of IV fluids in the anesthesia, I think, I don't know, that can be taken.
I mean, preloading, do they mean carbohydrate preloading or is it
No,
just
the fluid, IV fluid preloading before spinal
So
anesthesia.
they say after spinal, they go for hypotension.
Yes. I mean, yeah, that's a common practice. I think our anesthetists do that because they kind of load with fluid. I think this type of fluid loading, it is quite okay to use normal saline. It is quite cheap and it is okay. So to use 500 ml or 1 liter normal saline is absolutely fine. As in the trial in 2015, there was actually a randomized trial which I put up using 1 liter normal saline versus 1 liter plasmalite or any other balanced solution does not really make any difference to the renal dysfunction. So using up to 1 liter normal saline to resuscitate patients, this is probably very similar. So you're giving spinal, and then the patient is going to go for potential hypertension. So you're giving fluids. So you're kind of resuscitating the patient. So 500 ml to 1 liter normal saline is absolutely fine.
Hello.
Yeah, there's another question.
Can I add a comment? Yeah.
Dr.
Siddesh here.
Yes, good evening, sir.
Yeah. That was a lucid talk. You made it a complicated long talk into a short talk with a lot of clarifications. But Rajiv, I just want to ask you this spinal anesthesia, especially I have found these patients who have low cardiac output, the patients getting loaded because especially patients who are having hypertension and those who are on drugs, where these after giving spinal anesthesia, more than 50% of your vascular bed is off these drugs effect. So what happens is they load these patients with fluid, and once this patient in the post-operative period, spinal starts getting worn off, these fluid come into the general circulation where the drugs are acting, so they go in for pulmonary edema. This is what I have seen in some of my patients. So I think the best way to look forward is whenever there is an issue like this, best to avoid spinal anesthesia itself. So they can be put on balanced general anesthesia, or they need to be careful with managing this fluid management in this intra-op period and immediate post-op period when they are still under spinal effect for majority of the vascular volume in the body.
Absolutely.
Your input, Rajiv?
Absolutely, sir. I think what you alluded to, sir, is this problem with hypervolemia. I think we are actually, as clinicians, we have actually forgotten about this problem of hypervolemia, sir. What is right now pointed out is, the spinal wears out and then patients get hypervolemic, pulmonary edema, other problems come in. So I think we should be really, really careful to, think ahead and not just use IV fluids just for the sake of it. And we need to really plan and use them just like we would use antibiotics, and other medications, sir. I completely agree, sir.
Yes, sir. Sopimat, sir.
There's another question here.
I just wanted to make a comment that it's been an excellent talk. I think I just wanted to make, Raju, that earlier that I think that teaching and practice might have gone that the intake should be, or the fluid should be adjusted based on the urine output. I think that concept must go. I think that's one thing. I think, do you agree with that? That's one. And second thing is, I think most of the times whenever the BP is slightly low, somewhere around 90, 100, there is a lot of stress factor built. And people try to start with the inotropes and all that. Again, that shoots up the heart rate and everything. I think we don't have to be very aggressive in the inotrope starting unless the BP falls to a significant level where the vital organ perfusion may be compromised. This may be second thing. So these are some of the things, because there will be always some young intensivists or some other people. They are always, that aggressive in keeping the BP above 110, 120 like that. I think it is not necessary, I suppose. Otherwise, I think very crystal clear concepts. I just wanted you to highlight on these two things.
Yes, sir. I agree, sir. I think that, urine output measurement is kind of, that, I mean, that type of situation is okay if you're monitoring the urine output every hour, patients are undergoing surgery, but however, there are a lot of other clinical signs which can be used, capillary refill, the settling of the heart rate, blood pressure settling down, patient improving, skin turgor. So these are all things which can be used to have a general idea about how the patient is responding to fluids. And generally speaking, you would need to look at urine output and things, only at a later time. But what is happening now in the ICUs is that, let's say, critically ill patients, you're measuring the IVC diameter and you're
Yes.
looking at the SVV change. If you have a cardiac monitor put in, so these type of very highly refined things are being used, especially if patients are undergoing major surgery. But if it is for simple things, I think simple clinical assessment of the patient is actually more than enough to know whether the patient is responding to the fluid or not. I completely agree with that, sir. And the other thing is about, like you mentioned, about being very aggressive with, I agree. I think that, a lot of clinical things are going out of the window by, because of the use of all these various types of monitors. By simple assessment of settling of the heart rate, improvement in capillary return, I think these type of things will give us a lot of information, especially in a situation where we are treating a new trauma patient or hypovolemic shock or even septic shock when they come into the emergency. I think these type of things will obviously be of great help to us, rather than relying too much on modern gadgets. They have a role, but they have a role in a different situation.
Rajiv, Dr. Rajana has put an ideal point, monitoring of pulse pressure variation. I think monitoring of pulse pressure is also very important.
Absolutely, sir.
Yeah,
Absolutely.
yeah. And he has mentioned about the RL converting into lactate.
Actually, and absolutely, sir. I think that's a very important point. Actually, lactate is converted to bicarbonate, and bicarbonate is further broken down into CO2 and H2O. And so I don't think we need to worry too much about the lactate as long as the liver is working fine. Okay. So the lactate in ringer is actually, it will be metabolized by the liver beautifully. So I don't think there is an issue with lactate in the ringer at all.
Okay.
And I think there is one other question as to how many units of fluids to be given in the postoperative period. Like how do you measure that? That's one question is there.
Yeah. So like that trial showed, sir, it is okay in the first 24 hours to have a positive balance of up to 2 liters. Okay. So, I mean, basically, you have the maintenance fluid requirement is 1.5 ml per kg per hour. So that's the rule of the thumb. So if suppose somebody is 60 kgs, then it's 1.5. That's actually the maintenance. Plus then you include the losses, and then you include the insensible losses, and then you add the sodium requirement and the potassium requirement and the chloride requirement per day. And that's how you kind of, work out the amount of fluid that is needed. And then, in the first 6 to 12 hours, frequent assessment is what is needed, blood pressure, pulse pressure variation, skin turgor, capillary refill, and if you have your monitoring, CVP, and then if you have cardiac monitoring, SVV, stroke volume variation, and then pulse pressure variation. So these type of things can be used, and then you can measure the SVR and things depending upon the type of surgery that your that your patient has had. And at the end of 24 hours, if you have a 2 liter positive balance, that's absolutely fine. But then continuing on beyond 24 hours, 48, 72 hours, cumulative fluid balance of 1 or 2 liters every day is probably not ideal. After the first 24 hours, you probably just need to try and get the patient into neutral balance, and then stop the patient getting into hypervolemia. So I think that's the important thing.
Yeah. Thank you, Murli. Can we end this?
Yeah, I think we can.
I think all the guests have joined. It's right time to hand over to Gaddi.
Thank you very much.
MB Patil, Rajshekhar Jaka, and Rajiv Lochan for their valuable talks. I thank Dr. Ramappa from Raichur and Murli from Fortis Hospital, Bangalore, for chairing the session. Thank you.
Thank you very much.
Gaddi, it's
Yes,
your
sir.
time.
Yeah, I thank
inauguration of the conference.
Yes,
thank you.
I thank Dr. Venkatesh for moderating today's sessions. He maintained time very well, made some interactive discussions look interesting. Thank you, Dr. Venkatesh from KCSI for managing screen one today. Yeah. So it's a time for inauguration of Kscasicon 2021, the formal inauguration program. So let's begin with the welcoming of dignitaries. Good evening, ladies and gentlemen. We extend a warm welcome to you all to this formal inauguration of 39th Annual Conference of Karnataka State Chapter of Association of Surgeons of India, being organized virtually for the first time. Without much ado, let's begin today's function. I cordially welcome Dr. S.S. Sopimat, Chairman KCASI, to chair the session today. Welcome you, sir.
Thank you.
Now I welcome Dr. Arvind Patel, Chairman-elect, Karnataka State Chapter of Association of Surgeons of India. Welcome, sir. I welcome Dr. Jaspal Singh Tehelia, Honorary Treasurer of KCASI. I welcome Dr. Vidyadhar Kinal, Immediate Past Chairman of KCASI. I welcome Dr. Narayan Hepsur, Immediate Past Secretary. I also welcome Dr. Lakshman, Chairman, Scientific Committee of KCASI. I welcome our EC members. I welcome National EC members. I welcome Guest of Honor, Dr. Santosh Jan Abraham, Director, Academics, ASI. I welcome Guest of Honor, Dr. Sanjay Jain, Honorary Secretary, KCASI. I welcome Guest of Honor, Dr. G. Siddesh, Vice President, ASI. And I welcome Chief Guest of today's function, Dr. Abhay Dalvi, President, Association of Surgeons of India. I also welcome orators, distinguished senior surgeons, whom we are honoring this year. I also welcome all the faculty and postgraduate students for this function. So let's begin today's function with the invocation by invoking blessings of the great architect of the universe with this beautiful rendition.
गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि.
I request Chairman KCASI to invite Dr. Dalvi to declare this inauguration function as open. Followed by that, we will be lighting a virtual lamp. So, Pimet sir.
Yeah, I request Dr. Dalvi to announce that this inauguration is done.
I, Dr. Abhay Dalvi, President of the Association of Surgeons of India 2021, declare the inauguration open. Thank you.
Thank you, sir. Let's light a virtual lamp indicating destruction of the darkness and moving ahead towards the light.
Kalyanam Arogyam Dhanasampadah Shubham Kurutvam Kalyanam Arogyam Dhanasampadah Shatru Buddhi Vinashaya Deepajyotir Namostute Deepajyotir Namostute Shubham Kurutvam Kalyanam Arogyam Dhanasampadah Shubham Kurutvam Kalyanam Arogyam.
Thank you. Now it's time to present a secretary report for the year 2021. Good evening all. Respected Presiding Officer and Chairman of KCASI, Dr. S.S. Sopimat, Chief Guest, President ASI, Dr. Abhay Dalvi, and all the invited guests, members of KCASI, associate members of KCASI. It gives me immense pleasure to present to you all Secretary Report of the year that never was, that can be called as COVID year 2020. KCASI remains the second largest branch of ASI with the 21 city branches actively working, and the membership strength of KCASI now stands at 1988 full life members. It also leads in the membership strength of ASI Social Security Scheme. Change of guard happened at 38th Annual Conference of KCASI, hosted by Surgical Society of Bangalore at Hotel Sheraton Grand on 16th February 2020. For the first time, annual conference was held in a 5-star ambience and had a ton of academics. Congratulations to the office bearers of Surgical Society of Bangalore and Dr. Uday Muddebihal, Organizing Chairman, and Dr. Arvind Gubi, Dynamic Organizing Secretary of 38th Kscasicon Bangalore, for providing us a memorable conference. It's significant to note that the SSB and the organizing committee have contributed a sum of rupees 10 lakh with the request to keep that money as fixed deposit and use it as a research grant and name it as Kscasicon 2020 Research Fund with certain guidelines attached to it. These guidelines have been published in the website and for all the eligible to use and apply for the grant. I urge the members of KCASI to utilize this grant towards research. Coming to the academic activities, despite the limitations posed by COVID, All branches performed extremely well given the constraints. Surgical Society of Bangalore is in the forefront of conducting activities regularly. They conducted Dr. Hanumaya Memorial CSCP successfully and also KCASI Surgical Quiz Program. Winners were Dr. Shashank and Dr. Dhruva from KIMS Bangalore. Belgaum and Vijaypura branch were also active academically. KCASI organized workshops on evidence-based surgery and research methodology at Vijaypura, Sri Rajarajeshwari Medical College, Bangalore. KIMS Bangalore held on 14th and 21st of June for Bangalore and for Kolar area, and it was held on 12th and 19th July for North Karnataka delegates. It was also held on Learning General Surgery platform. The COVID activity of the branches included the KCASI procured PPE kits with the help of ASI, and initially we provided it to the branches against a cost basis, and later was donated to KIMS Hubli, WIMS Bellary, District Hospital Vijaypura and MMC Mysore free of cost. All the branches and its members were in the forefront of COVID specific activity in providing succor to the needy. Noteworthy activity this year has been installation of the first office bearers of Chitradurga branch. It was conducted virtually by the chairman on 27th January 21st and was attended by many EC members. Chairman also held a meeting with HODs on June 14th last year. Chairman also met with the HODs of surgical departments in view of the constraints posed by COVID virtually and updated them about the EBS workshop and proposed changes to the academic content of the conferences. Chairman's city branch meeting was held on 7th of June 2020, and it was also held virtually to discuss the activities of the local branches with the president and secretaries of the state branches. The KCASI MidCon this year was a novel event. It was held for the first time virtually under the team led by Dr. Lakshman and his team. The kudos to the abstract evaluation team of Dr. Tejaswini, Dr. Shivram, and Dr. Vidyadhar for evaluating the abstracts. More than 300 papers and posters were presented, and the whole expense of the event was 15,000 rupees, which was incurred to subscribe the 3 Zoom screens. And prizes to the winners were sponsored by Dr. Suprimat, Arvind Patel, Jaspal Singh, Dr. Shivram, Dr. Dayanand Nuli, Dr. Rajgopal Shanai, Dr. Aruna, Dr. Naz, Surgical Society of Mysore, and Dr. Lakshman K. And the screens were sponsored by Dr. Suprimat, Dr. Lakshman, and Dr. Gadi Divakar. Dr. S.S. Suprimat needs a separate mention here. He is a quintessential organizational man. I thank him for reposing his faith in me. Though the COVID was a dampener for his enthusiasm, his contribution has been phenomenal this year. Dr. Jaspal Singh is a silent and a workhorse for the KCASI Association. He maintained meticulous accounts, at the same time coordinated with the city branches and heads of the departments. Shastra and website need a mention too. Newsletter, the Shastra from KCASI was brought in 4 editions under the leadership of Dr. Naz Jan Sheikh. Dr. Ramakrishna HK has made our website of kcasi.com up to date, and he is in the forefront of digitalization of all the documents, including the EC minutes meetings, and also uploading of all the guidelines and the activities of KCASI. My sincere thanks to our scientific committee constituted by Chairman Dr. S.S. Suprimat. It was headed by Dr. Lakshman K. and consisted of Dr. Arvind Patel, Dr. Aruna, Dr. Naz, Dr. Jaspal Singh. They brought in a freshness to the way we conducted conferences virtually in this COVID-19 period. They met a phenomenal 20 times in 1 year. This year, online elections of KCASI were held in view of the COVID. We associated ourselves with we associated with the online elections of ASI. So this year, Dr. B.N. Patil was elected as Chairman-elect for 2021, and Dr. Chandrasekhar S. from Mysore was elected as Honorary Secretary, and Dr. Chandrasekhar N. was declared unopposed for the post of Treasurer. And for the nominations of EC members, for the EC member non-medical college area, Dr. Naz Jahan, Dr. Sarvesh Rajay Aras, and Dr. Vijay Kumar were declared unopposed. And for the EC member post from the medical college area, Dr. Kalaivani, Dr. Dinesh H.N., Dr. Amaresh, Dr. Rajshekhar C. Jaka, Dr. Y. Gurubasavana Gowda, and Dr. Vijay Kamath were declared elected. Dr. Siddesh, a member of KCASI, we are proud to announce that he has been elected as Vice President ASI for the year 2021. We wish him all the very best for his tenure as President of ASI 2022. It's time to introduce the orators for this year. For Professor H.S. Bhatt oration, Dr. Gurshantappa Elgachin will be doing the oration this year. Dr. A.J. Narendran oration, Dr. Chennana will be doing. And Dr. S.S. Narsanigi oration will be conducted by Dr. Narayan Hepsur, and Dr. M.P. Pai oration will be conducted by Dr. Captain L. Ramachandra Seva Medal. Dr. S.R. Kalgud endowment lecture has been delivered by Dr. Srinivas Pai. And orators for 2022 approved in the last year AGM were Dr. Vidyadhar Kinal will be delivering Professor H.S. Bhatt oration. Dr. Lakshman K will be delivering Professor A.J. Narendran oration. And Dr. Naz Jahan Sheikh will be delivering Professor S.S. Narsanigi oration. And Dr. Gabriel Rodriguez will be delivering Professor M.P. Pai oration. List of conveners for 2021 will be Dr. Balkrishna Rao Memorial Symposium will be delivered by Dr. Prasad S.S. from Manipal. Dr. R.B. Patel Symposium will be conducted by Dr. Kasa Somshekar. So it's time to introduce our distinguished senior surgeons whom we are honoring this year. The honoring the surgeons will be the KCASI takes pride in recognizing yeoman services rendered by the distinguished senior surgeons of the association. It's my pleasure to present them virtually to the members. I present Dr. Durganna T to the audience. About Dr. Durganna T, Dr. Durganna T completed his MS General Surgery in 1985 before joining the Government Medical College, Bellary as assistant surgeon, where he earned good reputation as a teacher. He underwent further training in advanced laparoscopy in Chennai and in palliative care. In 1997, when he was assistant professor, he was transferred to Bangalore Medical College, where he worked in various capacities, culminating in being the head of the Department of General Surgery in 2013. He has been involved in teaching activities for postgraduates, conducting research activities and clinical trials, and examiner for various universities. Dr. Durganna T has also been the MSA inspector to various medical colleges in India. He has held many administrative posts and retired from government service in 2016 after 31 years of service as the medical superintendent of Victoria Hospital, Bangalore Medical College. He currently works as professor of surgery at Rajarajeshwari Medical College, Bangalore. He was awarded the prestigious FRCS by the Royal College of Physicians and Surgeons of Glasgow, UK in 2013, and Fellowship of American College of Surgeons in 2018. He is an active member of academic circuit, participating as faculty in various conferences and workshops across the state and country. He was involved in WHO project for integration of oral health into general health in 2008 and 2009. I request Chairman S.S. Sopimat to welcome Dr. Durganna and let him address for a few minutes.
I request Professor Durganna to address the audience, please. Sir, you are here?
Hi, sir.
Yes, please.
Sir, I actually thank the organizing committee for honoring me, and it is a pleasure for me to join with you, and thank you very much.
Thank you, sir.
Okay.
Thank you, sir. Thank you for accepting honor from KCSI, sir.
Okay.
Now it's time to present the second distinguished senior surgeon whom KCASI is honoring this year, Dr. P. Sampath Kumar. It's a pleasure to introduce Dr. P. Sampath Kumar to this audience. Professor Dr. P. Sampath Kumar was born in February 1955. After an excellent academic career, he passed his MBBS with a first class from Kurnool Medical College, Kurnool in Andhra Pradesh. The prestigious N. Ghulam Hussain Gold Medal for standing first in general surgery, perhaps was the motivation for him to set out on a career in general surgery. He did his post-graduation in general surgery from Jipmar, Pondicherry. His passion and love for the subject of surgery led him to join Kasturba Medical College, Manipal, as a lecturer in general surgery. His successful teaching career culminated in his rising to the post of Professor of Surgery, Head of the Department of Surgery, and Associate Dean of KMC Manipal. He successfully completed 35 years of teaching service and retired from Kasturba Medical College, Manipal in 2019. After retirement, he joined the Melaka Manipal Medical College, Manipal campus for a teaching assignment in surgery. The unexpected disturbance in the regular teaching due to the COVID-19 related lockdown brought out unexpected challenges to him in conducting online classes. Putting to excellent use his skills in computers, he is relishing the challenge. He has his own technique of delivering didactic lectures and even conducting online clinical case teaching. His passion is teaching of surgery, and areas of special interest include acute abdomen, decision-making in emergency surgery, management of post-operative complications like enterocutaneous fistulae, management of necrotizing fasciitis, and blunt injury abdomen. He has delivered many guest lectures in several conferences and CMEs, including the Dr. MP Pai variation 2014 and Manipal variation in 2018. He himself has organized several CMEs during his stint as KMC Manipal. He has to his credit 15 publications in various national and international journals. He was a postgraduate examiner in surgery in many universities. I request Dr. Sopimat sir to welcome Dr. P. Sampath Kumar to address KCASI.
May I request Professor Sampath Kumar to say a few words, sir?
Good evening, everyone. I am extremely honored when a few weeks ago, Dr. Divakar rang up informing me of the decision to confer this award. I was pleasantly surprised and humbled, and the first doubt comes to my mind whether do I really deserve this. But anyway, it is extremely heartening to see that your services, whatever they think it is recognized by your peers and colleagues in the fellow thing in that. And I'm extremely thankful to the Karnataka State Chapter of ASI for honoring me. And thank you very much, especially all the members of the Executive Committee of KSCASI. Thank you.
Thank you, sir. Thank you.
Thank you, Dr. Sampath Kumar sir, for accepting the honor. Thank you very much for attending the function.
Thank you.
Now, it's time to introduce Dr. Srikantaya R to the audience. Dr. R. Srikantaya was born on 27 July 1939 to late Srimati Chandrama and late B.N. Rudrappa. He hails from family of doctors. His grandfather, Dr. B. Nanjappa, MB and CM, was the superintendent of Victoria Hospital and Principal Medical School, Bangalore. Dr. R. Srikantaya joined Bangalore Medical College as a second batch student in 1956 and passed MBBS from Mysore University in 1962. He had his postgraduate training in King George Medical College and passed his MS General Surgery in 1967 from Lucknow University. He served as lecturer and reader in surgery in MR Medical College, Gulbarga from 1968 to 1974 and moved to Davangere. He joined JJ Medical College, Davangere as Associate Professor of Surgery and retired as Professor in 2004 after a period of over 25 years. He is a committed, sincere and devoted teacher who has taught both under and postgraduate students for over 40 years. He has been examiner at various universities, life member of Association of Surgeons of India. He was president of Davangere Surgical Society during 1999 and 2000 and was executive committee member of Karnataka State Chapter of Association of Surgeons of India during 2001 and 2003. He is happily married to Srimati Sudha Srikantaya. They have 3 daughters. First 2 are doctors from JJ Medical College, married to medical doctors, settled in Chicago, USA. Third daughter is an orthodontist practicing in Bangalore, married to an ophthalmologist. I request Dr. Sopimat sir to welcome Dr. R. Srikantaya to address KSCASI.
Srikantaya sir, welcome you and request you to say a few words, please. Are you around, sir?
Yeah, he's there, sir.
Yeah.
Hello.
Yes, sir.
Dr. Sopimat and also Dr. Divakar. I am also very, very grateful to all the members of the organizing committee for honoring me and recognizing my services in the medical college. I thank you all and thank you for the honor done to me.
Thank you, sir. Thank you, sir.
Thank you, Srikantaya sir, for coming here and accepting our honor. Thank you very much. Now it's time to introduce Dr. Vijay Kumar M to the audience. Dr. M. Vijay Kumar needs no introduction. He was secretary of this organization, was born in 1957. He did his MBBS in 1979 from Madras University and DNB General Surgery in 1985 from HIL Hospital. He then completed his MCH in 1993 from Kidwai Memorial Institute of Oncology, Bangalore. He was awarded the Fellowship of Royal College of Physicians and Surgeons, Glasgow in 2007. He has undergone advanced training in various renowned centers abroad. He joined Kidwai Memorial Institute of Oncology, Bangalore in the Department of Surgical Oncology as senior resident in 1984 and ascended to become the professor and head of the department till he took voluntary retirement in June 2015. He was the director for 5 years for Kidwai Memorial Institute of Oncology, which he got elevated from Regional Cancer Center to State Cancer Institute. He was the visiting professor in the Department of Surgical Gastroenterology, Bangalore Medical College for 15 years. He is currently working as the Vice Chancellor and Professor of Surgical Oncology since July 2015 at Enepoya Medical College Hospital. He was Honorary Secretary for Indian Association of Surgical Oncology at the national level for 2 years and went on to become the President of Indian Association of Surgical Oncology in 2015. He was the Honorary Secretary for Surgical Society of Bangalore and was the Honorary Secretary for KCASI. Presently, he is Chairman of Task Force dealing with health promotion and prevention in oncology in the National Cancer Grid under the aegis of Tata Memorial Hospital, Mumbai. He was the observer in the University of Heidelberg, Germany, University of Bujon, France, and University Combined Hospitals, London, UK. He was sent by the government of Karnataka for studying the NICE guidelines of NHS scheme in UK to incorporate in Vajpayee Arogya scheme. Dr. Vijay Kumar has over 50 publications in reputed international and national journals, including several large clinical trials. He has presented over 60 papers and delivered over 100 invited lectures worldwide. He has contributed to 8 books. He has been invited as guest of honor by the British, European, Brazilian, and Chinese Society of Surgical Oncology. He has received numerous awards, including a traveling fellowship from reputed national and international organizations. Recently, he has been trained in robotic surgery, which he has established in Enepoya Medical College Hospital. His areas of interest in cancer are creating cancer awareness and health promotion, surgery of oral cancer, thyroid cancer, breast cancer, esophageal cancer, gastrointestinal cancer, gynecological cancer, bone and soft tissue cancer, and pediatric solid tumors. I request Dr. S.S. Sopimad to welcome Dr. Vijay Kumar M. to address KCASI.
May I request Professor Vijay Kumar to say a few words, please?
Good evening, everybody.
Good evening. Good evening.
It is really a pleasure to see you all virtually. Dr. Sopimad, the chairperson of KCASI, the secretary, the past presidents, past secretaries, and the guest of honor today, chief guest, the president of ASI India, and our own friend, Dr. Siddesh, the vice president, and all other dignitaries. It's really humbling to be acknowledged and recognized for whatever very little work which we have done in the past 40 years or so. I joined, as they said, an institute, Kidwai. Why I am repeatedly saying that, apart from what you already told, I am here because of Kidwai. For many, it's a place of work. For me, it's a temple of worship. Thank you very much for recognizing me and inviting me to be a part of this. I am really grateful to all the members and the organizing committee and the EC who chose me to be so. In a lighter vein, I have to conclude with my style. I never thought I was senior enough to get it. They made me old. Thank you very much for calling me old. Thank you and have a nice day. God bless.
Thank you, sir. Thank you.
Thank you, Vijay Kumar, sir, for attending and accepting our honor. Thank you very much. We'll move on to the next point of the inauguration program, that is introduction of the orators. If it were to be a physical conference, we would have called them on stage and felicitated them and would have given them citations and scrolls. It's a pleasure to introduce Dr. Gurshantappa Elagachin, who will be delivering Dr. H.S. Bhatt oration this year. He is a professor and head of the Department of Surgery at KIMS Hubballi. And the next orator for Dr. A.J. Narendran oration is Dr. Channana C., who is a professor of surgery at VIMS, Bellary. And it's a pleasure to introduce Dr. Captain Ramchandra L. Seva Medal, retired Professor KMC Manipal, who will be delivering a Professor MP Pai oration this year. And Dr. S.S. Narasanagi oration will be delivered by Dr. Narayana Hepsur, Professor of Surgery at KIMS Hubballi. As I told earlier, Dr. Srinivas Pai has already delivered Dr. S.R. Colgood endowment lecture this evening. And coming to symposia, Dr. Balkrishna Rao Memorial Symposia will be convened by Dr. S.S. Prasad this year. And Dr. R.B. Patil Symposium will be convened by Dr. Kasa Somshekar, who is Professor of Surgery at VIMS, Bellary, and Dr. S.S. Prasad, who is convening Balkrishna Rao Memorial Symposium, is a professor at Manipal, KMC Manipal. Thank you all for coming here and attending the inauguration function. Thank you very much. So next point on the agenda is branch appreciation awards. Though due to COVID, majority of the branches were involved in COVID relief work. 2 branches, as I mentioned in my secretary report, did extremely well in this period. KCASI usually used to give away 3 awards in the 3 categories. That's the large branch, best large branch, best medium branch, and the best small branch. We have done away with that tradition because of the COVID. We are just appreciating 2 branches which have done extremely good work in all the academic and also in COVID and also in social activities. So those 2 branches are Bangalore branch and Belgaum City branch will receive appreciation award from KCASI this year. So Pimat sir, to say a word about their appreciation, please.
Congratulations to both the branch. They have done extremely well, and COVID didn't deter them from conducting a lot of activities. In fact, Bangalore conduct almost every month, and apart from that, they had this Hanumataya Memorial like oration and the annual CME and all that. I think they did a fantastic job. Similarly, Belgaum branch also, though other branches did the activities, but these branches, I think they did a fantastic activities compared to other branches. So we thought we'll give them appreciation award. And I hope other branches also will continue to do the activities and come up to the expectation of other branch, the office bearers and the KCASI in the next year. Hopefully the COVID should disappear. Thank you. Congratulations to both the branches and the office bearers.
Thank you, sir. Congratulations to both the branches as mentioned by Dr. S.S. Sopimat. Coming to the next point, the KCASI also appreciates Dr. Lakshman K, Chairman Scientific Committee, for his contribution towards academics of KCASI. Dr. Jaspal Singh Tehelia, Honorary Treasurer. It also appreciates all the EC members who will be completing their term this year. The next year, the new branch after this inauguration, the new branch will take, members will take over. It also appreciates services of Dr. C.S. Rajan and Dr. Gurushantappa Elagachin, who worked as quiz masters during state level Dr. K. Shekhar quiz competition. And also the KCASI recognizes Keystone Medical Services Private Limited, who are our official e-partners. Sir, I request Dr. S.S. Sopimat sir to congratulate them, please.
Yeah, I really congratulate the entire team. They've done a wonderful job and they've been like a backbone for most of our activities. And I fall short of words to appreciate them. Actually, I really thank them all for a very solid support and the contribution what they have done for the KCASI this year. Congratulations and thank you all.
Thank you, sir. So now we come to inviting guests to address KCASI. I request Dr. Sanjay Jain, who has come as a guest of honor to this function. Dr. Sanjay Jain is Honorary Secretary ASI. He works as Professor, Department of Surgery at Gandhi Medical College and Associated Hamidiya Hospital, Bhopal. As I mentioned, he is the current Honorary Secretary ASI and he is Honorary Treasurer ABSI. Ladies and gentlemen, I welcome Dr. Sanjay Jain to address the gathering. Dr. Sanjay Jain, sir, please do the honors.
Thank you and very good evening to all of you. Namaste. So, presiding officer, Dr. Sopimat, the chief guest of the evening, the president of the ASI, Professor Abhay Dalvi, our own vice president, Dr. Siddesh, all the dignitaries, dear members. It's an honor to be with you all, and whatever I have got, I have received. Because the Karnataka State ASI, Karnataka chapter being the one of the largest chapter in the country with almost 3,000 membership. And another thing which I am proud to say, that it has been leader in the ASI social security scheme. See, these are the things. So when I was thinking, how will I speak, what I will speak, suddenly I got relieved because it is more to learn from Karnataka rather to tell anything to them. It has been my pleasure and my pride to be here today, even attending the previous programs of the Bangalore Surgical Society and all other programs. There have been excellent programs. And so it is more of the, I'll say, my personal feelings toward the chapter rather than being official. I was blessed to work with Dr. Sopimat as EC member. I'm blessed also to work with Dr. Arvind Patel. I have been witnessing the very crisp reporting by the secretary, Dr. Gaddi Divakar, and definitely the affectionate Dr. Rajan. And whenever you need support, there are always pillars like Dr. Shivram or Dr. Shenoy. So it's a pleasure. It's really a good feeling in my heart when I come to the Karnataka ASI. I want to convey the greetings on behalf of the Associations of Surgeons of India, and I expect this to continue, and I will expect the Karnataka chapter will continue to guide the entire nation. And fortunately, we have Dr. Siddesh to lead us next year. So it is all Karnataka for the coming days. Again, thank you very much for inviting me. My best wishes, and thank you. Thank you all.
Thank you.
Thank you, Sanjay Jain, sir. I request Dr. Santosh Jan Abraham, Director Academics ASI, today's another guest of honor, to address this gathering. Before that, I would like to introduce Dr. Santosh Jan Abraham. Dr. Santosh Jan Abraham has been past ASI president, and now he is very active in academics of ASI as a Director Academics, and he is very active in conducting NACP courses and continuing medical surgical education programs which are running successfully on every Wednesday from 9 to 11 a.m. I request Dr. Santosh Jan Abraham, sir, to introduce the address the gathering. Please welcome, sir.
Respected Dr. Sopimat, Chairman of the chapter, Gaddi, Honorary Secretary, National Leadership, Professor Dalvi, Professor Sanjay Jain, and I have a lot of good friends in Karnataka. For ages together, we have worked very closely between Kerala and Karnataka. I see the smiling face of Vijay Kumar saying, and I listen to his talk. I have Dr. C.S. Rajan, always I can fall back upon him for any academic help. I have Dr. Rajgopal Shenoy, Shivaram, and the galaxy of eminent people. And needless to say that the list grows up with Siddesh taking up the leadership of the national ASI. I'm sure that in years to come, Karnataka will be on a stronger position because of the leadership and the academic contribution and the sheer number which you have been able to amass. Apart from all these things, let me also put it into, for the information. You have one of the largest teaching numbers in the country. The largest number of postgraduate institution and the largest number of postgraduate training facility are being shared by Karnataka, Maharashtra, and Tamil Nadu. These are the three states which fight neck to neck in terms of the sheer number. And this is translatable into the quality of medical care these three states are offering to their citizens of that state. And I'm extremely happy to state that the standard of medical teaching, surgical teaching in particular, is very high in all these states. And the quality of the deliberations, I peep in between your conferences, go through the program. I may be a silent, mute spectator, but I enjoy all the deliberations, particularly of the very senior learned teachers. and it will be a pleasure working with you in future also. I have been greatly supported in every venture at the national level. All of you have helped in various forms. I thank you, all of you, from the bottom of my heart for the continued support that you have given me during my presidency and later on. And I wish this conference every success and also in years to come. Thank you very much. Long live ASI.
Thank you.
Thank you, Dr. Santosh John Abraham, sir, for addressing us. Now, I request Dr. Siddesh, sir, Vice President ASI, to address KC ASI. Dr. Siddesh is a consulting surgeon and former professor at JSS Medical College, Mysore. Now he is consulting surgeon at Sigma Hospital, Mysore, and Vice President ASI. I invite Dr. Siddesh to address the gathering. Dr. Siddesh, sir.
Thank you, Divaka. Dignitaries on the dais, though virtual, and my dear friends. Indeed, it is my great pleasure to be talking to my own state chapter colleagues in the midst of our national dignitaries, the president and the secretary and the academic chief. I'm sure this, though virtual, has gone through like a very official, well-decorated platform of celebrations, including honoring of our very senior members with pleasure. Each one of them deserved that honor, and all of them have worked with me. We have attended a lot of conferences and deliberations. It is really a joy to share this dais and also honor them at this hour. Those who have been giving orations this year, my congratulations to them. I wish to look forward to a great delivery of great lecture to learn from them. At the same time, as Santosh put it, that Karnataka has been a leader in the producing not only number of postgraduates, but also very good postgraduate teachers. And I'm sure this legacy will continue. And this year, though pandemic has restricted our physical meetings, Dr. Suppimat has taken it as a war footing, conducting maximum number of academic activities. The MidCon, which went through, has been a real academic feast, and it has shown ways for future how even at virtual we can continue to learn and exchange our reviews. And this academic feast of annual gathering of Karnataka State Chapter, I'm sure will continue for the next 2 days as it has gone through today in very good vigor, and the academic exchange will continue. And dear friends, at this opportunity, I will again thank all the members of Karnataka State Chapter for having stood and supported me in this present election. And I will sure hope to contribute at my best to the good of the state as well as for the National Association. And we are again going through this turmoil in difficult times of pandemic, and also some policy decisions which are taken by the center need to be countered. As you all know, I think association will stand and fight it out to the best of interest of its members. With Abhay as the head of our association, I'm sure the academic is going to take it to newer leaps, and I look forward to work with him to take this association to bigger heights. Thank you for this opportunity, and wish all of you all the best in the future couple of days of this conference. Thank you.
Thank you. Thank you, Siddesh.
Thank you, Siddesh, sir, for addressing the gathering. Now, it's the time to invite our chief guest, Dr. Abhay Dalvi, President, Association of Surgeons of India, to address this gathering. So before that, I would like to introduce Dr. Abhay Dalvi to the audience. Dr. Abhay Dalvi is Professor and Unit Chief in Surgery, Associate in Surgical Gastroenterology, and in charge of laparoscopic surgery at Seth GS Medical College and KM Hospital. He also has his practice at Global Hospital, Mumbai. Dr. Dalvi is the President, Association of Surgeons of India for 2021. Dr. Dalvi has been the President of the Indian Association of Gastrointestinal Endosurgeons and ASI Maharashtra State Chapter 2015 and 2013 respectively. Dr. Dalvi has also been the executive member of Association of Minimal Access Surgeons of India, that is AMASI, and on the board of governors in the Endoscopic and Laparoscopic Society of Asia, that is ELSA. He has been a reviewer of video abstracts of annual meeting of Society of American Gastroenterological Endoscopic Surgeons, that is SAGES, and is on 2 member committees. Dr. Dalvi has been faculty at international and national level in laparoscopic surgery, notably visiting professor of Mauritius in 2001, World Congress in Berlin in 2006, and Society of American Gastroenterological Endoscopic Surgeons at Baltimore in 2010. Dr. Dalvi is also on the editorial board of Journal of Minimal Access Surgery, Indian Journal of Surgery, and the Journal of Postgraduate Medicine. He has more than 50 publications in national and international journals, invited faculty at live operative workshops, invited lectures at multiple conferences, and has delivered 13 orations, including the prestigious Professor P.K. Sen oration at Kscasicon 2019. Dr. Dalvi has a large experience in laparoscopic surgery that includes common procedures like cholecystectomy and appendicectomy. His interest, however, is solid organ surgery, having performed 152 splenectomies and 371 adrenalectomies. Happily married to Mrs. Sujata, a gynecologist, he has one son, Adit, who is a senior software developer with Microsoft at Seattle. Ladies and gentlemen, Dr. Abhay Dalvi, President ASI, for you. I request Dr. Abhay Dalvi to address KCSA gathering. Welcome, sir.
Yeah, thank you. Am I being heard?
Yes, sir.
Yes.
Yeah. Unfortunately, my net at home has gone down, so I will be on my mobile, and I don't know whether even I'm seen. But dear friends, nothing gives me more pleasure to stand here as the chief guest, inaugurating the annual conference of ASI Karnataka State Chapter in the year 2021 by virtue of the constitutional obligation. It is the first time pleasure to be with Karnataka State Chapter Conference, as the dates often coincide with the annual conference of the Maharashtra State. Karnataka has been always on the forefront of academic activities. I must compliment the state chapter for excellent academic program this year under the leadership of Dr. Sadashiv Sopimat, Divakar Reddy, and the organizing team, particularly Dr. Lakshman as the chairman. It is also an honor to be present during recognizing and honoring senior surgeons from the state. My namaskara to all of the senior surgeons who have been felicitated. It's heartening to hear a good, healthy discussion after my delivering the Dr. T.S. Jairam Memorial Lecture. I hope that teachers in medical colleges help me in solving the problems of the PGs through ASI. Association of Surgeons of India has been successfully running the regional refresher course for last 6 years and has almost become the flagship program of the association. The second program to develop skills is the National Skill Enhancement Program introduced by Professor Arvind Kumar as the president in 2019. Despite the pandemic in 2020, Zoom and other avenues have taught us to have opportunity in adversity. We could complete the academic commitments with great success on virtual basis, including the Kscasicon 2020. To my dismay, postgraduates have lost a lot of operative experience. ASI on its side have started this year a video-based operative teaching program on virtual platform from February 2021. It's every Wednesday, 9 to 11 p.m. and it's free, and any PG can just go on to the ASI Facebook page to learn whatever they have lost. We have included common procedures, mainly open, basic minimal access surgery procedures, and endoscopy will also be covered. As pandemic comes to a decline, we hope and pray that the Ministry of Health and Family Welfare relaxes now the norms of routine operations soon, and we will be able to teach PGs on hands-on work. Having mentioned precedents 2019 and 20, I will not shy away from giving the credit where it is due. Ideas may be many, but implementation is necessary. Dr. Santosh John Abraham, as the Director Academics, is here. And my salutations to him for decorating the academics of ASI even further this year. I thank you, Dr. Santosh. He is on the way to announce another academic bonanza for the PGs. As Dayanand Nuli says in the chat box, Santosh is ASI University Vice Chancellor, and I completely agree with Dayanand on this aspect. It has been covered that Karnataka has the highest number of medical colleges and thereby academic staff. Please feel free to communicate with the HQ to further the cause of ASI. Please convey the academic activities to the HQ. It's time that KSC gets the best chapter award for so much of academic activity that is being done. Also on record, as recorded by me during all these conversations, that cities are doing so much work. You have instituted prizes or recognizing the cities. Let these cities be also recognized by the headquarters for being eligible for the best city chapter award of the ASI. Dr. Sopimat was mentioned as the driving force towards social security scheme. Yes, I salute him, and that's why Karnataka state has the highest number towards the social security. I wish, and on behalf of the executive committee of the Association of Surgeons of India, the conference of ASI Karnataka state chapter, all the success. Thank you. Long live ASI Karnataka state chapter, and long live ASI. Jai Hind. Thank you so much.
Thank you.
Thank you, sir, for addressing the gathering. And it's a pleasure to have you here as a chief guest for inaugural function of KC ASI. Now, I request the presiding officer and chairman of KC ASI, Dr. Sopimat, to address the gathering. Welcome, sir.
Thank you, Dr. Divakar. Respected Dr. Abhay Dalvi, President ASI, Vice President Dr. Siddesh, Dr. Sanjay Jain, Dr. Santosh Abram, we are privileged to have you today evening on this occasion. Respected seniors and my dear friends, well, when we took over in the February of last year, we had many dreams, we had many desires, we had many missions, but COVID disrupted when it started. So though we were disappointed, but we were waiting for an opportunity which didn't come to meet physically and carry on our activities. So we decided to go on virtual. We got up, we made plans, and we restarted, chalked out the whole year programs, and just got moving with it. In fact, I missed attending physical conference at Gulbarga, supposed to be my alma mater, which is my alma mater from where I did my postgraduate studies. And I missed attending this year conference there during my chairmanship. And of course, we did many activities. I think our state has done probably the maximum activities in the entire nation. And we are proud to say that we did all these activities with the support of all our EC members and all other faculties and all other members. And our distinguished orators, conveners, faculty, and other presenters, I'm sure they're going to add to our knowledge of our youngsters and postgraduates. And I thank all of them who have actively participated in this and are actively contributing to the scientific development of all youngsters and their skill development. And also I congratulate and thank for having accepted our all the senior surgeons. We wanted to felicitate them, and we honored ourselves and thank for accepting our honors. Well, my strength has been my team, as you have seen. We work like family. I made this comment in between also. We had disagreements, we had arguments, we had difference of opinion, but we all moved as a collective force. And the proof of that is conducting a mid-con and this annual state conference on our own without any supporters, without any sponsors. I cannot take individual names. I think enough number of times it has been already mentioned. Each and everyone has contributed to the success story of this KCASI this year. Dr. Divakar Gaddi, though he mentioned about everyone, I must mention about him. He is a very cool, meticulous worker. I always see him as smiling. and he has been of a great support. Many times he used to tell me, sir, you don't worry, sir, I'll handle this situation. So many times he acted as a buffer. Many times he made me to sit quiet. He carried on with the activities. Even today also, you must have observed that he was guiding me what I was supposed to do. He would just say, sir, you do this, you do that, like that. So he's been a great worker. And as you can see today also, he's single-handedly handling everything. And in fact, many of you may not be knowing that his home has been converted into KSCISI, this conference console. In the first floor, all of them are sitting, families in the ground floor. So, and few of our EC members are also there. So it's a teamwork which is led by him. So I must thank him for all this success along with our all other EC members and everybody. Of course, Treasurer Jasbal, he has been a very workhorse fellow with a lot of ideas, and Chairman-elect Dr. Arvind Patel, and he's also a cool worker with a balanced temperament, unlike me, and our national EC members. I remember that whenever there was a meeting at ASI, they were raising an issue that national EC members should get associated with the state EC members. That was never an issue with our state. They are always there in all the meetings. They are always part of our discussion. They always give suggestions and guidance. So they are part of our EC committee, and they are part of our meeting, and they have been always with us. And we must thank them. And our ex-officio, like Professor Vidyadhar, who said, I'll be there with you, and he has been there with me. And Dr. Hebsur, our ex-secretary. All these people have been contributing along with our other, say, team leaders of our respective committees. And many who have extended support are like Assembly of Strong Backbone. I can't take individual names because the list is quite huge. It will take a long time. Actually, my situation was like a traveler in a Mumbai train. The moment you enter into this in a rush Mumbai train, you get carried away. You can't move around. The crowd takes you. Which direction? So all my EC members, they just carried me in that direction. So I must really thank all of you for that. And it may appear like, vote of thanks my talk, but I have to do that because I won't get an opportunity to talk again like this. Well, apart from what Dr. Gaddi has mentioned, what happened this year different than what was this? There was a lot of transparency in the decision making, and all decisions, all EC committee members were openly expressing their opinion. No one was left. There were arguments, disagreements, everything was happening, but it was very open, and decisions were taken in a very democratic way. In fact, the topics also we took from the members, that what topic should be covered from postgraduates in the mid-con, in the Kscasicon, like that, say in the annual conference, like that, we took suggestions from them by way of Google Forms. In fact, faculties or talks also, what talk you would like to give? Would you like to be a faculty? You would like to be a speaker? Would you like to be a judge? Would you like to be a chairing person? So all these persons who are there in the scientific people, deliberation today, either in one or the capacity as either a chairman or a judge or a speaker, they all volunteered. And also, other thing what I have done is we are trying to promote youngsters. I think it is time that we must push our youngsters. So we are trying to pull them up. So as you can see, many youngsters have surfaced in this conference, and we are literally pushing them to go into the front line in this all scientific deliberations, and they're taking active part, and we are very happy about that. And rural surgery, of course, in this year, because the rural surgeons wanted some topics to be covered which are of interesting to them, delivered by them, we gave them a free hand. You choose the topics, you choose your specter in your section, and you conduct that session. And they did that. And discipline was the hallmark of this year. The cutoff of abstract submission was very strict. It was web-based, and no one could submit any abstract next day. In fact, it displeased many, and the system was so robust and transparent. In fact, none of us could do anything. We received many calls. In fact, I made a comment that I have been rendered powerless by the powerful system what we created. So that's why no one could alter what was happening. So everything was so systematized. You can see that even today, everything is going on in time. Everything is so meticulously planned, and discipline is the hallmark of this year KSCISI activities. And my appeal to ASI leaders for all year, I, of course, have written, and Dr. President of ASI, Dr. Dalvi also conveyed that endoscopy in MS curriculum should come back, which is missing in the new curriculum, which was there in the old MCI curriculum. It has been taken away in the new curriculum. All efforts must be made to bring this back. Otherwise, the surgeons are going to lose endoscopy forever as a tool. And also I request that you must, the ASI should take initiation in defining a rural surgeons. Who are actually rural surgeons now? Or should we call them limited resource surgeons? And how do you protect them, or how do you enable them to do emergency procedure to save lives fearlessly? So let there be some guidelines. So we need to do that. So these are all my appeals to the leaders of the ASI, and my appeal to our own colleagues that we must promote maximum numbers of our members to join ASI as members and take up active part in scientific deliberation whenever chance is available to us. I think all youngsters should take a lot of interest and participate immensely. And I wish many youngsters will become national faculty more and more. That is my interest. And third thing is promote ASI in each, this ASI SSS, which is one of the best scheme, I can say, that I think all our members should take advantage. If you look at so many people have been benefited this year, and it was unimaginable how much they have been benefited, which they didn't expect. It's sad that we lost some of them, but it has been very prompt in rewarding all those members. So it's one of the best schemes that is available. I think we must promote this, and we must insist that everyone becomes member of this ASI SSS. With all this, once again, I must sincerely thank all my members without taking any individual, because all have contributed immensely, along with our office bearers, ex officio, national list members. I cannot take individual names, and they have been of immense support because of them that we could do all these activities. And thank you all. My sincere thanks to all the national leaders who made it possible today. We are highly privileged to have you, and we are happy listening to you. And once again, thanks to one and all. Enjoy. Divakar, I'm ending my talk here. You can carry on forward from this. Thanks to you all.
Thank you, sir. I request Dr. Jaspal Singh Tehalia, Honorary Treasurer KCSI, to propose vote of thanks to this gathering. Dr.
Thank you,
Jaspal,
Diwakar, sir. Thank you very much. Good evening, respected ladies and gentlemen. As we come to the near end of today's inaugural ceremony of the 39th Kscasicon, I request you all to kindly allow me to indulge for a few more minutes patiently and allow me to propose the vote of thanks. I start with our National President ASI, our chief guest for today's evening, Dr. Abhay Dalvi sir, who has been a constant source of aspiration to all our activities. Thank you very, very much, sir. Next, I would like to thank our guest of honor, the very own son of our soil, Dr. G. Siddesh sir, Vice President ASI, who has been a source of driving force always. Thank you very much, sir. Next, I would like to thank Dr. Sanjay Jain sir, Honorary Secretary ASI, for being here today. He is our guest of honor for today's evening. Thank you very much, sir. Next, I would like to thank Dr. Santosh John sir, Director Academics ASI, our guest of honor for today's evening. Thank you very much, sir. Next, I would like to thank the presiding officer for today's evening, Dr. Sopimat sir, Chairman KCSI, the constant pillar to all our efforts and the driving force. Thank you very much, sir. Next, I would like to thank Dr. Arvind Patel, sir, the Chairman-elect KCSI, for all the support. Then I would like to thank Dr. K. Lakshman, sir, Chairman Scientific Committee, for always being there with all the helpful and kind tips. Thank you very much, Lakshman, sir. Next, I would like to thank our past chairmen, Dr. Vidyadhar Kinnal, sir, Dr. Dayanand Nuli, sir, and past Secretary Honorary Dr. Narayan Hepsu, sir. Last but not the least, I would like to thank the national GC members who have been always there as a constant help and always been there to help with all their ideas and guidance. Thank you very much, sir. And the state EC members who are always a pillar to the state EC in their functioning. Thank you very much, all the members. I also would like to make a mention about the scientific committee members whom might have missed. Dr. Ramkrishna sir, Dr. Naz ma'am, Dr. Aruna Rao ma'am, and the screen managers who I would like to make a mention specifically, Dr. Hosni Khan, Dr. Sangvi, and all their screen managing team who have done an excellent job for today's virtual KSCSCon. Thank you very much, all of you, sir. Next, I would like to thank all the orators and the delegates who have been attending the function, the conference from the very morning today and making it a very colorful and a very enthusiastic event. Thank you, all the delegates and the orators who have been there all the time today, sir. Next, I would like to thank Mr. John and Mr. Anand from the Keystone, who have been our web managers and the managers for virtual Kscasicon. Next, I thank all the members whom I might have forgotten and all the people who have worked for the success of today's event. Thank you, one and all. This is Dr. Jaspal Singh, Honorary Treasurer, KCSI, signing off for today, sir. Thank you very much.
Thanks all. Thank you.
Thank you, Dr. Jaspal, for proposing those vote of thanks. From KCSI, I also sincerely thank our faculty and chairperson for conducting today's scientific session. And I also thank all the faculty for tomorrow's and day after tomorrow's session. Before I sign off with the national anthem, I would like to remind all the members that tomorrow we have 3 screens. Session 1 or in session in all the 3 screens will start at 2 p.m. and all the links have been shared. And the links are also there on the kcasi.com website. You can log in through the website also. Now I request all the members to stand up for national anthem, please.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Jai Hind.
Jai Hind.
Ladies and gentlemen, I thank you all for your presence here. Kindly enjoy this conference. Have a wonderful time. Thank you. Good night. Long live ASI. Long live KCSI. I thank all the members for attending today's function. Thank you very much.
Thanks all. Thank you.
Thank you very much all. Long live ASI.
Yes, sir. With the permission of chairman, I'll end the meeting for today.
Yeah, please.
Thank you, sir. Thank you, sir. Good night, everyone.
Good night. Good night, everybody.
Good night.
Great job, Goody. Great
Thanks,
job.
sir. Thanks, sir. Thanks, sir.
Good night, Sophie. Good night.
Good night.
Good night,
Good night.
Sophie.
Thank you. Thank you. Thank you. Thank you.
Sophie, the wonderful job. Divakar, wonderful job.
Thank you, sir.
Thank you.
Thank you, sir.
Keep it up.
Thank you. Thanks a lot. Thank you. Thank you.
Well done,
Thank you,
Sopimat. Appreciate
you,
your
sir.
work. And Dr. Gaddi, superb steering of the mic and the timing. It was really a pleasure to be part of this. Really.
Thank you, sir.
Thank you, sir. Our pleasure. You are with us, sir.
Congrats and well done, Dr. Sopimat. Dr.
Thank you.
Good night. Good night,
Thank you,
everybody.
sir. Thank you,
Night,
sir.
sir.
Thank you.
I'm shifting to Karnataka.
Oh, come. Anyway, you are coming
Welcome,
nearer
sir.
now next week, so you can come in a little more nearer.
Thank you and good night.
Give me
all.
practice.
Good night.
Yeah.
Good night.
Thank you.
Good night, Abhay.
Come.
Bye.
No problem.
Good night, sir.
all.
Good night.
all.
Thank you
Good night.
and good night all.
Bye.
Bye.
I'll end, sir.
Yeah, please.
Okay. Good night, everyone.